Ankur Institute of Child Health, and he was the HOD of GCS Medical College. Emni Kirti beyond India jai છે. He is also the president of Pediatric Association of SARC in 2005 to 2008. If we look at his publications and awards, it will be endless. Nonetheless, published more than 100 articles in journals and books. Welcome, sir.
Good morning, friends. It's indeed a great pleasure delivering the first talk on this extravaganza GUJPEDICON at Surat. We all know the hospitality of Surat friends, and since yesterday, we are enjoying that hospitality. Thank you so much for inviting me to be one of the guest faculty for this very important conference. Well, friends, we all know last 3 months or so, we had outbreaks of various viral diseases, started from the vector-borne disease like dengue, chikungunya, and few cases of malaria, and then respiratory illnesses. We all know that respiratory illnesses are the commonest cause of outdoor practice as well as indoor practice, especially in pediatric segment. And probably it is around the year that we get different type of illnesses. So today I'll be talking about the commonest viral illnesses, how do we diagnose them, and how do we manage them. Well, in the past, when we did not have many vaccines, that time, whenever there were infections, we were thinking of bacterial illnesses. But now, with the availability of different vaccines, the scenario has changed. And world over, you know, the protocols have also changed. In Western world, which is a evidence-based medicine, whenever there was a case of PUO with some viral illness, they were thinking that probably it is a streptococcal infection or pneumococcal infection, and they had advised that especially in children less than 3 years to start with the penicillin or penicillin-related antibiotics. But now things have changed. Everywhere now thinking that probably as the viruses have taken care of all these different type of bacterial illnesses, so commonest is the viral, and that is why protocols have changed, and they have advised that one should give symptomatic treatment, try to find out the cause, and then only think of treating the bacterial illness. Let's see a few cases. The first one, a 6-year-old male child. These are all the real cases which I saw in last 3 months or so in my practice. The child had come with fever, high grade with chills for 5 days, cold and cough for 5 days, treated at other place with antibiotics, IV fluids. There was no improvement, and so brought to our hospital. When child was brought to us, temperature was 103, respiratory rate was 33, conjunctiva was red, there was presence of rhinitis, throat was congested, and respiratory system shows bilateral few crepes and bronchi both. Liver was 2 centimeter, spleen was not palpable. With this, we investigated, and the initial investigations, hemoglobin count, etc., was showing that probably it's not a bacterial one, though child was treated with antibiotics. And we thought that probably it is some kind of a respiratory viral illness, and we sent throat swab for the PCR. And this came Influenza B virus, which was present there, and child responded to the antiviral treatment, and child was all right. The next case, a 2-month-old child had fever, excessive crying, cough, difficulty in feeding. Child was transferred from other hospital as there was no improvement. Again, child had fever, respiratory rate was 48, heart rate 124. Antifrontally were open but at level. Child was irritable and cranky. There was no pallor. Respiratory system did not show any findings, no crepes or rhonchi. It was a silent chest. The Abdomen was distended, liver was 3 centimeters, spleen was just palpable. It was tympanic, but peristalsis was present and other systems were normal. Again, if you look at the investigations, the count was 3,550, please polymorphs were 64, platelets were 1.2 lakh. X-ray chest was little hyperinflation, rest was normal. So again, we thought that this is some kind of a viral illness, and we sent throat swab to look at the viruses, and where as the season there were some cases of influenza also, so we asked for both, and this child had Rsv infection. So again, second case was of viral illness, Rsv virus. Third case, 8-year-old male child was transferred from other hospital. He had fever for 5 days, cough for 5 days, not able to stand since last 3 days, and there was a decreased oral intake. There was a oliguria, temperature was 100, rhinitis was there, mild, throat was clear, tenderness of both the thigh as well as calf muscles. CNS was more or less normal, little decreased tone in power in both the upper and lower limb. But child was not able to stand on his own, and other systems were normal. The primary investigations again were more suggesting on the lower side of total count with low polymorphs. Platelets were also low, so it was again season of the vector-borne disease, so we sent for NS1, which was negative, but CPK total was 1200. Chikungunya thought of, but it was also negative. And then we thought that look for the other viruses in the throat, and this came as influenza type A, H3N2 was positive. So again, this was one kind of respiratory virus illness, which has brought this child with a CNS type of symptoms also, along with very few symptoms of respiratory system. Another case, a 5-year-old male, a female child, had fever for 5 days, cough, dry, brassy, paroxysmal cough. There was a post-tussive vomiting also. Temperature was normal, respiratory rate 32, heart rate was 100, the SpO2 was normal. There were no other big positive findings. There were no Krebs or bronchi, and other systems were normal. Again here, the investigations were more suggestive of viral illness and was not contributing. We again sent for throat swab. COVID, we thought first, and we sent for COVID, which was negative. But again, this child had Rsv positive. So even the child at age of 7 years had Rsv virus, which was positive and causing the disease. Another case, a 4-year-old male child had fever mild to moderate since almost 40 days. And daily child was getting 2 to 3 peaks. History of cold cough in first 7 days of illness. No history of vomiting, pain in abdomen, body ache or joint pain. Temperature was 100, throat congested. Bilateral cervical glands were present. Biggest was 1.5 by 1 centimeter. Liver was just palpable, spleen 2 centimeters. So this was the condition, and child was getting fever almost for 40 days. The primary lab investigations, hemoglobin was 10.7, total count 8,120. Lymphocytes were 68, platelets were 2.28. SGPT was 482, SGOT was 356, alkaline phosphatase 136. Vidal was negative, Brucella were negative. The cultures in the past sent twice were also negative. COVID antibodies, we thought that probably child is maybe having MISC, but COVID antibodies were also just borderline positive or equivocal. So then we thought that this is probably infectious mononucleus, and EBV capsid VCA was sent, which was more than 160. So this was a EBV virus infection leading to the prolonged fever with the lymphadenitis, plus there was a hepatosplenomegaly. So friends, we all know that in the past acute lower respiratory infections, we thought we all know that they can be bacterial as well as viral infections. The acute viral bronchiolitis and bacterial and viral bronchitis were remaining the leading cause of global child mortality for many years, especially in third world country. And with the newer steps that has been taken by governments all over world, the bacterial pneumonia has gone down considerably, and because of that, there is a now increased use of vaccines which has targeted these certain diseases, especially bacterial respiratory pathogens, and that has reduced. So now, world over, the leading cause of all acute lower respiratory infections are most of the places it is viral infections with Rsv virus, influenza virus, parainfluenza virus, rhinovirus, and human metapneumovirus are the top viral conditions in children, and that leading to the different type of clinical presentation. So if you look at the commonest viruses that can cause viral illnesses nowadays, at present, because of pandemic, COVID-19 may be the heading the list, but I am not going to talk about COVID-19 now today. I will be talking about the other viral infections, and other are the rhinovirus, coronavirus, common coronavirus, I mean, influenza, Rsv, parainfluenza, adenovirus, Ebv virus, human metapneumovirus, and human Boca virus. Out of that, rhinovirus, influenza, Rsv, parainfluenza, and adeno, they are the commonest that can lead to different type of clinical presentation. The common cold is the commonest type of acute viral URI that we see day in and out, and about 50% of all colds are caused by one of the more than 100 serotypes of the rhinoviruses. The common coronaviruses, which are almost 4 different types, they can cause some outbreaks. The infections caused by influenza viruses, parainfluenza viruses, enteroviruses, adenoviruses, and Rsv and metapneumoviruses can also cause the common cold-like symptoms only. And out of all the common cold viruses, in different studies, it has been found that in spite of the investigations by PCR as well as culture, 20% of the common cold is still by unrecognized viruses only. Out of all that we see, rhinovirus is probably commonest for causing the cold. And this occurs in certain seasons, fall and spring. They are most efficiently sprayed by direct person-to-person contact, although sprayed may also occur via large particle aerosols. The most potent deterrent to infection is the presence of specific neutralizing antibodies in the serum induced by the previous exposure. And susceptible, as there are many myths about the cold, that the children can be susceptible because by exposure to cold temperature, host health and nutrition, or upper respiratory anomalies, but these are the myths and not the true. It is the exposure to the virus which leads to the common cold rather than the exposure to cold or any other food or other related things. The common coronavirus, excepting the COVID corona, are 4 types which can lead to again different types of rhinitis and URI. These include types 229E, NL63, OC43, and HKU1. There are outbreaks of this type of virus causing the upper respiratory infection. They are usually mild to moderate URI and is the cause of about 20% of colds are because of this type of outbreaks. This is different than the coronavirus 2019, and it should not be confused with that virus. So even by the PCR of COVID-19, these viruses are not detected, so they are totally different viruses. Another common virus that can infect the human being is the influenza, and we all know that there are 2 types, type A and type B. Type A has many different combinations of H and A, and there is antigenic drift in H and NA antigen produces strains that cause a pandemic with significant mortality. It can cause fever, coryza, cough, headache, and malaise. And influenza itself may cause pneumonia, or patients with influenza may develop secondary bacterial pneumonia. So that is how there may be different issues with this. What happened to this slide? more we technically advance, there are more glitches and problems. So we have to have our foot down to the earth so as we don't face this type of. And influenza can be diagnosed by the now RT-PCR which are available, the reverse transcriptase PCR, which are sensitive and specific and can differentiate influenza types and subtypes. They can be also diagnosed by antigen test also, but the sensitivity is less. Most of the patients are treated symptomatically, hardly any need of antiviral drugs. The drugs which are used for as antiviral, commonest is oseltamivir, but in some cases in Western world they may use zanamivir and peramivir. Recently a new drug has been launched in the Western world, which is a baloxavir, which has more efficacy and require short course of the antiviral drug. The antiviral drug is recommended only for high-risk patients or the patients which are hospitalized for some kind of the complication that a child develops. This recommendation is based on data suggesting that early treatment may prevent complications in these type of patients which are immunocompromised or those who are high-risk patients. The Rsv infection is the next commonest infection that we see. Most of the children by 2 years of age can get infected by Rsv infections, and children can affect even adults once they get the infections. Usually there is an annual outbreak in all age groups. Most healthy children and older children who get Rsv will get a mild case with cold-like symptoms only, but some of the children who are younger than 1 year, especially younger than 6 months, can get a severe disease, and that can lead to commonest is the bronchiolitis, or sometimes we call it pneumonia also. It could be dangerous for some infants and young children, especially those who are born premature and who had some respiratory problems when they are born. They can have a very severe disease and can lead to a severe infection. Commonly used type of Rsv clinical laboratory test for the diagnosis is the now RT-PCR, which is more sensitive than culture and antigen testing. In some situation, antigen testing can be used, which is sensitive in children but not sensitive in adults. So in younger child, even antigen testing can also help. There are no specific antiviral drugs which are used in most of the world, except in USA. They are using palivizumab, especially in a very young, high-risk infants like those who are born very small as a premature child, and there this drug is used, and there is a good result from within these conditions. The Parap influenza virus is another virus that can cause the disease. There are 4 types of parainfluenza viruses, 1, 2, 3, and 4. They share antigenic cross-reactivity. The common illness in children is URI again. Parainfluenza type 1 is a frequent cause of croup, and so any child coming with croup, 99% they will have parainfluenza virus. Parainfluenza type 2 also can cause similarly croup, but it is a less severe. Parainfluenza 3 can cause pneumonia and bronchiolitis, and parainfluenza 4 has a mild illness. A specific viral diagnosis is clinically unnecessary, and it may help distinguishing parainfluenza virus from a bacterial infection in some situations. Again, the treatment is a symptomatic treatment. No specific antiviral drug is available or needs to be given. The another virus which can lead to respiratory illness is adenovirus infection. The adenoviruses are classified according to 3 major capsid antigens like hexon, penton, and fiber. There are 7 human adenovirus species starting from A to G, and because of that there are 57 different type of serotypes of adenoviruses which can cause infections. The different serotypes are associated with different conditions. They are commonly acquired by contact with secretions from infected person or by contact with a contaminated object. Infection may be airborne or waterborne, and asymptomatic respiratory or GI infections which continues shedding the viruses, and because of that they can infect the other children or persons. In immunocompetent host, most adenovirus infections are asymptomatic and they are not recognized and they just pass, but they shed viruses and that can infect the other people. It can cause fever and URI-like symptoms, including pharyngitis, otitis media, cough. The picture may be like exudative tonsillitis with cervical adenopathy in many situations. And here we need to distinguish it from group A streptococcal pharyngitis. In the Western world, they differentiate it by the RDA, which is available there. Adenovirus type 3 and 7 can cause distinct syndrome of conjunctivitis, pharyngitis, and fever, which is known as pharyngoconjunctival fever. Rare adenoviral syndrome in infants includes severe bronchiolitis and pneumonia. Recently, Dr. Parap Chatterjee from Kolkata had published a series of cases where different types of lower aspect infections were caused by adenoviruses. That is probably the biggest series that is published from India about the adenovirus infections. In close populations of young adults, it can cause outbreaks of respiratory symptoms like fever and URI. It could be either tracheobronchitis or occasionally pneumonia. The epidemic keratoconjunctivitis is sometimes severe and occurs sporadically, and it can damage the sclera and conjunctiva, cornea also. Non-respiratory adenoviral symptoms include hemorrhagic cystitis, diarrhea, and meningoencephalitis. Most patients recover fully. Even severe primary adenovirus pneumonia is non-fatal, excepting very rare fulminant cases. PCR testing can detect adenovirus and is useful when patients have a severe disease and diagnosis is needed, especially if the child is in ICU and child has some other immunocompromised situation. Treatment is supportive. There is no specific viruses which are antiviral treatment available. Another virus which can cause disease is the Ebv virus. It is a human herpes virus 4, which is a gamma herpes virus. The primary infection is causing acute infectious mononucleus, which is characterized by fever, lymphadenopathy, hepatosplenomegaly, malaise, and abdominal discomfort. It is the first human virus confirmed to be oncovirus, and it can give rise to various lymphoproliferative malignancies, and some types of lymphoma can be caused by EBV. Again, there is no specific treatment available. The diagnosis is simply by total WC count, where you look at heterophile type of specific lymphocytes, and heterophile antibody test can be done, which can help. Normally in PS, if more than 20% atypical lymphocytes or more than 50% lymphocytes with at least 10% atypical lymphocytes, you can suspect the infectious mononucleosis. A positive result of antibody test is also strong evidence, and confirmatory testing can be done by capsid antigen VCA IgM, as in our case we did it, which was very high. The antibody response is like that. So if you are testing for the IgM VCA, in first 5 days probably it can come negative. So normally, if you are suspecting infectious mononucleosis, start testing after about 7 days or so, then there is a high chance that this will be positive and you can get the diagnosis. So friends, the diagnosis of viral respiratory infections is typically clinical evaluation and local epidemiology. We need specific tests in a very, very few situations and only in a complicated cases. The diagnostic testing is reserved for situations in which knowing the specific pathogen which can affect the clinical management. Or if you want to epidemiologically know what are the outbreaks due to, then for that type of epidemiological surveillance, you may ask for the specific diagnostic test. Otherwise, in most of the situation, it is a clinical condition and the situations can help you. The tests which are normally available and which can help in making the diagnosis, they are rapid antigen test, direct fluorescent antibody test, viral cultures, PCR, which can be standalone, as well as multiplex PCR. The rapid point of care antigen-based diagnostic tests, they are readily available, but they are not that sensitive. That is why they are not routinely used. Direct immunofluorescence assays are rapid and inexpensive method. They are recommended for infants and children due to high sensitivity of these tests. But commonest tests which are done are the PCR tests. Cell culture or serological tests are slower than PCR tests, but may be useful for epidemiological surveillance. The cultures, they are observing the cytopathic effect, and that is how one can find. It is considered to be a gold standard. But the viruses like Adenovirus Influenza, Rsv Influenza are most common that are isolated and detected by cell culture. Now, modified cell culture methods which are used has reduced the turnaround time from 5 to 10 days to 24 hours. But despite these advantages, many clinical relevant viruses are difficult to grow in culture and may produce variable regions, and that is why viral culture is not still a commonly used method.
Sir, 1 minute remaining.
Used. There are wide variety of newer nucleic acid amplification tests which are available, and these are very important. And nowadays they are considered to be a second gold standard for the diagnosis of the viruses. Single individual pathogen is suspected, then monoplex real-time PCR or combo PCR can be used. While these are different types of nets which are now done, there are large syndromic panels available now in the some of the tests, some of the labs, and which are very important. And studies have reported increased diagnostic yield more than 60%, and sensitivity is almost close to 80 to 100% with this type of the test. The one panel which is available commercially is the BioFire Respiratory Panel 2.1. It is a PCR-based multiplex nucleic acid test intended for use with BioFire field array or BioFire field array torch system. It allows healthcare providers to quickly identify common respiratory pathogens. Panel yields results in approximately 45 minutes using the narrow swabs. And these are the different viruses which can be identified. Another panel which is available is the Pneumonia Plus panel. Again, that is based on BioFire field array. 15 of the bacteria panel provides semi-quantitative results which may help determine whether an organism is a colonizer or a pathogen. Is more sensitive than culture. Difficult to grow organisms in culture can also be identified with this type of studies. The panel identified a bacteria in additional 22% of BAL or sputum specimens, and that helps you in identifying the organisms. Samples that we required for this type of test are BAL or sputum, and in performance, if you look, in the BAL, the sensitivity is 96.2 and specificity 98. Sputum 96.3 and specificity 97.2. These are the organisms which can be detected from these panels, and this is another group of bacteria which can be identified. Even the antimicrobial resistant type of the enzymes which can be also detected by this type of Pneumonia Plus panel. So friends, to summarize, majority acute viral infections in pediatric age group are viral in nature. In most situations, clinical evaluation and local epidemiology gives the diagnosis. You don't need a very specific diagnostic test. It should be typically reserved for situation in which knowing the specific pathogen can affect the clinical management. Monoplex PCR can help in diagnosis in majority situations. Multiplex PCR like BioFire is helpful in intensive care setting and immunocompromised situations. And low resource setups and third world countries, cost is the prohibitive factor, so as there is a biggest limitation of this test. Otherwise, they are very useful tests. Thank you so much, friends. If there is any question, it will be my pleasure to answer them.
Thank you, sir, for this wonderful session. I would now like to invite Dr. Rakesh Desai, sir, to felicitate Dr. Raju.
We shall be taking questions at the end of the session.
Moving to the next session, I would like to invite Dr. Nirmal Chorodia, sir, to present the topic of approach to upper airway emergencies. Dr. Nirmal Chorodia is the head of the department Nirmal Hospital and the director of the PICU. I welcome you, sir.
There is a small announcement. We are having a wonderful lecture over here. If anyone is interested, there is paper presentation going on at 6th floor cluster hall.
लाइट है
स्लाइड चेंज यहाँ से कर सकते हैं इधर से
एक बार कर दो स्लाइड चेंज ओके
Good morning, everyone. First of all, I would like to thank Academy of Pediatrics Gujarat and organizer of this conference PACT for giving me the opportunity to present my talk, Approach to Upper Airway Emergencies. As we all know, and Dr. Rajubai also told, that respiratory infections are the most common infections in children. And out of those infections, the emergency which we encounter in the emergency room are most common respiratory emergencies. If we diagnose them in time, manage them properly, we could save most of the children and can reduce our morbidity and mortality. Why the slide is not projected? निर्मल चौराड़ी Okay. I'm sorry for the inconvenience. So as I told, the respiratory emergencies are the most common emergencies in children, and if we can diagnose them in time and proper treatment is initiated, the most of the children can be saved. We all know that if a child comes with the respiratory emergencies in our emergency room, child may present at different stages. Child may be having respiratory distress. If not treated in time, child may lend to respiratory failure or shock. It may lead to cardiorespiratory arrest, secondly to cardiorespiratory failure. And pediatric cardiorespiratory arrest are 80% due to respiratory emergencies in children. Therefore, a timely workup, proper management is very, very essential. Now, coming to the approach to a child with upper airway obstruction. Why upper airway obstruction is more common in children than adults? The reason being the anatomy of the airway of the child. It different from the adult. We know the children have got the large tongue. Epiglottis is floppier, U-shaped in child. It is shorter in adult. The vocal cords are upward strained, while in adult it is horizontal. Larynx is more anteriorly placed, and trachea cricoid is the narrowest part of the airway, upper airway, and the trachea is narrower and less rigid in child. And their lung capacity is also less, so if they develop air problem or airway problem, it can lead to the hypoxia, and that can be a very ominous sign. So the child can present with pertinent sign of stridor, inspiratory usually, most of the cases that is instated, it may be expiratory associated with inspiratory also. Child can be anxious and agitated, secondary to hypoxia. There can be increased work of breathing in terms of suprasternal, sternal, intercostal and subcostal retractions. Child may develop hypoxemia if not attended properly and treated in time, and hypoxemia is the late sign of upper airway obstruction. Diminished respiratory efforts, drowsiness, decreased stridor with decreased air entry are the ominous sign. That means the child is going into impending respiratory failure. So a stridor which is very low in sound and noise may not be a good sign. It may be a bad sign. It may be a late stage disease. So type of upper obstruction is divided in two types, mainly partial or complete. It may be a partial obstruction or it may be a complete obstruction, and depending upon the site, it can be supraglottic, glottic and infraglottic variety. In supraglottic varieties, the commonest causes are anaphylaxis, epiglottitis, retropharyngeal peritonsillar abscess, laryngomalacia, congenital malformations, tumor of oral cavity and pharynx. And glottic and infraglottic variety are laryngotracheobronchitis, which is the most common cause of upper airway obstruction, then tracheomalacia, anaphylaxis, foreign body in the airway, subglottic stenosis, bacterial tracheitis and vocal cord palsy. So depending upon the anatomical site of the obstruction, we can come to which can be the diagnosis, what can be the diagnosis. They have a specific clinical presentation. If it is a supraglottic obstruction, it can be a muffled cry and voice, soft inspiratory stridor, drooling, dysphagia, dysphonia and dyspnea. These are the signs of upper airway supraglottic obstruction. If it is a glottic obstruction, then it can be present with a weak or hoarse voice, high-pitched inspiratory stridor. And if it is an infraglottic obstruction, then the voice may be normal, but there will be brassy cough, biphagic stridor, and maybe mild wheeze also. So the causes of stridor in upper airway obstruction, as we have seen by anatomical site wise, but which are the most common and uncommon types are, the commonest are the viral laryngotracheobronchitis, which we say group. Superimposed infection on laryngomalacia or subglottic stenosis can also be a common cause. Uncommon causes are epiglottitis, bacterial tracheitis, laryngeal foreign body, inhalation injuries due to burns or chemicals, anaphylaxis, severe bilateral tonsillar enlargement. And rare are the angioinative edema, diphtheria. Though we are not seeing much of the cases, still from the rural areas we are seeing cases of diphtheria and retropharyngeal abscess. What are the danger signs and pointers to the cause? Sudden or rapid onset, it is foreign body, epiglottitis, tracheitis and anaphylaxis. Soft or low-pitched stridor, epiglottitis and tracheitis. Toxic appearance with high fever, epiglottitis, tracheitis and retropharyngeal abscess. And drooling, open mouth, sitting forward, that is epiglottitis, retropharyngeal abscess, severe tonsillar obstruction. So depending upon the presentation, we can also come to a differential diagnosis, what can be the most common cause. Now coming to an approach to a child with cough and stridor, we can differentiate if there are 4 signs present, like alert, no chest retraction, SpO2 more than 92% at room air, and no cyanosis. If all 4 are present, means child is alert, there are no retraction, means increased work of breathing, child is maintaining the oxygen saturation more than 92%, and there is no cyanosis, then we have to look for if the child has got fever or toxic looking child. So if there is a fever, then it can be epiglottitis or bacterial tracheitis. Now these all 4 are in the early presentation. This all can deteriorate and can present. So I will come to that also. But that means that this child is maintaining the oxygen saturation in the emergency room. So if we can approach the case in the right time and treat them well, we can avoid the complications. So if there is a fever, then it's epiglottitis and bacterial tracheitis. So oxygen if the child is hypoxic, antibiotics to be started. If intubation, ideally in operation theatre, use inhalational anesthesia, and ENT and the expert has to be there in the standby. And if you intubate the child, take the culture, tracheal aspirate culture and send the ball also for the culture. Now, if there is no fever, then it can be croup, or it can be a mild fever for first 2 to 3 days, as we know. In acute laryngotracheobronchitis, upper respiratory infection, there can be mild fever for first 2 to 3 days, and then child can present with a stuttor. And there can be croup, or it can be foreign body, or it can be allergic. So, if there is a previous history of allergy or the similar attacks, then it's most commonly it is the allergic. And the treatment is epinephrine, intramuscular, if it is an allergic attack, and steroids. And if there is no previous history of attacks, then history of choking or aspiration. If it is a choking history, then it's a foreign body. And if there is no choking history, then most likely it can be a croup. And if we suspect foreign body, then bronchoscopy you must do immediately. And we can also go for the radio imaging to have a diagnosis if it is a stable child. In an unstable child, don't rush for the radio imaging or any investigation. If the child is hypoxic, just give oxygen, take the child to operation theatre and plan for bronchoscopic examination. Sorry. But if the child is not having all these 4 signs which are not ominous, means child is not alert, child is having work of breathing increase, child is having hypoxia, saturation less than 92%, or child has got Asian grey skin color or cyanosis, that means this child is in impending complete obstruction and child needs immediate attention. So intubation in operation theatre, as I said, endotracheal tube should be one size smaller than the normal recommended. Inhalation anesthesia drug is the recommended, and these children should not be given muscle relaxant for intubation because that will be very risky. If you give the muscle relaxant, you can't intubate, then we may lose the child. And experts should be there to intubate, maybe senior anesthetist or pediatric intensivist or an ENT surgeon or a pediatric surgeon to be standby. So if the successful intubation is there, and if this intubation is not successful, then we have to deal like a complicated or a difficult airway management. I will come forward with my next slides. So once you intubate the child, then we have to see if there are signs of inflammation on the posterior pharyngeal wall, bulge, or a foreign body or secretions. And if there are inflammatory signs, then it is epiglottitis and bacterial tracheitis, or a foreign body can be there. Remove the foreign body, send the secretions for the culture, and once we get the report, treat accordingly. And if there is no inflammation sign, it can be a croup, lower airway foreign body, and as I said, remove the foreign body by bronchoscopy, and then we can go for the further investigation also. Now, what are the indications of hospitalization? Signs of severe upper airway obstruction, somnolence, drooling dysphagia, no response to nebulized epinephrine. If you have given a nebulized epinephrine, 1 dose, and we can repeat every 20 minutes for 2 to 3 doses, and if there is no response, that means that the child may need hospitalization, child should be hospitalized. And persistent symptoms for more than 4 hours in spite of treatment becomes the indication for hospitalization. So indication for intubation, suspected epiglottitis, but as I said, in epiglottitis, if there is a severe hypoxia, yes, intubation is required, but it required intubation by the experts. So if we are not competent enough to intubate, it is better to give oxygen, deliver oxygen by other routes rather than going for intubation, because intubation can lead to sudden death of the child if we are not expert in that. Inhalational injuries, fall in conscious level, increasing respiratory failure, that is rising PCO2, exhaustion, hypoxia, saturation 92, less than 92%, despite high flow oxygen by mask more than 5 liters per minute. So as I said, intubation has to be done by an experienced person, preferably in the OT, use inhalation anesthesia, and no muscle relaxation in these cases to be given. There can be difficult intubation. If we cannot visualize the airway, then we have to use laryngeal mask airway, and needle cricothyrotomy or tracheostomy has to be done. So this is the normal visualization of the airway. If we can clearly visualize the airway, then and then we should attempt the intubation, otherwise call for the expert, take the child to the operation theatre. And this is abnormal pediatric airway. We can't see the vocal cords, we can't see the opening of the airway, and these kind of cases should not be taken for intubation in the emergency room. Better to shift the child in operation theatre. So laryngeal mask insertion, again, it's a very, very simple device. We all should practice once or twice how to introduce the laryngeal mask. It's a very, very simple technique. So whenever we find that there is a difficult airways and difficult intubation, we may try. But when you can't visualize and there's a lot of edema, even I think doing any kind of intervention can become risky for the patient. So it is better to provide the oxygen by the bag and mask slowly, or you can provide by mask with the high 10 liter per minute. And let this thing to be done by the experts. But LMA practice, I think for all emergencies, we all should learn because it's a very simple technique to introduce. Needle cricothyrotomy and then tracheostomy can be done in the emergency situation. So post-intubation management, properly fix the endotracheal tube, normal lung ventilation. In case of there can be post-obstructive pulmonary edema because of the sudden change in the pressure. If it is there, then apply PEEP for 6 to 8 hours, and usually it will resolve the pulmonary edema. Time of extubation, appearance of leak around endotracheal tube, and usually it takes 36 to 48 hours. So once we have ventilated the child, give sufficient time for the underlying pathology to return the normal, edema to be resolved, and once the leak starts, and I think that is the right time to extubate the child. If all the parameters are normal, then try extubation. Otherwise, don't try extubation very fast, even if the child is settled, because in most of the cases, once we put the tube, the children settle. So we feel the child is fine, parents also feel my child is okay, but please don't wean them fast. It will give sufficient time, at least 36 to 48 hours. So let us have some case scenarios. A 2-year-old child with 3 days of upper respiratory infection, now with fever, barky cough, and respiratory distress, mild respiratory distress. Woke up with barky cough and noisy breathing, fever for 3 days. Child presented alert, but it was irritable in moderate distress. Pulse was 160, heart respiratory 50, SpO2 96%, room air. Audible marked inspiratory stutter was there. It was a severe suprasternal retraction and air entry adequate. So the child was alert but irritable, and there was increased work of breathing. Child was maintaining the saturation by increased work of breathing because there is definitely a severe suprasternal retraction. So this child need to be attended immediately. So it's a case of croup. Viral infections of upper airway causing subglottic edema. Parainfluenza 1 and 2 virus are mostly common for croup. Usually in winter in younger children 3 months to 36 months. Barky cough and stridor with fever. So here with the lateral X-ray of the neck in cases of croup, we can see the narrowing of the upper airway, that is TP sign, and there is a hypopharynx is distended. So this is the case of acute laryngotracheobronchitis. In case 2, sick appearing 3-year-old child with 1 day history of fever, stridor, drooling, and respiratory distress. Fever 102, drooling, and will not lie down, noisy breathing, unimmunized child. Agitated, toxic appearing child, drooling in severe distress, heart rate 180, respiration 50, SpO2 89%, room temperature, air. Audible marked inspiratory stridor, severe retractions and stridor, unable to swallow secretions, a diminished breath sound. So this is a case of epiglottitis. We can't see the vocal cords and airway entry. So third case, a 12-month-old with sudden onset of respiratory distress with stridor, healthy child, mom heard sudden forceful coughing, turned blue and having moderate respiratory distress. Child was irritable, audible stridor was there, saturation was 86%, room air, severe retraction with minimal air entry. So this is a case of foreign body, sudden spasmodic cough. Child was otherwise playful and normal, and this always suspect foreign body. In this case is acute case of foreign body. So 1 in 1 lakh children can present with a foreign with sudden onset of respiratory symptom like choking, coughing, etc. And most common age is 1 to 3 years, and all kinds of foreign body we have seen in our emergency room. So this is a case of epi chest X-ray. Let us have some images. And there is a foreign body. Can someone tell where is the location of this foreign body? Where it is? It is in the trachea or esophagus? So it is in the esophagus. So in esophagus, in AP view, you see the round shape coin. If it is lateral, it will be just a slit. In trachea, it is just the opposite. So this is the tracheal foreign body. In the lateral view, you see the shape of the foreign body, and in the AP view, you will see like this. So this is how you can differentiate whether it is in the esophagus or the trachea. And a foreign body in the esophagus, if it is at the cricoid level or at bifurcation of the trachea, it can press upon the airway and can cause upper airway obstruction. So esophageal and foreign body can also lead to upper airway obstruction depending upon where it is lodged. And this is, as I say, TP sign in acute laryngotracheobronchitis. The upper part is narrowing, and this is a suggestive of acute laryngotracheobronchitis. So here it is thumb sign. It is the epiglottis. See, on one side of the picture you can see, sorry. So this is epiglottis. So this is swollen. When it is swollen, it gives this kind of a picture. See, this is a complete respiratory airway blockage. So this is the thumb sign. So I think this is again a very important sign to identify epiglottitis. So this is a retropharyngeal abscess, widening of the pharyngeal wall, and you can see this pharyngeal abscess. And this is a CT neck where there is a necrosis. Sorry. Lost. So there are only 2 slides. Okay. Fine. So this is a tonsillar area, and here we see the abscess. This is a peritonsillar abscess. This is CT contrast neck, and this is a peripheral enhancement of the contrast, and this is hello. So this is a peritonsillar abscess. So we can see the hypodense area here. This is abscess foramen. This is a enhancement, peripheral enhancement of the contrast, and this is a peritonsillar abscess. Similarly here, the same picture, we can see this. This is a abscess formation, and this is a peripheral enhancement of the contrast. Okay. So in summary, infections are the most common causes of upper airway obstruction. Early diagnosis and airway management is the most important. Most cases diagnosed clinically and management can be started. Investigation have limited role in early management but helps in reaching final diagnosis. Timely transfer to higher center after initial management is required. Team of experts for severe cases, and outcome is favorable if diagnosed and treated early and in time. Thank you very much.
Thank you very much, sir. It was a very, very practical lecture, and it comes out from someone who has worked in the intensive care very extensively. We'll take questions after 2 more lectures. So can I request Dinesh Patel sir to please felicitate Nirmal sir. I also request Nirmal sir to be seated in the hall. We will take questions later on. Can I now invite our next speaker, Dr. Ritesh Shah. He is a pediatric neurologist, one of the senior pediatric neurologists of entire South Gujarat. And he comes with a very, very difficult and a confusing topic. He'll make it simpler for us. Approach to a child with neuroregression.
મિનિમાઇઝ કરો ને ત્યારે પાછું મિનિમાઇઝ કરીને પાછું પ્રેઝન્ટેશન સ્ટાર્ટ કરો. So good morning, friends. Thank you, AOP Gujarat, and specifically thank you, Surat people, for considering the local person as a faculty for this difficult topic. I have 20 minutes. So 20 minutes, I don't know, it is a too less a time for this topic, but I will try to make it as simple as possible, because this is not a common thing which we see in our practice. As a pediatrician, we may be seeing 2 or 3 or 4 patients a year. So not day to day, you are seeing these neuroregression patients. Let's start. So aim of my talk would be give clinical approach to child with neuroregression and discuss pathognomic features of common neurodegenerative disorders. I will not bore you with any hi-fi and fancy names of various neurodegenerative disorders. We will not go in details of imaging, biochemistry, enzymes or genetics, and will not discuss management here. So it is purely a clinical approach, how to reach to a diagnosis, clinical diagnosis. So what is neurodegenerative disorder? So it is a group of disease. It is not a single entity like infectious disease. It's a whole lot of thousands of diseases, I can say, which are neurodegenerative disorders. So it is the two common things are the progressive loss of neuronal structure or function in different areas of central and peripheral nervous system. So there is some functional or structural loss, and which lead to loss of previously acquired motor, sensory or cognitive skills. So two things, some loss of structure which lead to loss of function. And the etiology could be genetic, viral, toxic, lots of etiologies are possible. So patient opedema will not come as a regressive disorder, it will come as a developmental issue. So usually in early infancy and late infancy and first 1 or 2 years, lots of time there is a confusion whether it is a delay or it is a regression. So you have to start your history from very basic. You have to start from your developmental history. So which we learn in our residency days. There are 4 domains of development. So you have to stick to those domains. You have to ask the milestones in all domains. Then only you can determine whether it is delay or it is a regression or something. So OPD में आवे patient at 1 year with my child is not walking, or 15 months my child is not walking. What will you do? So first you have to confirm the delay, because parental anxiety is not always, many times I know padosi know the neighbor child has started walking at 1 year and his child is not starting walking at 13 months. He will come, my child is not walking. You just examine, do everything, it is not delay, it is just a normal variation, you can wait for 2-3 months. So first you have to confirm the delay. Sometimes it is not always delay which parents complain. Second, you have to decide which domain there is a delay, whether it is a motor domain, language domain, or cognition and social domain, because these 3 domains are very important. And after you decide there is a delay in some domain or it is a globally delayed, then you decide whether it is a static or regression. So your regression patient will present as a developmental issue. So first these 3 questions you have to answer. If you directly jump to think about regression in all patients, many times you will be wrong. So this is a very basic thing but very important, because journey of patient will start from this history. So confirming the delay, deciding the domain, and deciding whether it is a static or regression. Then comes pseudo regression. So many a times CP patient, regular cerebral palsy patient, at 10 years he comes with complaint of, "Sahib, pehla chalto to now he stopped walking." So what do you think of regression in those patients? Patient is already having cerebral palsy, but he stopped walking at 11 years, which he used to walk at till 10 years. No, it is not regression. It is a increasing spasticity. As the age increases, the bone length will increase, your spasticity will increase. If patient is not doing proper physio, then he may regress. So increasing spasticity could be a cause of deterioration in CP patient. New onset movement disorder. So nowadays we see lots of autoimmune encephalitis, which comes with history of 1 or 2 or 3 months of lots of movement disorders, lots of dystonia, dyskinesias, drooling, all these things. So don't think of always directly jump to genetic neuroregression. Think of some other disorders. New onset seizures. There is a whole category called epileptic encephalopathy, where because of seizures, because of epileptic activity, patient shows signs of regression. So because of ongoing seizures inside, there is a language regression, there is a motor regression, there is a cognitive regression, which is treatable. You do EEG, if you find the seizures, you give the drugs, patient will be better. So they all look like regression. Progressive hydrocephalus, side effect of drugs. Suppose patient is on aptoin for last 7 years. He may develop cerebral atrophy and he may have some ataxia. or some psychiatric issues like in adolescent boys, depression or lots of other psychiatric issues, which also can look like regression. So before jumping to regression, rule out pseudo regression. And Siddharth would agree with me, he is here as a pediatric neurophysician. As a pediatric neurophysician, in our practice, we see more pseudo regression than real regressions. So the pseudo regressions these are the three commonest pseudo regressions. Autistic regression. Almost 30 to 40% of child with autism, they will present as a language regression. Initial up to 1.5 years, they have some 3, 4, 5 words, and then they stop speaking. It is not in real sense a neurodegenerative disorder. Epileptic regression, which we label as epileptic encephalopathies. Lots of epilepsy is now emerging that because of underlying EEG spikes, patient is regressing, not any underlying disease. So you treat the seizure properly, patient could be better. Or autoimmune encephalitis, which is in last 4 or 5 years, we are seeing lots of patients, they also look like regression. So before jumping to regression, rule out pseudo regression. Now coming to our real topic of the day, coming to developmental regression. So how do you start your approach? So any history, like we as a resident, we used to tell, 3-year-old boy from this village, presented with complaint of this. We start our history like this. So age is most important factor to decide your flow chart. Like is the era of AI, everything is algorithms. So for any approach, you should have some algorithm. So for regression, the first algorithm starts at the age. So onset of disorders before 2 years and onset of disorders after 2 years, they are totally different. Suppose somebody presents at 1.5 years with dystonia, I would not think of Wilson disease because Wilson will start at 7, 8, 9 years. If some patient with 1.5 years comes with slow myoclonus, I would not think of SSP because SSP will come at 7, 8, 9 years. So disorders come at certain ages. So first most important thing to decide about your further plan of action is age. Don't read this chart. This chart is just symbolic. So in our textbooks, the classification of neurodegenerative disorders are according to age. Disorders starting before 2 years, disorders starting after 2 years. So this is the first differential diagnosis. So this is some 38 disorders which are listed in this book. And in each disorder, they have some 10 to 15 variants. Suppose one of these 38 disorder is Leigh disease. Leigh disease can be caused by n number of genes. So lots of clinical variation. So the number is I am just telling you, and this is the disorder, these are the disorders starting after 2 years. So the books are saying something is starting before 2 years, something is starting after 2 years. So if you see this number 38 and 23, that means your differential will come to half. As soon as you ask the age, your differential diagnosis of neuroregression will come to half out of some 80 disorders. So the age is most important. What we commonly see in our practice in less than 2 years is these are the 8, 10 disorders. It's not very difficult as we go further. So MSUD we see in newborns, homocystinuria, gangliosidosis, Krabbe's disease, metaromatic leukodystrophies, Leigh disease, NCL, Rett syndrome, Pelizaeus-Merzbacher disease, and muco-MPS. So these are common disorders which we see in our practice. Don't forget B12. Still we see infantile tremor syndrome, nutritional tremor syndrome in our practice. So always keep in mind B12 deficiency as a etiology for neuroregression in all young infants. More than 2 years, what we commonly see is again MLD, metachromatic leukodystrophy, mucopolysaccharidosis, SSPs, neuronal steroid lipofuscinosis, lots of other disorders, Wilson, adrenoleukodystrophy. Here again, keep B12 in mind. In last 1 year, I don't know why it happened, but I have seen 3 patients of subacute combined degeneration of cord because of B12 deficiency, which in my first 9-10 years of practice, I have seen only 1 or 2 patients. But last 1 year, I have seen 3 patients of SSED because of B12 deficiency. So keep B12 in mind whenever child presents with ataxia or some sensory ataxia or regression of motor milestone. Okay, going further. So age is most important to start your algorithm. One of the first of the 3 important question is whether it is only CNS or it is a multi-system involvement. So if there is a multi-system involvement, then your differential will come down further. It is either mitochondrial, lysosomal or paroxysmal disorder. Only these organal disorders will come as a multi-system involvement. What do I mean by multi-system? You look for various ophthalmic abnormalities like KF ring or telangiectasias or some retinitis pigmentosa or something. Organomegaly is hepatosplenomegaly. You look for endocrine dysfunction, failure to thrive child or obese child. Look for facial dysmorphism, like lots of paroxysmal disorder will have dysmorphic features, or micro or macrocephaly. Many white matter disorders will have a macrocephaly. They have a big head because of enlargement of edema of white matter. So if the systemic signs are there, always think for mitochondrial, lysosomal or peroxisomal disorder. So if you look at this chart, which I have shown you, only if you have multi-system involvement, out of this 38 disorder, your differential will come to some 10 to 12 disorders, because there are some 5, 6 lysosomal disorder and some 3, 4 mitochondrial disorder. So if there is a multi-system, out of this box, think of only 10 disorders. In more than 2 years also, again, same classification is there. Second question, whether it is CNS only or CNS with PNS. In adult neurology, our classical teaching is always localize your disease to one place. Whenever child present with you as a neurological problem, you localize first, whether it's a cortex disorder, basal ganglia disorder. But many times they have a multi-system. They have a CNS involvement as well as PNS, peripheral nervous system. How will you decide peripheral nervous system? Just look at reflexes. So any child with neuroregression, spasticity, lots of seizure, but absent reflexes, then associated neuropathy. So CNS involvement with associated neuropathy, only 2 groups are possible, mitochondrial or lysosomal storage disorder. So again, that multi-system along with deep tendon reflex is lost. Either it is a mitochondrial disorder or lysosomal storage disorder. And third important question is which area of neuroaxis is involved, which is very simple, which we used to teach our students every day in and day out. So whether it is a cortical involvement, white matter involvement, basal ganglia involvement, cerebellar or spinal cord or PNS. So there are lots of residents here, so just for reminder. So cortical patient, cortex degeneration will start as a cognitive deterioration, as a seizures, as a behavioral disorders, and as a psychiatric symptom. So if some disorder is starting with these 4 groups, then it is poliodystrophy. That is a gray matter disorder, because it's starting in cells. If disorder is starting in white matter, that is either spasticity or visual impairment, because optic radiations will be affected. So spasticity and visual impairment is a presentation of white matter disorder. Classically, adrenoleukodystrophy will present as a gait difficulty with vision problem. Your basal ganglia obviously will present as a dystonia, tremors, or lots of Parkinsonian features, movement disorder. Cerebellar and brainstem, they present as a cranial nerve impairment or dysphagia or ataxia or dysarthria or coordination disorders. And your spinal cord and peripheral nervous system, they will present as a flaccidity, hypoesthesia, muscular atrophy, loss of sensations, sphincter problems, and hyporeflexia. But keep one thing in mind, this is the onset symptoms. All neurodegenerative disorder will progress. So if you see the patient 2 years into illness, he may have everything. He may have seizures, he may have spasticity, he may have ataxia. How will you localize? So you have to go back in the history, you have to look old papers, old notes, and decide what is the starting point. So this is onset symptoms. This is not the during disease symptoms, because all neurodegenerative disorder, as they progress, they will involve different systems and different organs of the brain. So this is the onset symptoms. Again, same. So there are, out of that same chart, only 3 are the white matter disorder of less than 2 year age. So somebody is less than 2 year with white matter signs, you only 3 differential diagnosis. So this is all clinical. If you have somebody less than 2 year with lots of seizure and cognitive regression, there are only 2 disorders. So out of these hundreds of disorders, if you go these 4 steps, age, multisystem, PNS, and area of involvement, then your differential will go down drastically. And you will reach to some 2, 3, 4 differentials. Okay. So out of when you are now clinically sure that my child is having this some 3 or 4 leukodystrophy, he is less than 2 years and he is having some white matter disease, then you go for investigation to confirm your diagnosis. And Siddharth would agree with me again here that in 90% of disorders, before investigation, we are sure what patient is having. In 90% of patients, we have a clinical diagnosis without any investigation, not even MRI, not even EEG, not even genetics. So this is entirely a clinical approach for your neuroregression. MRI will not go in detail, but just for simple understanding. So this is the, so here is something is there in basal ganglia. So which is some basal ganglia disease. Here you can see some atrophy. You can see lots of sulci prominent. So this is some gray matter disorder. Here you can see something in basal ganglia, this black something in putamen. Here white matter is at fault, so white matter disease. Again here white matter at fault. And this is spectroscopy, which is useful to diagnose 1 or 2 disorders. So this is just give you the glimpse of various imaging of various disorders. And this is the only prototype report I have kept just for your understanding. So because genetics is very important for diagnosis of, confirmatory diagnosis of these disorders. So this is the report how it looks like. It will show you the name of the gene. It will show you where in the gene, in which exon there is a change. It will give you exact location, 634 position or whatever. Zygosity, whether it is present in both genes or one gene, which disease the gene is associated, and significant classification. This classification is very important. This classification is given by ACMG, American College of Medical Genetics. They classify all variants in 3 categories: pathogenic, likely pathogenic, and uncertain significance, or VUS, variant of uncertain significance. This classification will change every 6 months. As the data of AI will increase, this classification will change every 6 months to 1 year. So whenever you order some genetic test, you will get the report, but you will get this uncertain significance. My patient is clinically having basal ganglia disease with some dystonia, but report is saying uncertain significance. What should I do? I just tell the lab every year that give me updated report without any charge. Without any charge, they will give updated report every year. They will just generate the report from the system, from the same database, because your significance of the variant will change every 6 months to 1 year as the data increases. So in all genetic reports, whenever you get the unclarified report, always ask for the re-report after 6 months, 1 year, 2 year, whatever time you need. So this is just for information. Okay, now going for, I have 3 minutes. We have 3-4 cases. You can speak this. Late infancy, so something less than 2 years. Developmental delay and regression, and Hurler phenotype, something coarse face and lots of bony changes, and this type of lots of mongoloid spots, which you see daily and day, all patients, but this is too much. So this is very classical of GM1 gangliosidosis. So GM1 gangliosidosis patient will have lots of mongoloid spots. Late infancy, so less than 2 years. Gait difficulty, that means something motor, white matter. Spastic paraparesis, starting with white matter. Neuropathy, so some lysosomal or mitochondrial. No seizures, so no gray matter. This is the MRI. White matter changes, classical tigeroid pattern. So this is metachromatic leukodystrophy. There are only 2-3 differentials with this clinical picture. Late infancy, some 1-year child. Episodic coma, few days he is fine, few days he is bad. Little ataxia. Regression. Failure to thrive, so systemic sign, multi-organ involvement. So either mitochondrial, paroxysomal or lysosomal. Hirsutism. Absent reflexes, again neuropathy. So either mitochondrial or lysosomal. And lots of apnea. Where is the localization here? Residents, localization. Cortex, white matter, or cerebellum or brainstem. So something in cerebellum and brainstem, primarily brainstem, because lots of episodic coma, ataxia. And if you see these changes, this is a little difficult, but there is some changes in basal ganglia. Second MRI, there is some changes in, brainstem and basal ganglia changes. And this is classical Leigh disease, which is very common in our practice. We see almost 5 to 7 patients a year of Leigh disease. Childhood onset. So now we are in the more than 2-year age group. Seizures, dementia, behavioral. Gray matter or white matter? Gray matter. Retinal changes. Some movement disorder. And cerebellar atrophy. So this is very classical of NCL, neuronal ceroid lipofuscinosis. Gray matter disorder with cerebellar atrophy. Seizures and regression. I forgot to write the age. Childhood onset, 7-8 year. And this is the video. What is this? Very good. Slow myoclonus. So classical SSP. But every time the myoclonus is not so good, see this myoclonus. This is 2 days back patient. Look at very carefully to eyes and overall body. बहुत subtle છે. Myoclonus could be so subtle. Sometimes it's difficult to differentiate, but this is again a proven case of SSP. Childhood onset, movement disorder now. So basal ganglia, dysarthria, dystonia, KF ring. No doubt, everybody knows KF ring, Wilson disease. Childhood onset ataxia. So some cerebellar disorder. What is this? This sign. Telangiectasia. So this is ataxia telangiectasia. So very simple neurodegenerative disorders are actually very simple than epilepsy. Epilepsy is much more complex, what I think. This is very simple. So there are some acquired causes like SSP, progressive HIV infection we see sometimes. Multiple sclerosis also sometimes can look like regression after lots of episodes. B12 deficiency and anti-epileptic drugs. So last slide. So my approach is developmental regression. First decide whether it is delay or regression. Second is pseudo or true regression. If it is true, less than 2 year, more than 2 year. And then you decide the localization, white matter, gray matter, basal ganglia and brainstem. Then our differential will come down to 2-3 diagnosis. Thank you.
Thank you, sir, for this wonderful session. I would like to request Dr. Chetan Shah, sir, to felicitate Dr. Ritesh. Moving forward with the next session, the next topic will be approach to floppy infant to be presented by Dr. Siddharth M. Shah. I invite you, sir. Dr. Siddharth Shah is a consultant child neurologist at Royal Institute of Child Neurosciences, Ahmedabad. He has been a speaker at national and international conferences, and he has a special interest in neurogenetics and neuromuscular conditions.
Good morning, everyone. So it is really an honor and pleasure to be here. So thank you to the Surat Pediatric Association and organizers for inviting me. It's also a great pleasure to be standing in front of an audience after 2 years or more than that. We've all got bored of Zoom and sitting in front of nobody and talking and assuming that somebody is listening. So at least here you can see if somebody is listening or sleeping or interested. So it is really a pleasure. Thank you very much. So the topic given to me is again carrying on with the theme of approach. So we want to keep it quite practical for practicing pediatricians in day-to-day practice, and it is approach to a floppy baby. So all of us have seen a floppy baby. In the first year, when we say baby, we of course carry on infancy or first 2 years, and we're talking about that. And it is quite a challenge. It is interesting because the differential diagnosis is quite wide, and it can be from common disorders to some rare disorders. And as Ritesh very nicely, helped you divide neuroregression into a simple approach, I'm going to do the same and try and help you divide the same approach with a mental approach there of what you are going to do when you are faced with a floppy baby. So the learning objectives are very simple. What is hypotonia and how to recognize it? Because the first step is to confirm that this child is floppy and has hypotonia. When we talk about etiology or physical examination and localization, is it central? Is it peripheral? And if it is peripheral, where in the pathway is it? How to approach when you've identified these two things with simple investigations, and we'll look at some interesting cases to help you use that approach. So the first question is it hypotonia? So what is tone and what is hypotonia? So we all know what tone is, and hypotonia is described as reduced resistance to passive range of movement in joints. So of course, when we think of tone, it's normal tone. You examine, say, 40, 50 patients every day, and you look at their tone, and you look at them. Tone can be seen, tone can be felt. If you've done that, and you've got an idea of normal tone, then you know what a low tone is and what hypertonia is. So hypotonia or hypertonia. And that's the first step in your practice. So to decide whether this baby is actually floppy. Of course, it is important also to remember that hypotonia and weakness are two different things. So weakness is reduction in the maximum power that can be generated. So if I put it simply, hypotonia, you have to feel it. You have to move the limbs. And everybody has their different practice. Either the child is sleeping and you just move their limbs around the joints and see what the muscles feel like. For weakness, you have to arouse the child. You have to get him to sit or stand. And you have to see whether the child is able to do that and grade that power. What is interesting is that weak infants will always have hypotonia. because the motor pathway is involved, they will always have hypotonia. But a hypotonic infant may not always have weakness. So that is to be kept in mind and try and separate the both. Floppy infants, how do they present to you? They will always exhibit poor control of movement and delayed motor skills. So they can present to you as just isolated motor delay. And so if you see a child with isolated motor delay, it's always worth checking if this baby is floppy, is this baby weak, and what could be the etiology. And hypotonic motor movement patterns. So we talk about frog-like posture. You just see the child is lying there in neonate with frog-like posture. You arouse the child, you tickle the legs, and there are some movements, but it is not as vigorous as your normal movements. So you know this child is hypotonic and could be weak as well. When we think about the etiology, you have to clearly think, is it central, is it peripheral? If it is central, there are some very common causes like HIE. So child with hypoxia will initially present with hypotonia, and eventually the tone will change on to hypertonia. Chromosomal disorders, congenital syndromes, they are very common in our practice if we think about it. And all the inborn errors of metabolism that will present in neonatal period could present with hypotonia with or without encephalopathy. When we think about peripheral disorders, we're going to think about anterior horn cell, the peripheral nerve, the muscle, or the neuromuscular junction. And you have an example for each. So anterior horn cell, spinal muscular atrophy. Peripheral nerve, so all the congenital neuropathies. Neuromuscular junction, so all the congenital myopathies. And when you talk about muscle, it is going to be, my mistake, neuromuscular junction, congenital myasthenias. And we talk about muscle, it's myopathy or muscular dystrophies. So basically, at the same time, when you're taking a history and physical examination, you're also working out a differential diagnosis in your mind. So how do you confirm hypotonia? It's very, very simple. You lift the baby. And so basically horizontal suspension or vertical suspension. In horizontal suspension, as shown in the picture here, you get basically a floppy baby who arches over your arms and gives a U shape. And that will tell you that this is like a ragged doll, so which is confirmatory of hypotonia. If you do vertical suspension, child will slip through your arms. Vajan akhu tamara hath par padtu hoy. So you will feel the heaviness of that, and that will confirm that this child has generalized hypotonia. If you do a traction test, so you get the child to be put in supine and you lift the child, you will see the head leg that is shown in this picture as well. So it can be quite easy, if you observe properly. Along with it, many hypotonic children will have hyperlaxity of ligaments. So if you bend their arms, they're quite bendy around the elbows, around the wrists, around the fingers. And they can sit in W position. So that can be given in history as well, that they always sit in W position, which is suggestive of a hyperlaxity, basically. If you look at the face, sometimes that can be suggestive that they have a kind of myopathic face, as we say. You can see the lips here, you can see the face, it's expressionless. And of course, along with the generalized hypotonia and generalized weakness, it can be suggestive of a peripheral weakness disorder. So this is basically how to confirm hypotonia. You have the definition in mind, you do the examination, and you confirm whether it is hypotonia or not. Then you're thinking of central versus peripheral. So it's very, very clear that central hypotonia disorders will often present with decreased level of consciousness. The hypotonia is mainly axial rather than in the limbs. So it is truncal and it is along the head control. Whereas peripheral hypotonia, you will always see peripheral weakness or hypotonia. Often the strength is normal with hypotonia in central disorders. So think of Down syndrome. The child is very floppy, hypotonic, but they can still sit, they can still walk, and often when you lie them and try and assess their muscle power, they can do anti-gravity movements in the limbs, so which confirms they have a normal power often. Dysmorphic features can be helpful again in central disorders because a lot of congenital genetic disorders present with hypotonia. As I said, if you've got a child who has had HIE or another metabolic disorder, they will often then present with spasticity and exaggerated reflexes later on. So that confirms that there is a central disorder. Presence of seizures, abnormal visual tracking, that can be all clues in the physical examination when you're examining the child to confirm that this is a central disorder. Peripheral hypotonias, they'll have limb weakness, they'll have normal or decreased reflexes, and they will have muscle atrophy. And I'll look into that in a little bit more detail. So how to make a diagnosis? And this is a wonderful study, and it clearly shows that history and physical examination itself will give you the diagnosis 50% of times. The rest of the confirmatory investigations will help you another 50% of times. But often it will lead you where you need to go in terms of the right investigation. Now the good thing is investigations are available, they're becoming cheaper, and you all can use them in your practice. MRI centers are everywhere, in small centers, big centers. But do try and formulate a diagnosis, and that will help you identify the right investigation that you are going to do. So what to do in the history? So prenatal history should be included, fetal movements, fetal presentation, the amount of amniotic fluid, because that can give you a diagnosis of a central or congenital hypotonia. The Apgar scores can be sometimes suggestive, so you could have a child who needs resuscitation and then is hypotonic. So whether this child suffered HIE or the child was floppy and that's why needed resuscitation. So if you understand. So it could be a floppy baby who just needs resuscitation, has not suffered HIE. This is quite interesting and important, that a hypotonic newborn should be considered septic until proven otherwise. And I've often been reassured by my colleagues that the septic screen is normal, only to find that the blood culture comes back positive with Klebsiella after 2 days. So it's not always neurological, and it could be sometimes general as well. So worth keeping in mind. A term infant who is born healthy, but then later on second, third day starts having hypotonia is often a neurometabolic disorder, and that is worth keeping in mind as a pointer. Central congenital hypotonia, so genetic disorders, etc., will not worsen over time, but if you have had a brain injury, then that will worsen over time, and then it will develop hypertonia and deep tendon and brisk reflexes. So after the physical examination, along with physical examination, the localization is very, very important to choose the right diagnosis. And for that, basically a motor examination is very, very necessary. It's not that difficult. So these are the points you need to do in your motor examination. You look at the strength, you look at reflexes, you look at the plantar, you look at infantile reflexes, you look for fasciculation. That can be difficult sometimes, but still helpful. You look at the muscle mass. That can be easy. You look at sensation, and you look at tone. Of course, you've looked at tone at the start, but you look at tone specifically. And I'll help you break this down a little bit further to make sense. Okay. So first of all, you're thinking on examination, is this central, is this peripheral? Again, UMN versus LMN. And if you look at this, it's very, very easy that at this line, here these are central pointers, these are peripheral pointers, and everywhere weakness will be present along with hypotonia if you've got a peripheral disorder. If you've got a central disorder, the power is likely to be normal. Reflexes will be decreased in all peripheral disorders, and the infantile reflexes will be absent along with that. So clearly, at first examination, you've decided whether this is central or peripheral. Within peripheral, how can we decide whether this is anterior horn cell, this is nerve, or this is muscle? And basically, anterior horn cell, the fasciculations can be present, and atrophy, especially proximal atrophy, will be present in anterior horn cell disorders. In nerve disorders, sensation will be involved, and there will be distal atrophy. And in muscle disorders, there will be proximal atrophy again. So anterior horn cell and muscle disorders, you'll have proximal atrophy. Nerve disorders, you'll have distal atrophy. So by using this simple examination, you've come to a kind of point where you know that this child has hypotonia, whether he has weakness or not, whether he has a central disorder, whether he has a peripheral disorder. Okay, so this is the approach, the clinical approach. We'll look at some cases, and along with that, we'll look at some investigations that we would use in these children that would make it helpful to confirm the diagnosis. So one of the commonest disorders that we see in our practice with hypotonia. So Down syndrome, basically, the dysmorphism. You've examined the child, they all have significant floppiness. I think if there is 1 or 2 pointers in Down syndrome that every child has is floppiness and a flat occiput. They might not have obvious dysmorphic features sometimes, they all won't have CHD, they all won't have hypothyroidism, but they all will have floppiness. And basically the reason why you need to remember is that once you've diagnosed the Down syndrome, you've done your job, you need to help them progress because they will have delayed milestones as well. Almost all Down syndrome children will start walking, but the age is quite late, normally between 3 and 5 years. Sitting is quite late. So do refer them for multidisciplinary approach of treatment. Basically check for thyroid, check for other things, but do send them for physiotherapy as well. So that will be helpful as a treatment modality for children with Down syndrome. Second case, so this is a child who's a 5-day-old baby who presents with poor feeding and lethargy. The child did not have any problems at the time of birth. On admission, you notice some subtle seizures on either side. So right or left, the parents have not told you, but you have noticed. You also notice that the baby is drowsy and has a frog-like posture with some movements on stimulation. So when you stimulate the baby, the child does make movements. So what is the possible diagnosis? So let's think it this way again, central or peripheral? Central. Thank you for listening. So at least you clearly know now this is a central disorder. This is not a neuromuscular problem. Okay. So once you know it's central, what type of etiology? It could be sepsis. So sepsis definitely needs to be ruled out. So unless proven otherwise, sepsis is possible. IEM. Wonderful. So again, children who present slightly later on in neonatal period could be IEMs, again with seizures, with drowsiness, so a little bit of encephalopathy. So you need to check your ammonia, you need to check your lactate. It could be an organic acid disorder, it could be a urea cycle disorder. Any disorders that you could name out that is possible on 5th day of life with this kind of presentation within IEMs? Somebody said MSUD. What investigation would you do straight away? Sorry? TMS? Urine CMS you said? Yeah, it'll take 5 days, but it is the right investigation to confirm the diagnosis. But another useful investigation is MRI brain. The MSUD pattern is very, very clear on the MRI. There is no confusion about it. And straight away you can start treating the child depending on what the abnormalities are. But the urine GCMS is often going to be confirmatory after that. So what MRI changes am I pointing to? All the myelinated parts of the brain, they shine up on DWI imaging. So the MRI can be very, very simple, diagnostic. It will come with a line by the radiologist. These findings are suggestive of MSUD. So it can be very, very useful. Well done. Okay, so another floppy neonate. 10-day-old baby is found to be floppy, query since birth. We're not sure, but possibly. Poor feeding. When I go to see the child, there's an NG tube. Child is being NG fed. Has some dysmorphism. Again, like you, I'm not very good at dysmorphism. I can identify Down syndrome. Beyond that, it can be very difficult. Can perform anti-gravity movements, but still weak. So you have identified this child is floppy, poor feeding, weak. No seizures, and undescended testes. So what kind of disorder is this? Central or peripheral? Okay, somebody has said peripheral. Poor feeding. It can be both. But poor feeding and suck can often be a sign of central disorders rather than peripheral. And then there is dysmorphism as well. Though I didn't know what the dysmorphism is about, but there was dysmorphism. So you're thinking of probably central disorder. And which kind of central disorders? Genetic disorders. Dysmorphism. The whole book of genetic disorders, 2,000, 5,000 odd of them. Any diagnosis on genetic disorders here? I've given a very important clue. Fantastic. Prader-Willi syndrome. My approach is very simple. Floppy child, NG fed, first week of life, undescended testes. Only think of Prader-Willi syndrome. Don't do anything else. So these are the criteria for Prader-Willi syndrome, diagnostic criteria. There are major, minor, supportive findings. And if you have 1 point each and minor criteria 0.5, you've looked at the baby, there is central hypotonia, there are feeding problems, there is hypogonadism. You already can make a diagnosis. What is the investigation of choice here? Sorry? Genetic testing. Which genetic test? Clinical exome is very expensive, 15,000 rupees, 30,000 rupees. There's a simpler test. Fish test, okay, or MLPA, 3,000 rupees. It'll be back in 2-3 days. So forget about clinical exome. You've made a clinical diagnosis. Why go for clinical exome? So we do that, but that is useful there. So again, this child with Prader-Willi syndrome, and you can see on fish test or MLPA, you can easily diagnose Prader-Willi. Okay, another floppy 5-month-old female child who was born without any concerns. Parents say that she was doing well till 4 months of age. Hypotonia, mild head leg on examination, weakness in lower limbs predominantly. There are absent reflexes as you examine. Mild distal atrophy is also seen. So central or peripheral? Peripheral. This is very clear. You cannot miss this. Okay. In peripheral, anterior horn cell, nerve or muscle? Okay. Sorry, somebody said anterior horn cell. Any other? Neuromuscular is possible, I agree. I think at this stage it can be a little bit difficult. What in the history is there to suggest that what it could be? Yes, exactly. So the child was doing very well till 4 months of age, but there was some regression. If you listen to the parents carefully, they are never wrong. So in this child, so what is the diagnosis then, Ketan bhai? SMA, absolutely. I mean, so this is one disorder that has become very interesting. It is so common. What is the carrier frequency of SMA? 1 in 40. So from this room, 10 of us are probably carriers of SMA. Okay? It is that common. Okay. So, and the disease rate is quite frequent. So that's why you see a lot of SMA type 1. So very important to know about the clinical presentation, early diagnosis. So SMA 1, 2, 3, 4, we're talking about SMA 1 here, depending on the age. Again, simple test, not clinical exome. You need MLPA for SMN gene. In Ahmedabad labs or Surat labs, it will cost you about 4,000-5,000 rupees. The result is back in 5 days. Nowadays you also need copy numbers like this. So don't send PCR, send MLPA now. Why? Because there are treatments available. And depending on the copy number, you will decide what treatment. We've all heard about the injection of 16 crore rupees. One of our patients from Gujarat has taken it, and that is Zolzen SMA. Yeah, last 2 slides. I'll finish shortly. So again, the treatment is available. Remember, the earlier the treatment, the better the outcome in these patients, even after spending 16 crores. So if you help identify the patient at 3 months of life, the outcome is going to be much better than 7 months of life. Last presentation, 5-month-old, hypotonia, weak, head leg, poor anti-gravity movement of upper and lower limb, absent reflexes, no atrophy, tented lip, some swallowing difficulties as well. So again, we're thinking of peripheral, mild facial weakness is there. So what is a clue for that? Myopathies and dystrophies, very good. So congenital myopathy or muscular dystrophy, just last slide. So basically myopathies are thought to be intrasarcoplasmic. Muscular dystrophies are outside the muscle or the layer of it. That's the main difference. They can present in very similar ways, though CPK will be very high in congenital muscular dystrophy. So do a CPK. MRI can be abnormal in muscular dystrophy. It will be normal in myopathies. Think of the other things. Often genetic testing is what helps you. And so to summarize, it is important to recognize hypotonia with or without weakness. History taking is very important. Physical examination will be very important. Think about central versus peripheral, and each condition will have its own different management, so investigation and prognosis. Thank you very much for your attention.
Thank you, sir, for this wonderful session. I would like to invite Dr. Digan Shastri to felicitate Dr. Siddharth.
Yeah, we can take a question each for the previous 3 talks. Any questions? For viral respiratory infections, for upper airway emergencies, for neuroregression, and for floppy infant? Yes, Dr. Digant has a... Yeah, Praful.
I, can I ask two questions or only one question? So first question is to Nirmal Bhai. Sir, in your presentation, in upper respiratory obstruction emergency situation, you have mentioned in many of the flow charts about intubation by an expert in a OT. But there are primary care pediatricians where they don't have the facility for intubation in the OT. So what should be the action by, at that level? That is a one question. Another is that there is no mention about tracheostomy anywhere in the flow charts. So is there any role of tracheostomy in upper respiratory obstruction?
I spoke about the tracheostomy because I did not take with this algorithm of the difficult intubation. In difficult intubation, if you are not in a position, then it's better to go for the tracheostomy. See, I said laryngeal airway mask, and then about the cricothyroidotomy, needle cricothyroidotomy, and then the tracheostomy. So if you are in doubt and it's a really serious case, and then it is better to call a pediatric surgeon and get the tracheostomy done. I think that is the most easy part to do. And if you know the child is very sick, there's a severe work of breathing is there, there's a lot of retraction and you can't visualize the airway, then you try to give oxygen by the mask at the highest level, 10 liter or 12 liter per minute. But otherwise don't try to disturb the child, because the child is otherwise whenever you disturb it, then sometimes the obstruction increases because of the reflux spasm. So whatever is the best comfortable position, even the child may be in the lap of the mother. So you continue with the oxygen and try to deliver the oxygen as much as possible. But if there is a complete obstruction, then whatever the easily available thing you can do, just like putting a needle on this called cartilage, below that, we have to save the child. But attempting the intubation, if you are not competent, then it will deteriorate the child. See. And I think each and every child give some time for call for emergency help, and that would be better.
Thank you, sir.
Sure. Thank you.
Question to Raju Bhai about the... Sir, you very well covered about the clinical diagnosis of viral infections, and again in the last part you had also covered something about the multiplex PCRs and PCR. So the question is, apart from the cost, how much is the reliability, means specificity and sensitivity for this multiplex PCRs in diagnosis of course in the COVID we definitely, and for even influenza also we consider it as a gold standard, but for other viral infections?
No, for viral infections as such, RT-PCR is an excellent test, and if the standalone RT-PCRs are available, the sensitivity and specificity is much, much higher. But when we are talking of multiplex PCR, as there are multiple tests available, the sensitivity and specificity goes little down to certain level, but still it is almost close to 92% for the sensitivity and almost close to 95 to 96% in the sensitivity. So for almost those situations where you are suspecting some viruses which are not commonly seen, those type of viruses, and where standalone PCRs are not available, it would be better that you go for the multiplex PCR where the diagnosis is possible. No, it's not needed or not necessary in all the situations. You must always, clinically think of possibility, looking at both the things, the presentation as well as the epidemiology. And from that, based on that, you can decide what it is better to go for 2 standalone PCRs rather than going for multiplex PCRs, because ultimately cost will be still less in 2 standalone rather than going for the multiplex PCR. So that way, that's good. But in a situation where the child is in intensive care, child has some other complications, and you are thinking that there are some other possibilities, then in those situations, multiplex PCR would be better than the stain alone. So that is how you can decide what type of PCR you want to use. But nowadays, these type of PCRs are considered to be a second golden sort of a diagnostic rule. As you know, viral cultures were considered to be a golden rule, but now even the multiplex PCRs are also, so sensitivity and specificities are very good for that. Thank you.
Thank you. We may proceed to the next session. For that, I would like to invite Dr. Tushar Shah to deliver his talk on clinical update on PCV and hepatitis A vaccine. Dr. Tushar Shah is a consultant and professor, KGP Children Hospital, Vadodara.
A couple of you had questions. We can, Dr. Siddharth and Dr. Ritesh can take them in the lunch. Thank you.
So, thank you very much, and good morning to one and all present here. It's my pleasure, privilege, and honor to be standing here in front of you and talking on this very important, vital, and a vibrant topic, which has become suddenly very hot because of the new kid on the block, and that is talking about updates on PCV and hepatitis A vaccine. At this very prestigious event of our annual state conference, which is so well organized by Spectians. So congratulations to them. Yeah. So I'd like to dedicate this talk to the corona warriors who are fighting day in and day out since last 2 years against this biggest pandemic that we are facing, and let us hope it ends soon and we will be having such more meetings in the coming time. Before I go ahead, I would like to make a small disclaimer, and the disclaimer is that though the session is sponsored, I have not received any honorarium, and the discussion that is going to follow is going to be evidence-based. The agenda for today's talk is to talk on PCV and hepatitis A vaccine both. In the first small half, we'll talk about pneumococcal disease burden. We'll talk about what is important to a clinician, whether it is just the serotypes which are there in the vaccine or is it the protection that the vaccine offers. And we'll talk about the choice based on evidences regarding which PCV vaccine to choose in your practice. Similarly, for hepatitis A vaccine, we'll look at how serious it is and how the shifting endemicity of hepatitis A is leading to the need for long-term protection and evidence-based choice for hepatitis A vaccine. So coming to the first half of it, we know that pneumococcal disease is the #1 cause of vaccine-preventable death. And unfortunately, India ranks #1 in pneumococcal deaths in the whole world. You can see almost 22% of pneumococcal death under 25 years of age come from India. And that proves beyond doubt that protection against pneumococcal disease is essential. So there is no debate on that. Coming to various vaccines which are available in the market, as far as PCV vaccines are concerned, we have 3 vaccines now, and we know that the PCV10 Synflorix is a vaccine where the conjugate protein is protein D of non-typable Haemophilus influenza, which binds to 8 different serotypes, whereas tetanus toxoid and diphtheria binds to rest of the 2 serotypes. Whereas in PCV13 and PCV10, the conjugate protein is CRM197 diphtheria carrier protein. We also know that the new PCV10 has removed 2 important serotypes which we'll come to later on in the presentation, 4 and 18C, which also forms an important part of the total vaccine serotype prevalence. At the same time, serotype 19A, though it is not there in Synflorix, we know that it has indirect or cross protection, which we'll talk soon. So how to assess that which PCV vaccine is better? And for that, whether we will look at vaccine serotype coverage, whether we'll look at various antibody titers in the form of ELISAs and OPA and immunogenicity data, or will we look at the overall protectiveness or effectiveness of the vaccine? So definitely, I believe that it is more important to see in real life situation which vaccine is giving you better protection and effectiveness. So we'll try to dispel some myths which are there about the serotype prevalence and serotype coverage and serotype protection regarding when the vaccine is being discussed, especially a PCV vaccine. So we know that the vaccine serotype coverage has been told by various companies or various pharmaceuticals when they talk. What they mean is the mathematical sum of percentages of the disease contributed by all the serotypes in the respective vaccine. And let me tell you, friends, that the misbelief number one is that all the serotypes which are there in the vaccines are not necessarily going to be 100% protective. And for that, the example is the serotype 3, which is though there in PCV 13 and was there in 11 PCV vaccine of GSK initially, which was then later on shifted to PCV 10. We know that it is not effective because of the strong capsule. Similarly, the second misbelief, where we don't account for any cross protection, we need to understand that 6A has a cross protection and also had a cross protection even in PCV 7. Similarly, it has cross protection in PCV 10 of GSK by 6B. And 19A also has a cross protection from 19F. We'll look into that in next few slides. So, friends, the protection that we get is based on coverage or evidence-based that we need to understand. If you look at the coverage-based approach, then we know that there is definitely difference of around 10 to 12% in the serotype distribution. But when we look at the overall evidence-based approach, we know that on impact on overall disease burden and impact on that if it is concerned, then all the vaccines are almost equivalent. So we need to look at the evidence-based approach. This is to just highlight a recent latest systemic review on PCVs which was published in August 2021 in GIDC, where they had discussed or they had talked about invasive pneumococcal disease burden and PCV coverage in children under 5 in Southeast Asia with special implications to our country. And there, the objective of this study was to review and summarize the existing data on the burden of in under 5 antibiotic resistance and serotype distribution of IPD in Southeast Asia. And also, this was basically a observational study, hospital study, and all these studies were taken up. And between 2008 to 2018, total 49 articles were included in final analysis, which were published over 10 years. And they had also discussed about the direct protection and the cross protection. And in this, they had seen that the vaccine serotype, which if you look at that way only, then the 67.3% for Synflorix, 72.8% for the new PCV10, and 78.4% for Prevnar was there as far as the serotype distribution was concerned. But when they considered the cross-reactive protection against serotype 6A, which was 5.3, and against 19A, which was 4.1, then the serotype coverage for Synflorix is 76.6%, which is also almost equivalent. So we know that when we look at the serotypes along with the cross-protection data, then we know that the protection offered by all the 3 vaccines is almost nearly good and equivalent. And similar result, if we see from different countries like Sweden, New Zealand, Morocco, and Canada, then we know that there is similarly serotype difference for 19A, 6A, and 3, as we observed in our country of 8 to 10%. Or 10 to 12%, it is there in these different countries to the tune of say 17% for say Sweden. And there also they observed that when they looked at the effectiveness data on the comparison of IPD protection offered by Synflorix and PCV13, the impact was almost same for a pre-PCV to post-PCV phase. And similarly in New Zealand, also when they compared IPD protection, it was same, even though there was difference in serotype coverage difference between the 2 vaccines. Similarly, in Canada, at Quebec, also when they compared IPD protection, it was almost same between Synflorix and PCV13, and also same in the Morocco data. So as you can see from different country data also we know that additional serotype coverage does not result in higher protection, but it is almost same. As I was saying that 19A effectiveness studies across the globe for Synflorix and PCV13, if you look at those studies, as you can see from different countries, and then also we know that the Synflorix offers 62 to 82% effectiveness protection against 19A. And it is approved in 94 countries, including India, for protection against 19A, which also happens to be very important pathogen for invasive pneumococcal disease. So friends, this cross-protection data is important for us to understand because we know that this is not new as far as vaccinology or immunology is concerned. The same principle we had used when we could eradicate smallpox, where we used a cowpox vaccine for helping us to prevent against smallpox. Similarly, for BCG also we know that Mycobacterium bovis gives protection or cross-protection against Mycobacterium tuberculosis and Mycobacterium leprae. Similarly, in IPD we know that 6B was getting 6A was getting protected by 6B when it was PCV7, and similarly in Synflorix, 6B, 6A and 19A gets cross protection by 6B and 19F. Similarly in HPV, where also a bivalent or a quadrivalent vaccine also gets cross protection, and in Rota also we know that there is cross protection offered against different strains. So this concept is not new, friends. When we look at different titers or immunogenicity data, we know that nowadays we talk about not only ELISA titers, but even the functional OPA titers, which are important. So there also, if you look at this study, we know that there were significant OPA titers being noticed and observed in this study for 6A and 19A, which also signifies that there is cross protection which is offered. Beyond this protection for invasive pneumococcal disease, we know that in this Sweden data, where in different counties they use PCV vaccine, they know in few counties there was Synflorix and in few counties there was Prevnar. So there was a direct head-to-head comparison, and then we could see that there was further extra benefit offered by Synflorix, and which was a dual protection against not only IPDs but also against acute otitis media caused by staph pneumoniae and non-typhable Haemophilus influenza. So that is an added advantage. So if we compare all the three vaccines, we know that as far as immunogenicity and safety is concerned, all the three vaccines have good amount of data. But when we look at efficacy, effectiveness, dual protection, schedule flexibility, and use in special population like preterms, we know that there is no adequate data for the new vaccine which is recently being launched, whereas there is adequate and optimum data for rest of the two vaccines. And therefore, friends, to summarize my talk on evidence on pneumococcal disease prevention, I would like to say that pneumococcal vaccination is essential. There is no doubt about it, because we contribute to the highest number of pneumococcal morbidity and mortality in the world. Choice of PCV vaccination should be based on overall protection offered and not just on the serotype content alone. We need to understand that additional serotype coverage does not necessarily mean higher protection, because we need to also account for cross protection which is offered by various vaccines and various strains which are there in the vaccine serotype. And we also have an added advantage here with Synflorix, where it gives dual protection against IPD and AOM both. Coming to the second half of presentation, which is going to be a rapid one, on hepatitis A vaccination and understanding the dynamics of shifting endemicity. Friends, we know that if we get hepatitis A infection in early childhood, then the disease is mild, at times subclinical, and we don't have more symptoms, and it usually is passed on, giving some good immunity to that particular child. But nowadays, with the improving living standards, we know that there is shifting endemicity and shifting epidemiology of hepatitis A vaccine. So now when the disease is happening in elderly child or adolescent or say young adults, we know that the disease is more severe, causing there is a risk of death also with acute and fulminant liver hepatitis that we see very commonly with hepatitis A infection. So when we know that there is shifting endemicity, there is a huge need to give protection against hepatitis A infection, and we should aim at getting hepatitis A to all our patients. So understanding the same thing again, the historical view was that most of the patients get the infection in early age, and therefore they are going to be anti-HA seropositive, and very few will be anti-HA seronegative. But the present scenario, as I just said, that more and more number of people are now not getting that infection in the early age group. So we know that 2 out of 3 children under 10 years of age are vulnerable to hepatitis A infection. So adolescents as well as adults are at increased risk of getting hepatitis A infection. And that is the reason why we see a lot of infection in this age group, and not only infections, even we see a lot of outbreaks in this age group. So as you can see that there are a lot of reviews and data being published 2005 onwards, about 38 publications which talk of increasing number of adolescents and young adults getting infection by hepatitis A and even complications, and increasing number of outbreaks. So this means that there is a huge need to give protection and give long-term protection so that they are being taken care of even in adolescent and young adult age group. So when you have to choose a vaccine, the key parameters to evaluate a hepatitis A vaccine, we need to look at different things, which includes immunogenicity, long-term protection, real-world data, and the safety profile. So this is true for any vaccine for that matter. And when we talk of, say, Havrix, we know that as compared, this is an inactivated hepatitis A vaccine as compared to a live vaccine which is available also in the market. And when we compare these two vaccines, we know that Havrix is highly immunogenic because it gives almost more than 2 times GMT titers, as you can see, as compared to the live hepatitis A vaccine at 7 months, 12 months, and 24 months. And it offers 100% seroconversion in 19 days. So because it gives a very rapid seroconversion, it is also recommended for outbreak control. And when we look at live hepatitis A vaccine immunogenicity, we also understand that there is some primary vaccination failure. So it is not 100%. So almost say 91% around, as per this study data which was published in Indian Pediatrics in 2015 by the group. And there almost 13 children out of 141 where there were vaccine failures, and that means that there is 9% primary vaccination failure, and that is the reason why many of us still continue giving 2 doses instead of 1 dose of hepatitis A vaccine, which is also being recommended. And because it gives a slow and delayed uptake and low uptake, it is not recommended for outbreak control. We also know, based on these various calculations of antibody GMCs, kinetics, and mathematical modeling, that Havrix can provide a long-term protection at least up to 50 years of age. So it gives a very long-term protection, which is very, very essential because we are seeing shifting epidemiology and we need to give long-term protection. When we compared it with a live vaccine, we know that there is some declining titers over years as far as the data from China and India both are concerned. So friends, when we look at the impact in countries where it is used for universal immunization and universal mass vaccination, like in Panama and Israel, these are 2 models where we know that hepatitis A vaccination has given definite impact in the people who got vaccinated, but also in the people who were not vaccinated, so even the general population. So when it was used in universal mass vaccination in Panama, we could see that there was 90% reduction in reported hepatitis A incidence in vaccinated population, as well as 87% in general population. Similarly, in Israel, we see that more than 98% reduction in hepatitis A incidence compared with the pre-vaccination years, including unvaccinated population. As far as safety is concerned, Havrix has a long record of 25 years of safety data, and we all have used it often in our practice, and we know that it is a very safe and effective vaccine. When we compare it with a live vaccine, the data is limited, but in my experience, that is also equally safe. So summarizing, friends, the last slide, the large population of adolescent and young adults are now vulnerable to hepatitis A infection in India because of the shifting epidemiology, because of the improved living standards, hygienic, this water and safe drinking water and everything. We know that the whole disease burden is shifting to young adults and adolescents. So we need to give protection which is long-term and established, and therefore we need to resort to Havrix, which is trusted globally for more than 29 years. So thank you, friends, for your patient listening, and if there are some questions, I can take them.
Thank you, sir. I would like to invite Dr. Parang to felicitate Dr. Tushar. Sir, you can proceed to the presentation area.
May I now invite Dr. Upendra Kinzhwadeker to deliver the next session. He is a very leading private practitioner at Nerul and at Apollo Hospitals. He is the President-elect 2022, one of the most eloquent speakers I've heard, and a great knowledge of Marathi literature. He will talk to us about newer diagnostic tests in pediatric infections.
Can I have a remote here? Speaker also? A very good morning, friends. I'm really thankful for the kind invitation to participate in GUJPEDICON. Before going ahead, two announcements. First of all, I'm really emotionally overfilled because the last time I was at Awadh Utopia in West Zone Pedicon a couple of years ago, I had participated in the debate on vitamin D against Dr. Jagdish Chinnappa, my dear friend, and the judge was none other than Dr. Ashok Kapse. So this very place, this was the last time I visited Gujarat, so my humble respect to the memories of Dr. Ashok Kapse. And secondly, I express my gratitude to each one of you for honoring me by showing your trust and faith by choosing me as President-elect Indian Academy of Pediatrics. Thank you very much. So coming to the topic assigned to me, newer diagnostic test in pediatric infections. So all of us know that the type of microbial infection, the disease severity, availability of resources, and the technical expertise, which is there, which is ultimately going to determine how am I going to use the test or not. But more importantly, remember that we are all disciples of Dr. Baldev Prajapati and Dr. Y.K. Amdekar, sir, who would always tell us, please make a provisional diagnosis, go through correct history, clinical examination, and use lab to assist your diagnosis, not that labs are going to diagnose the condition. So whatever best resources that we have available, let's use this part more in history and examination. That science will never go away. Though wonderful, newer advances are being made in the newer diagnostic test, ultimately clinical examination remains the most important one. Of course, this is the one which is most talked about. One test, 21 pathogen, 45 minutes. What more we want? Because ultimately it is time has come that we want to have an actual microbiological diagnosis. I'm talking about BioFire microfilm array. So we have always treated pneumonia on the basis of antibiotics given on age-specific criteria. All of us know that. But now, suppose we want to use this test, I'm going to take help of a couple of cases, and let's see how we are going to use the available test to us. The time given to me is very less, but let me see as many cases that I can cover in this stipulated time. So let's start off with a common day-to-day case of bronchiolitis. A 2-month-old child, first episode of cough and breathlessness, oxygen is 88, temperature, RR 65, he's irritable, some bronchi and crepes. And then the pediatrician felt a little uncomfortable because of that saturation and felt, oh, am I missing a pneumonia? So could be, so he started cefotaxime and amikacin. X-rays in front of you. Now I have availability of RSV rapid antigen test. So should I use it? It comes positive. What is the significance of it? Can I stop antibiotics just because the test is positive? And should we do it in all babies? Bronchiolitis is not at all uncommon clinical condition. And then what about multiplex PCR? So let's see how it stands. So the bottom line is, in a day-to-day mild bronchiolitis, we need not do any test. So we go by our clinical acumen, we categorize the patients and give symptomatic treatment. Mild to moderate also. When it comes to severe, or a child who has a high risk factor, who is a premature, who has a chronic lung disease, who has unstable, hemodynamically unstable cardiovascular disease, who has recurrent lung infections, there if the child comes with bronchiolitis, I need to be 100% sure that it is bronchiolitis and I'm not missing any organism. So this rapid antigen test is excellent, let me tell you. And the cost is just 500 rupees. And what happens is, the only point is, look at this, prevalence, what is the disease prevalence in the society, that will determine the positive predictive value.
If the prevalence of the disease is negligible, you did not put attention to this test. And if it is really, you have many cases coming with bronchiolitis, the positive predictive value of the test goes very high. So that is the point to be remembered, but a good day-to-day test available, 500 rupees is the cost, and very much reliable as far as sensitivity and specificity is concerned. Then what about the other test, the multiplex PCR for Rsv diagnosis? A big no, because even if we have it, it will again have number of other viruses also could be growing, wherein it will not, as Dr. Rajubai said, more the pathogens reduces the sensitivity of the test. So rapid antigen test is good. The PCR is ultimately the gold standard. We do not have direct fluorescent antibody test, but if multiplex PCR comes, it still comes low down. It's not worth the cost of 15,000 rupees for a diagnosis of bronchiolitis. So if you have antigen positive, please, you may use it. So second case, this is an 11-month-old child who has come in month of August in Navi Mumbai, monsoon season. Cough and cold is 7 days, fever. There is no notification about influenza outbreak in my city. Child is febrile, is tachypneic, and reduced air entry. So point is, I am suspecting influenza. So influenza, whether it remains a clinical diagnosis or can I do some test? Again, the point is, mild to moderate cases, you need not do any test, and it still remains a clinical diagnosis. The moment it becomes a severe case, the child requires ICU admission, oxygen dependence, and then you need to be 100% sure that you're not missing a bacterial cause and you're really dealing with influenza. So what are the choices that I have? To treat empirically, yes. You may treat with oseltamivir in a given circumstances when the child is really sick enough, he is in ICU, he is on oxygen. But then, what about viral culture? Absolutely no. It's only of epidemiological importance to you, and then ultimately the companies will decide about what next the configuration of the vaccine has to be. For you and me, cultures have no role. Serology, a big no, because it takes time, and then it will not be of any use to you in clinical diagnosis. A rapid diagnostic test for influenza. I told you that Rsv is excellent, but if I tell you about influenza, it's just 20%. So a rapid diagnostic test for antigen detection, a big no for influenza. And then, of course, PCR for Neuropharyngeal aspirate, yes, it does have a great value. Now, again, the points are that which kind of PCR should I use? So there is a cartridge-based PCR you should take because the turnaround time is only 30 minutes. It's very much available over here. And then the conventional, rather than the conventional one, and the point is where you are dealing. Is it an outbreak situation or you have just come out with, encountered with a single case of influenza? So in the outbreak situation, do the standalone test, but if no outbreak, do multiplex PCR as it will tell us about other viruses. So this point needs to be remembered in an outbreak situation, no outbreak situation, a single plex or a multiplex PCR. But the point is a PCR is an excellent test for diagnosis of influenza, very much available. Now we have this CFID. This is a cost saving. Now you may say, Dr. Upendra, I have a doubt whether it is influenza or Rsv. How should I go about? My patients cannot afford a 15,000 rupees test. Yes, I agree. So this CFID is available. This is only two pathogens detecting test. So we have flu plus Rsv express assay. All of us know because of Gene Expert, the express tests are available. So this demonstrated extremely high sensitivity, specificity for influenza A and B and Rsv in 60 minutes. So why not make use of this test? A doubleplex PCR test which gives you only Rsv and influenza, it's much better than giving a multiplex PCR. Of course, if you have suspicion only of influenza, go ahead with a singleplex PCR for influenza. Let's move on to case 3. This is a 5-year-old child who has some crepitations, who made a diagnosis, fever, cough, and made a diagnosis of pneumonia. I started amoxicillin because, the age group is 5, so I'm fine, good enough if I start only with amoxicillin. Fever persists. Now I start scratching my head. Could it be mycoplasma? Should I empirically add on a macrolide? Yes. But somebody would say, no, I want a specific diagnosis. Grow mycoplasma, show somewhere mycoplasma, and then treat. So what is it? So what are the tests available for mycoplasma? I have a BioFire mycoplasma which comes positive in this child. So what is the significance? Do we have a standalone mycoplasma PCR or do we have to every time do a multiplex PCR? What about IgM? Where have the serology is good? What is culture and what is the role of cold agglutinin? Let's see one by one. Very important, simple message is it's not at all indicated to do a test in a mild self-limiting disease. You may empirically use this child on macrolide antibiotics. Perfectly all right. But if this child was immunocompromised, or if you have extrapulmonary manifestations, all of us know that mycoplasma very often comes with extrapulmonary manifestations, a mucocutaneous eruption, hemolysis, or encephalitis kind of picture, then I would be 100%, I would like to be sure what am I dealing with rather than empirically treating. Or if I have a child who is hospitalized, I have started him on beta-lactam antibiotics. I expect a response in 48 hours, but I don't get it. Then what should I do? So there these places I must use. And last but not the least, you know that mycoplasma is also immunologically mediated disease. So wherein sometimes you may have to give pulse steroid. Can you give pulse steroid just empirically for considering a mycoplasma complication? No. So in such situations, we need to have a bacteriological diagnosis of mycoplasma. So which test can I do? Nasopharyngeal PCR remains the best. Extremely high specificity. People say that if you grow somewhere nasopharynx, there are so many, because it's a colonizer, but then it is grown. No, if your child is symptomatic of low respiratory symptoms, and if you grow from nasopharyngeal, give importance to that mycoplasma which is grown over there. In a routine, you are not going to do a community survey, what is a mycoplasma prevalence. But in a symptomatic child, if you have grown, it is never found that a multiplex PCR will give you mycoplasma positive, wherein actually the virus was responsible. So give respect to that. So if PCR is not available, of course serology, but that will be in the second week of the illness. Cold agglutinins, a simple line is a big no. Let's forget about it. Cultures, in my 30 years of practice, I have yet to come across a single mycoplasma positive blood culture. So that's why I don't rely on that. But what is new? This is exciting. IgA serology. We have always talking about IgM and IgG, but now this is the latest, last 2 years, everybody is talking about this. This IgA antibody, it disappears early. So if a child who has a recurrent infection and you do combined IgA plus IgM, then you have, it is as good as PCR. Again, the point is no single plex PCR. So multiplex is 15,000 versus a serology of maybe 1,000, 1,500. It gives a much better picture. Of course, it is not yet freely available. The point immediately for diagnosis is a IgA plus IgM for mycoplasma will be a better thing to have in near future rather than a PCR. Okay, so what is the role of film array after these 3 cases which I talked about? People say it keeps shedding, so you may have persistent positivity, true infection versus carriage. So remember, if you grow a human metapneumovirus, if you grow an influenza, a parainfluenza, or a respiratory syncytial virus, these are true indicators. Never consider them to be colonizers and disregard that report. So these are grown. Do give respect to the film array report. ICU, NICU, it does have role. In community practice, in day-to-day OPT management, I need not do this test. So immunocompromised, chronic debilitating patients, local outbreak and isolations, unknown organisms, yes, let's do this, use this test. And there are certain patients who can really afford, so that time we need not think about 15,000, 12,000 cost. But remember, the only negative point of this is a rhino or enterovirus, it cannot differentiate. So the report you will get is rhino stroke enterovirus, so it all depends on you how to interpret. So this is the only negative point. Let's move on to CNS. 4-year-old child, fully vaccinated, fever, headache, and vomiting, a typical case of acute bacterial meningitis. I have started considering that it could be resistant ceftriaxone and vancomycin. Now I have taken extra CSF sample. I'm waiting. Gram-Stain has not shown me anything. Cultures have also come negative, but then I have this test available. Binax now streptococcal pneumonia antigen test, which comes positive. The questions which come across my mind, how much I should pay weightage to this test, how useful is a latex agglutination? Recently, we have stopped talking about it. Can it be a false positive antigen test? So let's see. And of course, this also comes there also. So film array meningitis encephalitis panel is also available. So can I use, all of us know that encephalitis, this is an excellent test to have. But even in meningitis, can I use this array? So this is, let's see. So this is an excellent paper published just as late as April 21, validating the usefulness of this test, especially with Binax now, pneumococcal antigen test. It gives a good, assistance to a diagnosis if you have not grown in culture. Because the time taken for identification, autolysis and prior antibiotics, these are the three important points for which you will not be able to grow Streptococcus pneumonia in CSF. Even if the patient has taken single day of antibiotics, there is a problem of, culturing S pneumonia. But if you have this antigen test which has come positive, do give weightage to that. So in meningitis, latex agglutination, we said, no, it cannot be written off because some of the tests, again, have a very good sensitivity of about 70%. It is much cheaper than BioFire. Again, only 3-digit cost, not even 4-digit. We have 3 organisms, right, for meningitis. S pneumoniae, H influenza, and Neisseria meningitis. H influenza, fully vaccinated, unlikely. Older children, we don't think of. In meningitis, we don't suspect much, not that common. So ultimately, it all boils down to S pneumoniae. So probably, I think we will have utility of this test because if this antigen test comes positive, you have at least an organism which is grown in front of you. You can confidently continue the treatment that this is S pneumoniae. And more importantly, these patients, you will not use BioFire. So if test comes negative, you may use a BioFire for panel of diagnosis. The points about S pneumonia antigen is it aids in the diagnosis of pneumococcal meningitis, but there are some false positives. There is a group called as Streptococcus mitis, which can be, but then clinical correlation, and we do not grow it so often. Patients who have received vaccine, we just know about vaccination is so important, but then for 48 hours the test can remain positive. So please do not do this Streptococcus pneumonia test in 5 days after giving the vaccine. Samples from patients taking antibiotic for more than 24 hours can be a false negative. But mind you, it has 100% sensitivity. So excellent test, if possible, do it. Now let's move on to 4 minutes. So acute encephalitic syndrome, wherein we need to have something growing. So this is a typical case, 13 months old child, previously normal, has come with status epilepticus and ultimately found to have acute encephalitis syndrome. How should I go about it? I have 360 cells in the CSF, 90% lymphoprotein, 190. MRI done is non-contributory. Any utility of BioFire over here? Yes. It does have excellent utility in acute encephalitis syndrome. It rapidly detects a panel of common viruses, bacteria, fungi associated with meningitis encephalitis. So great thing. Never disregard a report grown on BioFire in a case of acute encephalitis, but do not use it as a CSF replacement. CSF always remains a gold standard, and the culture, fungal, bacterial, whatever is grown over there, if it comes positive, nothing like it. But then cryptococcal antigen, I'll just come back to that. A negative result, mind you, will not rule out meningitis or encephalitis due to infection. So use only validated. We usually talk of conflict of interest. We never take names of antibiotic brands. But here I have been talking right from word go about BioFire Filmary, because that is the only company which is validated by FDA. There are 2-3 more which have already entered Mumbai. I'm sure they will be coming everywhere. But right now, mind you, they are not validated. So even if the brand of Binox now or BioFire, these are reputed companies. So if you are going to use, if you are going to spend 15,000, I have nothing to declare. There is no conflict of interest. But this is the only kit which is very much reliable. What is the limitation? CSF BioFire. The measles, the mumps, the dengue, the mycoplasma, the JE, rickettsia, rabies, influenza, EBV, TB, it is not at all there. And we know that they are extremely common in our day-to-day practice rather than some other organisms. Now, if I grow HHV6, if I grow human, herpes simplex or VZV, it could be latent infection. So kindly remember that, interpret the positive report very cautiously. And finally, a word about cryptococcal antigen. The antigen test is much better. Even though we have this multiplex Pcr giving you cryptococcal antigen, but do not rely, and antigen becomes a much better, which is much less sensitive. I'll take just one more case, try to do that. This is a much commoner part, extremely common in our day-to-day practice. In fact, Monday morning, this will be the first patient that you will be having. A 4-year-old child has high fever, throat pain. He has tonsillar exudate, strawberry tongue, just palpable spleen, jugulodigastric lymph nodes palpable. So I am dealing with tonsillitis and scarlet fever, EBV, or is it just Kawasaki coming out? Is it a clinical diagnosis? And what is the alternative? I'm sure all of you, like me, rely on clinical diagnosis of a streptococcal pharyngitis. We do not do test. But what does the science say? So this is a test which is available, a rapid test. Can I use it in my day-to-day practice? So this is a strep A diagnosis which is available. The cost is only 80 rupees. So here the cost doesn't come at all. But you and I use this modified Centaur or Micazek score. We use it and we categorize the patient. Even the US does the same. But the point is, should we use it in some of the patients? What is the utility of this test? No, only single large published data I found was from Dr. Balasubramaniam in Kancha Kamakoti. He is very aggressive, speaks very strongly on all forums about the utility of this test. What does he say? He feels that the sensitivity is 89%, specificity is 98%. Excellent. But if you talk to some other ID experts in the country, they feel this cannot be a rule-out test. So ultimately, the aim of everything is antimicrobial stewardship, right? So if it's a viral, if it is not showing something, I'm not going to use my amoxicillin also. But then some others say its sensitivity is not that great. I'll come to that also. What is the final conclusion? So the throat swab culture is considered as gold standard for this community setting because of lack of laboratory facilities. This is a point of care test which some people feel should be used, and it will use, because if the sensitivity and specificity is so great at a cost of 80 rupees, why not do it on every patient that comes to our OPD? And this is finally which I found after a literature search, that this is a huge Cochrane review, which is after doing 594 citations, this search has been done, published in Canada, and of course American Academy also uses this. One of the authors is Banerjee, so Indian person has also contributed. So what is ultimately the rapid test for diagnosis of group A review of diagnostic test accuracy, clinical utility, safety, and cost effectiveness. That is what you and I want at the end of the day. So this is a take home from that. It says, it appears that even if throat culture assays are replaced with other assay for detection of group A strep, it may still be necessary to maintain cultures to antimicrobial, because you need a susceptibility test. So you cannot replace cultures. That is one. The point is, there are PCR assays, the quantitative PCR assay, it cannot differentiate between DNA obtained from viable or non-viable organism. That is point number 2. And finally, it also appears there are no tests to distinguish between a carrier and a true infection. So ultimately it comes to, I think, the age-old teaching of using our clinical acumen, going by the clinical standards and making a diagnosis. I think after a couple of years, after seeing 100 patients, everyone is tuned actually whether it is a viral, and you can take time. There is no need to give the amoxicillin also right on day 1. You can call the patient on day 2, day 3, get confirmed about diagnosis of streptococcal pharyngitis on clinical parameters rather than using the test. But if you want to use it, you have all the reason, and the science also backs up with this. I think the time is up. Oh, I'm sorry. I think I should stop at this place because the time allotted was only 20 minutes. Okay, thank you very much for your patient hearing.
Thank you, sir, for this very informative session. I would like to request Dr. Kanak Singh Surma to felicitate Dr. Upendra. Sir, I would request you to proceed to the... Next, we would like to invite Dr. Baldev Prajapati to deliver his session on non-traumatic coma. Dr. Baldev is the HOD and professor of GCS Medical College Hospital and Research Center, Ahmedabad.
Good morning, friends. Let me express my gratitude to these organizers and friends of the SPECT for giving me this opportunity. The topic allotted to me is non-traumatic coma. And this is an institution where I'm working and enjoying learning the pediatrics. Friends, before I start this coma, let me take to you some basics of the science. First, what we mean by the consciousness. Actually, consciousness is defined as the state of awareness of external as well as internal milieu, in simple to understand. That means there is an awareness of self-environment. And please remember This consciousness has the two components. And as a clinician, when assessing the patient, we should know that there is a wakefulness or arousal stage. There is a sleep cycle, which physiologically all of us have, day and night. And that is regulated by ascending reticular activating system, which is very important component in the CNS connected to the diencephalon. And all of us know that when it is get disturbed, very classical example of hepatic coma, it's an early sign of this coma. And awareness is something different, where it requires the functioning of both cerebral cortex. An absence of this cycle, as I said, is very classical indicating the stage of coma. When we are evaluating this for the awareness, please remember, in the younger the children or the infants, we can't go to orientation of time, place, person, as my residents are mentioning in 2-year-old child. We should know that the awareness of its daily activity, eating, sleeping, playing, interacting with other children, I think these things are very important when we are assessing regarding the awareness of the child. When there is the impairment of the consciousness, how we assess? As I said, that the drowsiness may be the physiological. In some of the, I will say, good lectures, or even after the heavy dinner or lunch. But with the CNS involvement, it is arousable with just light stimuli and is responding for some time. While the next stage is the stupor, as soon as you remove the stimulus, person goes to the original status. And still more impairment, there is semi-consciousness, that means non-specific response, and no response at all is the unconsciousness. And when the unconsciousness is for than 1 hour, we call it the coma. I'm sure this is distinct, this stages differentiation will guide us for proper management. One more stage which I would like to remind you, that after this coma, when the patient recovers, does not die but recovers, but with this persistent vegetative state, here after the recovery may return to a state of wakefulness but without the cognition. And here there is the presence of the sleep cycle with this maintenance of the functions of hypothalamus and the brainstem, but there is a loss of the cortical functions. And all of us know that it's very difficult. Sometimes the person can live for the very long life in this particular state, and it's very difficult to maintain for the family. Having this now, let me take to you this non-traumatic coma in the children. Friends, all of us know that following the trauma, road accident, some injury, the coma develops to the child is quite different entity. And probably here I may not touch it. But with some other medical conditions, and that is particularly the vascular, which may be the arterial ischemic stroke, or even the sinus venous thrombosis, probably not uncommon in the children. And if you are aware, it requires very prompt, I will say, workup, which makes difference in the outcome. Maybe the hemorrhagic stroke following some vascular malformation, mass lesions, tumors, abscess, tuberculoma, hematoma, infections, bacterial meningitis, TBM, vasculitis, even brain abscess, even post-seizure starts paralysis, we know. Immune-mediated conditions are not uncommon. On the contrary, coming up, and if you are not aware, probably we are not able to reach the diagnosis like ADM and even the NMDA receptor encephalitis. Further, if I take to this hypoxic ischemic encephalopathy, very classical in the newborns, or even near drowning, and I think carbon monoxide poisoning in the gas seizure. Gas geyser is not uncommon. Probably particularly in the bathroom, the gas geyser is kept, and suddenly the person is found unconscious. I think that we should keep in mind following carbon monoxide poisoning. Metabolic conditions, hypoglycemia due to different reasons. Hyponatremia and hyponatremia. Please, friends, remember that hyponatremia, sometimes we do not know in the PICU patients, but they die of this hyponatremia. And if I remind you that why the isolate P is removed from the intravenous fluid therapy in the pediatric practice. In one of the studies in America, they found that following the simple surgery, like hydrocele hernia, just due to this improper fluid, isolate P, they lost several children due to the hyponatremia. That was the alarming point. From that we were stimulated and we studied, we understood that yes, this is the killer. So please, I think post-operative, if you get any patient deteriorating CNS point of view, please check the glucose and the electrolytes. Even acidosis, SIDH, diabetes insipidus, not uncommon. Sepsis, all of you know. Even sometimes the cerebral malaria, fortunately since last few years it has come down, but rickettsial disease has come up. And even the toxic shock syndrome as a, I would say, newer form of the infections, particularly the staphylococcal and streptococcal, that we'll have to recognize. Even this ADM encephalopathy, which I was talking, drugs, even the toxins, systemic disease like hepatic encephalopathy, uremia, diabetic ketoacidosis not uncommon, race has gone down, metabolic disorders, yes, and even the autoimmune disorders. I'm sure that these are the most common presentations of this coma in our daily practice. Here, what I want to share with you or emphasize as a clinician, most of the times we are talking as the teachers and the clinicians that go in the details of the history, come to the conclusion, then start the treatment. But here it's not so. We cannot. We have to do both the things simultaneously. And therefore, what is the best approach? That acutely and hyperacutely ill children, you know, hyperacute, that means within few hours, the child is found some deteriorating. On acutely, probably may take some days. And here, once they present with the coma, what we should do? It may be the primary neurological disease itself, or really coma is extended due to some other disease, maybe the secondary injury. And the basic cause may be the hypoxemia, hypoperfusion, or some metabolic derangement, which I was talking, hypoglycemia, or even the dyselectrolytemia. Here, I think is a considerable impact on eventual this outcome. This is very, very important. As a clinician, I think you have to work very promptly. Even continuously, you may ask some points of the history, examine the patient, and start the management. Everything should go, I think, simultaneously. Here, we cannot take the time as we are doing in our OPD work. And that approach particularly focuses on immediate this preventing and minimizing the injury to the patient. Therefore, it is very important, this stabilization. And next time trying that exactly what's the cause so that I can manage the patient successfully. Having this immediately, I should go for this evaluation of the cerebral cortex and the brainstem. I may go for the AVPU or Glasgow Coma Scale and pupillary examination. I think these three components are very important. Promptly, within few minutes, you'll be able to decide that which part of the CNS is affected and what you should do. And all of you know the AVPU. I may not go in the details. Even you know the Glasgow Coma Scale, which everybody should, I will say, translate in the practice, and daily Glasgow Coma Scale in the unconscious patient put on the paper. That will give you the idea whether the patient is improving or deteriorating, and accordingly you can change your further planning. Pupil examination, I think, which we were taught in the undergraduate, even in the era of modern facility of the investigations, CT, MRI or anything, still it is very, very rewarding and important in our clinical examination. We know that the pinpoint pupil with fever which is not responding, it's definitely pontine damage. And small pupil, I remember one of the patients in my round, child was unconscious within few hours. When I came to know that the child was given this Somva Chaudhry's because child was irritable and crying by the older sibling. And on investigations, first time we came to know with the constricted pupil that yes, it was the opium which is there in the Somva Chaudhry's which was responsible for this poisoning. So I think that's rewarding. Further, even the mid-size and dilated pupil and everything we should keep in mind. Emergency management, what immediately we should do? Assessment and stabilization of airway, breathing and circulation, as all of us know the basics. Glasgow Coma Scale, if it is less than 8 on, I will say, arrival of the patient, of the airway is not maintainable, immediately you should go for intubation and mechanical ventilation. I will say it is life-saving. Stabilization of cervical spine is very important. Many times I think everybody is in stress and hurry and they are losing. Even the movement, improper movement of the child will cause the damage to this part, especially following the trauma, and which may be responsible for even the death to the child. PO2 should be maintained. Quick establishment of the vascular access is very important. According to pulse, if you know in such patients, if I get the vein, but after the 15-20 minutes, it is useless. Go for the 3 attempts or 90 seconds. If not possible, go for the intraosseous. If not possible, go for the central line or something. But don't waste the time. I think that's very important message which we should keep in mind. Accordingly, you can go for further management. Hypoglycemia, of course, very important, and it should go for these 25 or 10% dextrose with the proper doses. Correction of electrolyte imbalance, I think, again, very important. I have seen in the intensive care units that many a times the disease for which child presented remains aside. And many a times the problems and complications is responsible for the death or deterioration. Most common is either the hypoglycemia, acidosis, or dyselectrolytemia, especially hyponatremia or even hypernatremia. And I think that is very important that all of us should keep in mind. Control of seizure is very important. Seizure is always causing the permanent even further damage to the brain. So its efficiently control is very important. Raise ICP is very important. Very simple points. Keeping the head in the midline, just raising by 30 degrees, hyperventilation, then sedation, and if requires intubation and this hypertonic saline. I'm sure simplest measures, I'm sure successfully, as Dr. Singhi has mentioned in his work in this raised intracranial pressure, that these features, these parts of the management works very well. Consideration of toxication. I think Dr. Mahesh Mohiti has very wide experience of this toxicology. And he has got several, I will say, examples of his case series. That once the patient presents unconsciously, you don't have the answer, go for the investigation for the toxicology, and to our utter surprise, we are learning more and more toxins which are common in the pediatric practice. Deciding the next component, as I was talking, the first stabilization. Next, how I should decide the cause. And all of us know that here also, history and examination. History of trauma, seizure, stroke, poisoning, as I was talking. Fever, headache, vomiting, we know infection. Seizures, maybe the status epilepticus, or poisoning like carbon monoxide, organophosphorus, or some others. Drug and intoxication, very important. And recent immunization and this problem, maybe the ADM-like presentation. Suppose if the patient is suffering from jaundice, the hepatic encephalopathy, maybe the hypoxic encephalopathy, maybe the dyselectrolytemia, dehydration in a case of diarrheal disease. Dysentery has somehow come down, but yes, that we'll have to keep in mind. And of course, the common metabolic diseases, diabetes mellitus, renal failure, liver diseases. Family history of sibling deaths is very important, that may be the metabolic disorder and suffer with the sudden infant death syndromes. And residence of the child from where the child is coming, either from the rural or the urban area, and endemic to the cerebral malaria, rickettsial, or Japanese encephalitis, or even the Kala-Azar, I'm sure that this information is also quite useful. Examination point of view, we know that the fever is indicating so many reasons, which all of you are aware. But if the child is hypothermic, please keep in mind hypoglycemia, adrenal crisis, or even the drug intoxication, which is very important. At the same time, tachycardia, probably hardly will go for the counting the pulse rate. If not counting, please look at your monitor. And if it is really tachycardia, various reasons may be there. It is said that the earliest sign for the shock is the simplest tachycardia. If you don't have the answer, I think that's a point for the clinician to consider that's a hypoperfusion. Maybe the cardiac failure, arrhythmias, and later on the if really bradycardia with the CNS involvement, always keep in mind the raised ICP. And suppose with irregular respiration, that pinpoints to this brainstem problem. Of course, intoxication, we are not measuring the blood pressure is another drawback in these critical patients. And if it is hypertension, which may be the transient one, I think recently just Thursday PG clinic what discussion, which was hypertension was missed, turned out to be hypertensive encephalopathy in an unconscious child, and at the end it was the case of SLE. So I think this is the thing that how we are coming to the diagnosis with the simplest parameters. Hypertension can be to several regions, which all of you are aware. Of course, pallor, if the attention drawing, maybe the cerebral malaria, intracranial hemorrhage, HUS is now totally down. Of course, jaundice, rashes are very important, particularly the meningococcal, rickettsial, and dengue, and even this DIC. Look at this, some head and scalp markers, maybe the hydrocephalus, AF full, that means some raised intracranial pressure, either the bacterial meningitis or something. Neurological examination and details. I think all of us are knowing these points, but I'm very sorry to say that this part is lacking. And particularly when the patient is critical, when the patient is in the intensive care unit, when you are fully aware that the problem is of neurological, but hardly people have put these findings on the case paper. Just my request that I'm sure that you will get the rewarding. Go for the level of consciousness. Glasgow Coma Scale is not for writing the short note in the MD examination. It should be translated in our daily practice with the impairment of consciousness and go daily assessment. That will give the idea whether the patient is improving or deteriorating, and next plan you can prepare. Brainstem reflex is very important. You can simply from the examination, not all else a CT MRI will be able to diagnose. Unconscious patient, convulsions, irregular respiration, multiple cranial nerves, injury should be at the only brainstem. And I'm sure that this examination is quite rewarding. Of course, the motor response, other thing you should go. Simply, doll's eye examination, it is say that that brainstem injury you can diagnose from that. Decerebrate, decorticate rigidity, all of you are aware. I may not go into the details. Decorticate rigidity is called rewarding simply. I understand that the patient is going to recover without much even the sequelae. Decerebrate, I am not sure whether they recover, and if at all, probably sequelae will be the very maximum in this patient. Though the simple examination is quite rewarding. Type of respiration, all of you know, just to save the time, I don't go into the details. CT, MRI or LP, this is the big question to this clinician. I think afebrile child with deep coma and focal signs, CT scan is quite rewarding. Particularly when you are suspecting the stroke, they say that the first investigation should be the CT when it is available. Of course, tumor, hemorrhagic abscesses will be CT is quite rewarding. Febrile child more than 1 year, AF is close, and Glasgow Coma Scale is less than 12. I think empiric antibiotics and antivirals, lumbar puncture you can decide later on after this papilledoma examination. And if less than 1 year old child, straight away we can go for this lumbar puncture. Of course, MRI is quite important, even more than CT in specific conditions like encephalitis and if the posterior fossa lesions are suspected. Neuroimaging, as I was talking, the CT, particularly often the first neuroimaging, especially with the presence of focal signs and raised ICP, more value in detecting the mass lesions, hemorrhage, hydrocephalus, and even the skull injuries. Contrast study is very important, particularly for the meningitis, brain abscess, and NCC. MRI is superior to CT, particularly in the stroke, encephalitis, ADM, and an MDR, encephalitis. Laboratory investigation should be planned as per your, I will say, suspicious clinical diagnosis, not blanket covering all. And that basic first, then second tier you can decide as per your possibility, treatment point of view. As I was talking that here we cannot go for detailed history and examination, investigations, and then I will start the AKT. This is not the time. Simultaneously, promptly, everything should be in hand to hand. Treatment, as I said, clinical evaluation and management. Emergency management and stabilization is quite important. Febrile encephalopathy will not wait over here. Start the ceftriaxone. Acyclovir I will have to start. If cerebral malaria is possible, even artesunate you can add. Suppose in the Surat when it was very bad, falciparum era. rickettsial disease, if you are suspecting the patient is from Solapur and deteriorating very fast with the skin lesions, yes, you can go for the empirical doxycycline. As already Dr. Upendra was talking, mycoplasma a clinical diagnosis. I think you can go for the trial of azithromycin. This is especially when the patient is in, I will say, PICU or serious critical situations. This is not for our office practice. Friends, please keep in mind. Antidotes was very specific for the toxins, which can keep in mind. Steroids, very specific conditions, ADM, meningococcal,
Sir,
with the shock, antiencephalopathy, autoimmune, and metabolic. I think identification is very important with the diabetic cases, hepatic encephalopathy,
wrap
etc.
in sometime, sir?
In short, this is algorithm. Identify and treat the aggravating factors. Seizures to be controlled first. Please, I am in the last slide. Fever, pain, anxieties to be controlled. Go for this Glasgow Coma Scale, CT, MRI, as I say. Go for the other investigations and consider the specific treatment which already we have discussed. Thank you, friends. Again, thanks a lot for giving me this opportunity.
Thank you, sir. I would like to request Dr. Keori to felicitate sir. For the next session, I would like to invite Dr. Chetan Shah to deliver his talk on completing the circle of DTP vaccination. Dr. Chetan is the chairperson and chief pediatrician of Anand Children Hospital, Surat.
So, good morning everyone, and at the outset I thank the organizers for inviting me to deliver this talk, and this is a disclaimer is that there are no economic grants or financial transactions have been involved, and there is no conflict of interest. So basis of this, the topic is DTP vaccines as a part of primary series and boosters. Now of late, there is a change in the epidemiology which has necessitated ACVIP to come forward with new recommendation, particularly pertaining to three important parts of the hexavalent vaccines. That is, one is hepatitis B, another is intramuscular polio, that is IPV, and third is, of course, in the DPT section of the hexavalent vaccines. And the most important changes are hepatitis B can be given additionally in combination of hexavalent vaccines, even in extra doses. That is one. Second is that full dose DPT should be given at the age of 4 to 6 years. And third important is that DTAP, that is this tetanus and TDAP can be given in place of DT after the 7 years of age. Every 10 years also the repeat DT that was suggested can be given as a TDAP. So these are few of the things, and this includes another extra IPV, that is total 5 doses of IPV at the age up to age of 5 years. So these are the few of the newer changes that have come up in the recent ACVIP recommendations. And there are some data to support it. There is a clinical data which is showing that there are high GMT titers against key antigens with fully liquid form of ready-to-use hexavalent vaccines in Indian registration study. These are the studies which were conducted in our own country, and it shows that high GMC and GMT titers against the key antigens of the hexavalent vaccine, that is the pertussis toxin, polio 1, polio 2, 3, all three polio variants, and hepatitis B surface antigen and Hib. All three, the fully liquid vaccine which was ready to use gave very high titers, and as all of you know, high titers is a reliable parameter for vaccine performance. And a higher level of GMC or GMT, it gives a sufficient immunity against subsequent exposures, and it may result into a disease which is less severe, which is mild disease or a no disease. So one is the reduction in the severity of the disease or disease burden, and another is that a higher GMT, GMC titers will give them a longer immunity. So immunity also will take time to wane, and it may result in longer duration of protection. So there is a direct correlation between the titers with the protection as well as the duration of the immunity. Regarding hepatitis B portion, this liquid hexavalent vaccine from Sanofi hepatitis B has been produced in a specialized plant in Argentina with a highly controlled environment, and is compliant with the European Pharmacopoeial Monograph, as well as it is produced exclusively for use in fully liquid hexavalent vaccine. And the most important the vector here is Hansenula polymorpha, which is a yeast form which acts as a antigen presenting site, where there is RNA sequencing going on, just like in our Covishield. This acts as a this vector, and there is advances in the molecular genetics. Due to presence of strongly methanol-induced promoters as well as less glycosylation with human glycoproteins, and this has led to there is an increased antigen presenting sites in this particular vaccine, which leads to higher antibody production against the organisms. And extremely high titers are produced as compared to any other hepatitis B antigen system, as evidenced in the clinical studies. So there is a robust response against hepatitis B antigens with this particular vaccine. There is another data which shows that co-administration with the other vaccines. We in primary immunization, we want to co-administer the same vaccine at the one visit, means the hexavalent along with, we want to give with the rotavirus vaccine as well as pneumococcal vaccine. So how much it interferes with the effect of the other vaccines. And what it shows is that co-administration data with pneumococcal vaccine, rotavirus, meningococcal has been studied extensively with hexavalent liquid vaccine, and co-administration did not adversely affect the immunogenicity of any primary series vaccines. Against this, there is no co-administration data available for the wholesale hexavalent pertussis vaccine, and there is another hexavalent vaccine which needs reconstitution. Here, if you see, there is an inconsistent antibody response to poliovirus type 2 with PCV10. That is, again, there is a lesser response to polio type 2, and increasing reporting rates of conversion with PCV13, both in clinical studies and post-marketing reports. So there are some reports with the vaccine that is requiring reconstitution with other vaccines. So there are definite importance and benefits of ready-to-use vaccine, because it does, gives specific advantages. It decreases the time to perform vaccinations, reduce wastage, reduce occurrences of handling errors, reduce health hazard, cost reduction, and preparation in half the time. So there are some of the advantages whenever you are using a liquid ready-to-use hexavalent vaccine. Now there are some of the studies which shows the importance of full dose DTP vaccine, full dose hexavalent DTP vaccine along with the IPV at the age of 4 to 6 years. And if you see the titers here, this was a primary immunization done with the hexavalent vaccine in liquid form, and there is a robust response whenever you give booster at 18 months of age. So this is a response which is, a robust response after you give booster doses following the immunization with the hexavalent liquid preparation. So there are a review of 16 years clinical experience with combination vaccines have shown that pediatric combination vaccines such as DTAP, IPV and PRPT, that is HIB, provide the opportunity to increase compliance. So if you give all the vaccine at a single call or single visit, it does increase the compliance because our vaccine schedule as such is quite crowded. So this additional, covering all the vaccines in one visit gives a advantage and it reduces the visits to the hospital. The pentavalent acellular vaccine has a seroprotective immunogenicity proven in clinical studies and effectiveness proven in large-scale surveillance studies and reduced reactogenicity compared with the wholesale pertussis vaccines. And inclusion of inactivated poliovirus is an important context, the shift away from oral polio in the post-polio eradication area. So, as I told you in the beginning, our new schedule shows a full dose DTP vaccine as per recent epidemiological analysis. And this shows that full dose vaccines represent today's standard of care as booster dose at the school entry. With the limited data on immunogenicity and effectiveness for low dose DTAP available, it is questionable whether there is sufficient evidence for use of these vaccines as replacement for full dose DTAP and IPV combination, which is available at present as in the form of tetraxim. So, these are suggested as a booster dose in 4 to 8 years old children in Norwegian and Swedish vaccination schedule. And even our own ACVIP has recommended full dose DTAP with IPV at the age of 4 years. So new ACVIP guidelines and their significance for DTP combination vaccines. So if you see, India remains a nation with one of the highest burden of tetanus, diphtheria and pertussis in spite of widespread DTP coverage. So if you see here, tetanus, almost highest number of cases in the world, diphtheria second to Nigeria, and pertussis also almost highest number of cases in the world in our country. So naturally we want to protect all our children against this, and as you know, as the age advances and the primary immunization is complete, later on as the immunity wanes, there are more chances of this disease shifting to the adolescent and elderly population. So we need to protect all of them. So this is the immunity against diphtheria among children aged 5 to 17 years, and if you see, it is waning over a period of few years. So pertussis estimates again shows very high incidence here. So diphtheria, pertussis and tetanus can be a burden at any stage of life. They are all life-threatening illnesses and they are recently reported across the world, and disease also circulates and can be transmitted across all age groups. Adolescents and adults represent the largest number of pertussis cases, and individuals are believed to become susceptible to pertussis approximately 6 to 10 years after the childhood vaccination. And this is the ACVIP new schedule, which shows, if you see here, first booster is 5 vaccines. You can add hepatitis B here, there is no problem if you give a hexavalent vaccine here. At 4 to 6 years, this is a major change, full dose DTAP vaccine along with IPV. And after 9 years also, there is a recommendation that reduced dose TDAP can be given in place of TD. And similarly, every 10 years repeat boosters also, DT can be replaced with TDAP. So again, as far as our polio status is concerned, we have eradicated polio. We are giving bipolar oral polio vaccine at present. So there is no type 2 polio being given over a period of, say, last so many years. So naturally our population has been against type 2 polio. There is a naive population which may not have any antibodies. So our purpose of not giving type 2 was that type 2 was responsible for most of the CVD patients, and that we want to protect this type 2. So just to avoid that, we stopped giving the type 2 polio vaccine. And just to cover them, we want to give IPV to all the Indian children. Moreover, India has a long border with Pakistan, a country which is still endemic for wild polio virus type 1. So we want to protect our children against the wild polio as well as the type 2 polio. And here comes the role of IPV, where we want to protect by giving IPV, and that is why our ACVIP has given the verdict of giving at least 5 doses of IPV in our immunization schedule. So even if you see, the Afghanistan still in 2021 also has wild polio type 1 case, 43 CVDPV type 2 cases. 2020 had almost 308 cases of type 2 VDPV. Pakistan also has, type 1 polio wild, and then 8 CVDPV cases in type 2. So these are the still countries in our neighborhood which are carrying the virus. And even in 2021 till 20th October, there are 333 CVDPV cases type 2. Similarly, 12 CPDPV type 1 and CVDPV. So type 2 still remains the most common type causing VDCPV. So just to cover this, our ACVIP guidelines 2021 shows that recommendation of a booster dose of IPV at 4 to 6 years of age for children who have received the initial IPV doses as per the ACVIP IAP schedule. Studies examining the long-term persistence of antibodies following the IPV vaccination has shown that it only up to the school entry level the antibodies are persisting. Then it goes declining. So with the highest titer were observed in the 3+1 schedule, as all IPV using countries recommend a school age booster. A preschool booster resulted in the seroprotection rate rising to almost 100% for all 3 serotypes, and GMT is rising 32-fold to 55-fold. So this is the justification of giving a IPV dose at the school entry. And following the preschool booster, almost 100% seroprotection and high antibody titers which persist for at least 5 years. So this is the basis for our 5-dose schedule recommended for IPV by ACVIP. So new Tdap vaccine recommendation, a full dose of DTaP, IPV vaccine to be given at 4 to 6 years of age. The recent changes in recommendations regarding the adolescent vaccine, Tdap usage and boosters. So there are some changes which I told you in the beginning, that the advisory committee of the Centers for Disease Control and Prevention has voted to allow Tdap to be used in 3 situations that typically call for TD vaccine. So instead of TD, now Tdap has been recommended. So decennial, that is every 10 years booster, which we are recommending to be given as a TD, has to be replaced by Tdap. Tetanus prophylaxis for wound management for people who previously have been vaccinated with Tdap and are not pregnant. Catch-up immunization for people 7 years and older, regardless of pregnancy status. So what our ACVIP says is that in a current ACVIP recommendation, 9 to 14 years is the recommended age, and 15 to 18 years is the catch-up age for Tdap. Tdap should not be administered as a second booster of DPT at 4 to 6 years, and instead it should be full dose DTaP vaccine. For delayed second booster, TDAP can be given after 7 years of age. And a dose of TDAP is necessary at 10 to 12 years, irrespective of previous TDAP administration. So many of the patients, they have lost to follow-up, and they come at 10 years or 11 years. There also at least one dose of TDAP is necessary. If TDAP is unavailable or unaffordable, it can be substituted with TD. So people of all ages need to be vaccinated with DTP vaccines and keep the circle of vaccination intact. So DTAP for 6 to that is primary immunization, first booster, and 4 to 6 years. So second booster also should be full TDAP. TDAP for preteens, so TDAP, that is 11 through 12 years, and TD or TDAP for adults. So this is the full cycle of new recommendation that has come up, and our ACVIP also has endorsed this. Thank you.
Thank you, sir. We would like to invite Dr. Bankim Jariwala to facilitate Dr. Chetan, sir.
We can take a couple of questions for the 3 talks. Neurodiagnostic tests in pediatric infections and non-traumatic coma. Anybody? Fine. Thank you very much. We shall move to our next very interesting session. It is a 1-hour symposium on early childhood development. To forward the proceedings, may I now invite Dr. Ketan Bharadwa, who is the director at Neoplus and is a leading private practitioner at Masoom Children Hospital, Adajan. He is the president of IYCF. Can you take the proceedings further and invite your panel and other...
Volume.
मेरा जो बचपन है वो ज़्यादा माताजी के साथ, पिताजी का नहीं। उसमें रोल ही नहीं था। पिताजी को बात करने का भी डर लगता था क्योंकि मारेंगे, गुस्सा होगे। आप बोल रहे हो आपके पिताजी गुस्से वाले हो और आप भी वैसे ही हो रहे हो। सेम हो रहा है। सोचा सही है, अपने को वो नहीं करना है।
कशी शौर्याची तब्येत आता? त्याच्यासोबत संवाद साधून त्याला स्पर्श करून आवाज आपण त्याला लगेच तिथं टोकतो, त्याला त्या गोष्टी करू देत नाही। म्हणून मुलांना आपण लहानपणी जर मनसोक्त खेळू दिलं, त्यांना रोकटोक केली नाही, रागवलं नाही, तर त्यांच्या जे चेतापेशा असतात मेंदूमधल्या, जे ब्रेन सेल्स असतात, तर ते असे दाट होतात।
तो वहाँ जाने के बाद वहाँ थोड़ा काउंसलिंग मिला। उसकी वजह से घर में है ना कोई भी आप चिड़चिड़ापन या झगड़ा मैं तू ये बातें होती ही नहीं।
So, before lunch, I'm sure that everybody would like the parents to be happy. You are all private practitioners, majority, and you would definitely like that your parents are satisfied maximal. And I assure you that after this session, you will have FOMO, fear of missing opportunity. That how early childhood development can be tailored and implemented, and how it can pay to you back. It is not only that it will pay to you back, but it pays to the society as a whole. And the government will also get aware with the evidence that if proper early childhood development is done through policies and everything, the cognitive potential of the country will increase by more than 18 to 20%. And that is a very, very big amount. And the fallouts of this cognitive potential, I am sure that in future years, the GDP of the country will increase a lot. Friends, we are thankful to UNICEF, Dr. Narayan Gaonkar, especially for seeding this point in our actions in last Rsv Pedicon. He insisted that we should work more on ECD. And that sprouted into a consensus paper on early childhood development. And then next year, last year, Dr. Piyush Gupta, Dr. Basal Raja and the whole team led by Dr. Digan Shastri has taken up a very big project for 3 years on nurturing care, early childhood development. So, in short, this early childhood development is nurturing the children in a way that they come out with their full potential as an adult. किसी ने कहा है, जिन चरागों को हवाओं का कोई खौफ नहीं, ये बच्चे हैं, जिन चिराग, ये चिराग है हमारे, जिन चिरागों को हवाओं का कोई खौफ नहीं, उन चिरागों को हवाओं से बचाया जाए. Let us all protect our children. अपना गम लेके कहीं और न जाया जाए, अपना गम लेके कहीं और न जाया जाए, घर में बिखरी हुई चीज़ों को सजाया जाए. That is very important. ECD is all about training parents and people and of course our government that we make our own home safe, sound and progressive. घर से मस्जिद है बहुत दूर चलो, यूं कर ले किसी रोते हुए बच्चे को हंसाया जाए. Friends, with this we are going to have a discussion, but then we thought that let us have some model presentations and of implementation of ECD. Now, after the sensitization last year, now we are into the phase of implementing. And so we have invited 3 level speakers for those who have already done this successfully. The first layer is in public health. We have got Dr. Arjun, who is AP in the PSM at Varda MIMS. I would call upon Dr. Arjun on the stage. Please take your seat. Then we have got second level hospitals who are implementing this, and we have got Dr. Gaurij Hood, who is consultant public health specialist and head of the Srimad Rajchandra District Intervention Center. Please come on the stage. We have got our own Iron Lady, Hema Binduji, and has implemented a lot in our tertiary care center. Please. And they will present their own short experience, and after that we will have a brainstorming with none other than our UNICEF friend Dr. Narayan Gaonkar. Please, he is health specialist of UNICEF Gujarat. Please come on the stage. And then we have our incoming Central IB president now, next 23 is Dr. Upendra Kinzhwadeker. Please come on the stage. And from the hosts, Dr. Digan Shastri, who is the mentor of the whole program and monitor also of the whole program, and he has envisaged the project Angan as an adoption of this ECD program. I invite him also. Please take your seat. And we have Dr. Swati Vinchurkar, who is a developmental pediatrician and who has backed up the whole scientific part of it, and she will also guide us on many aspects of ECD. So friends, we start with short presentations by Dr. Arjun. Please come.
We have Dr. Nilesh Thakur, OSD from RBSK, Government of Gujarat. Dr. Nilesh, are you there in the audience? If you are there, please take your seat.
હેલો સૌથી પહેલાં તમને બધાને અભિનંદન કે આપણા બધામાં એક વસ્તુ કોમન છે કે આપણે બધા માનીએ છીએ કે અર્લી ચાઇલ્ડહુડ ડેવલપમેન્ટ આપણા ભવિષ્યની પેઢી માટે બહુ ઇમ્પોર્ટન્ટ છે એન્ડ દેટ્સ વાય ઓલ વી આર હિયર. I will start with some kind of one stimulus I will want to give you right now. Just imagine કે એક 2 વર્ષનું બાળક અત્યારે વચ્ચે અહીંયા ચાલતું આવે છે, and in audience we have a people from the 25 years age group, 65 years of age group, everyone is here. What would be your first initial response? Just imagine, agar koi child is walking here in the middle path, what would be your response? We will like to engage with the child, right? You will smile at that child, yeah, you will make some faces, you will do something like that, you will like to grab the child. So what is it? What has made us to do that? This is the nature, this is the instinct we have inside us, because nature also knows that early childhood development, if it will be given to the child will reach to that full potential. So nature wants human being to, to achieve the full potential, and for that early childhood development is the key for that. So early childhood development is not a science, not a new thing. It is an instinct there inside us. Maybe we have forgotten that. So just here to brush up that thing. So we starting that we believe the philosophy ECD is there with us. It is an instinct of the nature. It should be there in our practice, and it was traditionally there in our practice, if you remember our grandparents and before that. So ARAMB is a model which was implemented by the Department of Community Medicine with partnership of UNICEF at MJMS Sevagram Vardha Medical College. We believe that early childhood development is right of every child, and we make a model which can be implemented at a large scale. So there is no need to tell what is ECD. I know you all are aware what is a nurturing care framework. So this is our model, which we name as ARAMB. ARAMB means starting of ECD, as well as ARAMB is ARAMB per life. So there were mainly 4 pillars. We make a strategy for customized messaging. We make a strategy for peer learning. We make a strategy for community norm building, and strategy to use the available opportunities at health facility levels, which will cater early learning, adequate nutrition, responsive caregiving, good health, safety and security to the child, while making the appreciative inquiry as a key thing, skill building, supportive supervision, community mobilization and intersectoral coordination. So where we have reached with our model. So I am here presenting our training module of the ARAMB. So we are only 17 people at MJMS Sevagram Medical College. But we try to make our model so simple that we can reach to the every child, not just to the Sevagram. So 17 project team has trained nearly 100 supervisors from the 2 districts. They 100 supervisors trained the 3,000 Anganwadi worker, and they reached to the 15 lakh population of the 2 districts of the Maharashtra. So that was our very simple model, and the dream which we have seen that we want to reach the each and every child, not just the child of Sevagram. So ECD activities started our department in 2012 with 10 villages, then we reached to the 1 lakh population in 13-14, they reached to the 15 lakh population in 18 and 20. We demonstrated it, and now I'm happy to say that Government of Maharashtra Health and ICDS Department has adopted our model, and it is now scaled into the entire Maharashtra state. So now we are reaching to the 12 crore population of the Maharashtra. Right now we are sitting here. There are training is being happen with the same model which I have told you in the 6 to 7 district currently right now. So that was the dream which we have seen to reach to the every child of Maharashtra, and now I'm here advocating that every child of the India should receive the ECD package. So what our project has achieved. So these are some of the process indicators that you can see that the we have used the system. We use what is there actually. We haven't intervene some new post, new person. Asa Anganwadi is already there. We just train them with some newer technique with the incremental learning approach. So home visits were increased, the mother response increased, responsive parenting increased. These are the process indicators that you can see. These are the impact indicators, stunting, wasting, and the most significantly development quotient also increased in our field practice area. So it is possible, it is doable, and it is important. So these are the key learning out of our model. Now, these are the model is set for the community, right? Now, I understand that here, most of the people who are sitting here may be working in the private practice. So which learning I want to discuss, or which learning which I want to share with you, what we have learned out of our 10-year journey. So there are some facility level opportunities here. However, before that, I myself being doctor, with apologies, I just want to share that during our 10-year journey, the most difficult group of people wants to deal was the doctors. Doctors, whether it is MBBS, public health, pediatrician, don't believe in ECD. They simply said that we are struggling with the hi-fi problems, we have a hi-fi interventions. So we doctors are not meant to tell parents to touch your child, play your child. These are very simple things. But simple thing can be a solution of a complex thing that we need to understand. If you are still not agree, I am ready to bombard you with so many facts. This is the story of the Jamaica, very, very famous experiment. 129 child, 4 groups, 1 child given supplementation, 1 child given ECD, 1 child given ECD plus supplementation, 1 group was a control. Now, what was the result? Now you can see that the red line is for the normal child, which has achieved the full potential. Control, the blue line, middle 3 line is very interesting. Pink one is supplementation, in which we are focusing right now, has not achieved as good result as the only stimulation has achieved. Stimulation plus nutrition is yellow line. So now you can see that stimulation is sometimes more important than just focusing on the nutrition. It is not just for the 24 months. If you see the prospective study, when this child reached to the 17 and 18 years of age, that child has a higher reading capability, vocabulary, and IQ score. And even when the child become a 22 years of age, this is from the same cohort, that child has a higher education, learning, fewer fights and violent behavior, and a less depression and less inhibition. Not only that, that child become, now you can see the impact of that project. The child who received stimulation achieved more earning than the child who didn't receive the stimulation. Nutrition intervention had no impact in the later life. The child who has received only nutrition become the same, the child who didn't receive the nutrition intervention. So nutrition intervention is a very small thing that cannot have a larger impact when you compare to the stimulation. And if you compare the amount of money the child who were earning in the age of 25 to 30 who received the ECD was way higher than the child who has received only nutrition intervention. Be ready, there are more facts are there. If there is a child who has not received the responsive caregiving, you can see the blue line. The child who has received responsive caregiving, you can see the red line. It is just like the muscle building philosophy. हम जिम में क्यों जाते हैं? जिम में તમે જેટલી કસરત કરશો તમારા મસલ ફાઇબર એટલા તૂટશે તો તમારા વધારે મસલ ફાઇબર બનશે ને તમારું મસલ મોટું થશે. Just like that, બ્રેનને પણ સ્ટિમ્યુલસ જોઈએ. The more stimulus you will give the child, brain will make more synapses and brain will develop faster. Again, so many facts I can share with you. And if you are a businessman kind of thing, so this is the Heckman curve. Heckman is a Nobel Prize winner professor. He says you invest money into the ECD, matlab early years, it will give the highest return. But what we are doing that, we are investing money in the adulthood, which has a very low investment rate. So if you understand in the language of input output, so this is also the solution. Now you will say, parents, hamari baat kem maanse? Again, these are the facts you can share with the parents. Your child brain developed by the 5 years. This is the 90% of the brain is developed. This is the synapses of the brain that earlier child, there is a no synapses, but brain makes 700 synapses every second until 5 years, 2 years of age, which is as good as adulthood. मतलब 2 વર્ષ સુધી તમારા બધા synapses બની જશે. More stimulus will give, just like muscle building, more synapses will be made. This is your growth, vision, speech, emotion, math, logic, social attachment, motor development. It is start as the birth, even before the birth, but it must last more than 3 years, 5 years. So early intervention matters. You can show this graph. Normal child ka MRI juo, tame extreme neglected child no MRI juo. You can see the growth of the brain. You can also show the parents these images, and you have opportunities. In a waiting area, you can post posters like that. You can run a video. And ECD is again not a science. Even the nurses at your clinic can give a message to the parents. The most important thing, don't tell the parents what to do. Tell the parents why to do. ECD કેમ જરૂરી છે એ કેવું વધારે અગત્યનું છે. Rather than just telling કે touch your child, play your child, they may not be convinced. Just tell them why ECD is important. Your child may earn more. Your child may do good in your school. Your child may have a better IQ. Your child may have a better DQ. Then parents themselves make various approaches to touch their child, play with their child. So how we can influence development of child?
Sir,
we need to be
last 1 minute.
we need to be responsive. We need to convert our sensitivity to responsivity. Touch your child, talk with your child, play with your child. Only resource required is quality time. So we have our YouTube channel, RM, Early Moments Matter. You can visit our YouTube channel. There are multiple videos are available. If you are still not convinced with ECD, our video will convince you for the ECD. So you can go to our RM YouTube channel. And if you want some of the resource material, we have a training manual, IEC posters. You can just email me. I can share it with you. Use it. There is no copyright. There is no need to take permissions to use this material. So let's change this story by changing the beginning of the story. Thank you very much.
We had been struggling improving our mortality statistics and nutrition statistics all these years, and we had never given importance to responsive, nurturing care. Not only us, it was all world around. Now I think we have got something, the Jadui Chirag. Let us hope that it will help us to come out with better results in future. Now let's go to the next step, that is a second level hospital care, where how do they do it, especially at DAC. I invite Dr. Gaurish.
So now it's a very, very good afternoon to all of you. So at the outset, I would like to thank all the organizers, especially the SPACT, UNICEF, for giving me this opportunity to talk about our experiences. So good afternoon, everyone. I am Dr. Gaurish, and I work as a public health specialist and the head of the Early Intervention Center at Dharampur, Srimad Rajchandra Hospital. So I would like to embark you on the journey which we had for early intervention. My colleague Dr. Arjun talked about the early childhood development, which was more for each and every normal child. But what about like we are all practicing pediatricians, and you get to see a lot of babies or newborns who are at a high risk of having cerebral palsy or developmental delays or neurodevelopmental issues. So how we embarked on this journey at our place, and how you can replicate this same experience in your own way. And I think IAP has also taken up this task very seriously, and they have started an ECD program. So I urge all the practicing pediatricians to please have a look at it and please be a part of it, because as Dr. Arjun said, investing in the early intervention or early childhood development is what is going to make each and every child of our country to reach to his highest potential, and that is what is going to be very, very beneficial to all of us. So moving forward, so the area in which we work is a poverty-stricken area. It's a southernmost part of Gujarat, is the areas of Dharampur and Kaprada, which are tribal predominant. They are highly underprivileged, unemployment, malnutrition, anemia is very, very high in prevalence over there. So our hospital, Srimad Rajchandra Hospital, is a trust hospital. It's a 100-bedded hospital at present. It's surely within the next 2-3 months is going to be a 250-bedded hospital. And the hospital's aim is to provide comprehensive health services to the underprivileged people at no cost or highly subsidized cost. So what we have observed, just the background of early intervention, is that most of the mothers, the expectant mothers which we have, as you can see that she is a pretty malnourished or an anemic mother, you can see. So naturally the progeny is going to be there. It's going to be a very, very weak progeny. The child is born with either a preterm, low birth weight, birth asphyxia, all kinds of complications. But with the good NICU care, we have ensured a very, very good survival rate for them. But what about the survival beyond survival? So this is where the role of early intervention comes in. So all of these premature or low birth weight babies, they eventually suffer from physiological or neurological disabilities, as I said, cerebral palsy. Evidence suggests that almost 2 to 3 per 1,000 is what the prevalence of cerebral palsy is. But in our area, definitely it is much more higher. Then cognitive impairments. So these are the problems and difficulties which we come across in pediatric practice over daily. So many things we need can wait, but a child cannot. For him, today is the day when we should start practicing something which would help him achieve his highest potential. So as the role of pediatricians in early intervention is that we have to identify the 4 Ds. And under those 4 Ds, the first D is the birth defect. Second D is the diseases which most of the pediatricians deal with. Third D is the deficiencies. And fourth and the most neglected one is the developmental delays and the disabilities. So early intervention and early detection of these 4 Ds is of utmost importance. Now a little bit about the model of how our hospital tries to does it. It tries to do it with a 360-degree model approach. And here, what we do is we begin a little early. So when a mother is pregnant, we tell her a lot about importance of nutrition, of personal hygiene, of getting an institutional delivery. Then through the hospital services, through Safe Motherhood program, and through the NICU, we ensure that the child is born and the survival is our first goal. Then beyond survival, we have the early intervention center, we have the CMTC, and if a child unfortunately has got some disability, we also have a rehabilitation center at the place, and we have a robust medical outreach program wherein 5 doctors go in the 100 villages and they do the primary screening for all these 4 Ds in the community. So now birth defects, you all know, it comprises of a pretty high number of population which is affected. Deficiencies we all come across, severe acute malnutrition, anemia, being a thyroid deficiency. Diseases, this is the most important chunk of population which comes to all pediatricians, and we are more concerned about this. But this 4th D, that is developmental delay, I think this is the one which we should never neglect. So any child suspected of not achieving the milestone, developmental milestone, be it motor, be it language motor, social or fine motor, you always try to assess that child and send him to the nearest DEIC. Now this whole concept of DEIC and RBSK, it has been taken up by the government of India, and you will be pleased to know that government wants to establish now on every district place this kind of district early intervention center. So even in Surat, in the medical college, we have got a DEIC, and you will be pleased to know that we at Dharampur, we are the training and model learning center for the core staff of DEIC. And as you can see that more than 10% of the childhood population, which is a huge chunk, they have some or the other sort of developmental delays. So what is the possible solution for developmental delays or for any sort of 4Ds? Is early intervention. So what is early intervention? It's nothing, but it's like in the initial first 2-3 years of life, as we have seen by the presentation with Dr. Arjun, that the brain is mostly, the neuroplasticity is the maximum till first 2 to 3 years of life. So these are the years when we as pediatricians or treating doctors or caregivers, we have to be very, very vigilant and pinpoint any problems and find a solution for them. So early intervention is defined as an introduction of a planned programming deliberately timed and arranged in order to alter the anticipated disability. So we have to act during the early years of life. So this is our NICU at SRH. It's a 25-bedded NICU, a tertiary care NICU with a separate aseptic, septic, step down and transitional wards. So what we do, specially or differently, is we identify all those high-risk newborns in the NICU and they are given the careful positioning in the NICU and they receive all kinds of therapies whilst they are in NICU before discharge. We also do a comprehensive screening of all normal newborns and the NICU children before they are sent back home. We do the hearing screening of each and every newborn. We do the vision screening and the retinopathy of prematurity screening, as more than 25% of the children who are born, who come to us, they are preterm or at high risk of having cerebral palsy. Again, these are all the pictures of the thing, and this is in just the common services which we do under the EIC. Apart from the core services like vision, hearing, neurology, we have all the pediatric super specialists who come at our hospital and they screen each and every children who are primarily screened by the core team of DEIC. And all these services are provided completely free of cost to the children and to the patients. Then there are joint consultation between pediatric orthopedics and neurology. Dr. Ritesh sir only comes from Surat. There's a few success stories. So here was a child, he was born as a full-term normal delivery and he started having convulsions on 7th day of life. He came to our DEIC at a little later stage and he was diagnosed to have West syndrome, which is hips arrhythmia. Fortunately, the child's father and mother, they were very, very receptive and they continued therapy, sensory integration, neurodevelopment therapy, and today the child is completely normal for his age. He is going to a normal school. Similarly, in the same premise, we have a child malnutrition treatment center. You can see that this child was of 2 years of age, severely malnourished, had developmental delay. Just with 14 days of therapy, we could achieve a weight gain of more than 15%. But this was after the 3 months. So this is where the role of mother and caregiver and ECD comes in. At 3 months, after 3 months, the child was completely normal. He came walking to me. So I think we all have a very, very big role to play in our practices. Now, as I said, at our place, we have this model training center as well. So we have trained more than 200 staff of all the DEIC centers of Gujarat state and Maharashtra state. So what are the few practices beyond early intervention? We would like to invest at a little early age. So we have a very robust school health education and checkup program wherein we tell all the adolescent boys and girls to have proper diet and nutrition. We do a lot of sensitization in the community as well. We have a lot of good obstetric practices as well. We have a model labor room. And we had a very, very interesting trial which we carried out recently and which was published in the American Journal of Perinatology. It was like the physiological cord clamping as compared to the early cord clamping. If we just wait for the placenta to come out and then cut the cord, we found out that there are a lot of advantages in the form of increased oxygenation, increased hemoglobin levels, and reduced stay in the NICU for all full-term normal vaginal deliveries. And now government of Gujarat has also taken it up and they have told it to all the government hospitals to follow these practices. So in conclusion, at our place, we have tried to successfully implement the early intervention and we have treated thousands of children who were in need of early intervention. So finally, I would like to say service is love in action and early intervention is nothing. It's not a drug, it's not a vaccine, but it's a group of doctors, it's a group of therapies working together to achieve to help achieve each and every child of our country for his maximum potential. Thank you. Thank you so much.
Thank you, Dr. Gaurish. Friends, you know how many children are born in India every year? Anybody? 26 million. And how many of them are low birth weight or preterm? 30%. So all these are at risk, and we are catering to more and more newborns through our NICUs. And if we don't see the future of them, we miss the train, because there are so many things which are permanent if they are not mended right in the newborn age. For that, I invite Dr. Hima Binduji to kindly share her experience of interventions in tertiary care hospital.
Thank you. I really thank the organizing committee of GUJPEDICON and Dr. Digant Shastriji, Dr. Prashant, and all the whole team to have invited me to share the experience of ECD, what is happening in our hospital. Basically, we all have been now sensitized about the early child development components through IAP and through many fora. Now the government is interested, UNICEF is interested to collaborate with us. And sharing experiences like this will make us feel more confident that it is doable. So you all must be aware that I was very much interested in this field right from 2018. So I realized that nutrition alone is not enough, and we have to talk to the parents about stimulating the child. And we had this Epic 1000 program, I think very successfully run last year, this year and we had a number of, basically we started with preconception care. So we also told and made all the pediatricians aware that there's a role for prenatal bonding. The senses in the child are being developed in utero. So why we waste time? Let us start as soon as the child develops a sense of touch. Start talking to the child in utero, make the child feel all those things we covered in this module. So I tried to integrate all this, components of ECD and the EPIC, and we have a program called Early Child, the Care Companion Program. So this is the program which is running in our hospital, the Nilofer Hospital, which is the tertiary care hospital for children and for the government of Telangana. I think we are the largest neonatal center in the world with 300 newborns on bed. Anytime you can come and visit our hospital. It's on 2 floors and it's just very much congested, but still we are trying to do a lot of quality care. So when this program, we have a lot of attenders. Actually, what made us think about this program, because we don't have enough of human resource. We know that all of us have problem with the nurses. So for 300 newborns, we didn't have that many nurses to take care. So right from the very beginning, since even before this family-centric concept came in, so we have actually allowed the parents to take care of the newborns when we didn't have the nurses. So that was the reason, but we found excellent results when the mothers and the parents were there. We had less amount of sepsis as compared to when, nosocomial infections we were struggling with. So that was always there in our hospital. So we thought instead of the attendants sitting around when the child is with us in the NICU, they are there for 3 days, 4 days, 5 days, depending on the problem. And the parents are always there, or some attendants or some caregivers are there. So we thought, instead of making them just throughout the day sitting idly, and sometimes the trouble is, ye injection nahi diya, wo injection nahi diya, ye kya ho raha hai. So we thought, let us engage them in the care of the newborn. So we started talking to them, see the nurse also, it actually lessens the burden of the nurses. So we taught the nurses, you tell all this to the caregivers, how to identify even apnea, how to identify now the child is having some convulsion. And then these caregivers used to go and report to the nurse, who was one or two in the whole group of 100 newborns in one ward. So that was, it all started that way. So we thought basic newborn care was being taught to them. And then we integrated the ECD component slowly. So this is what this bit small story I want to just share with you. So we all, the need of CCP, I think this is very much, I think the need is there in all other facilities where we are overstretched. So we are really, the healthcare facilities in some of the centers are really overstretched, especially in the government sector. And families often leave the facilities with inadequate information. When they go home, are we telling to the parents ki kya karna hai? Are we talking to the parents ki how to take care of the newborn at home? How many of us we just tell ye injection de do aur 5 din aur fir aake you come for the vaccine visit maybe. So let us now start talking about it, how to win danger signs, preventing complications. Yes, sir, very few people are doing. And the shortage of hospital staff is there all over. Many of the centers have it. And the average time that the public health providers are able to spend with the patient is very, very less, just 2 minutes. So this was the need, this was the reason why there was a need of the care companion program. So babies are in our hospital, of course, we are tertiary care, so they come with high risk of complications. A lot of preterm deliveries and lot of success stories. We don't have even time to publish or tell about the success stories. That is the amount of work, and our residents are really doing a lot of good work. And these sessions we started, when this care companion sessions is nothing but the nurses are trained and they become the trainers. The nurse trainers again teach the young nurses who are coming into the NICU. So we have a pool of nurses who are trained in the care companion program, and they take sessions for the parents. After they finish the injections and all the work, the routine work in NICU, they just spend 5 to 10 minutes when the parents are around. So maybe around 12 o'clock, 1 o'clock, when they're a little free, they take sessions for them. And this, they explain about the healthy child and what is the healthy newborn and how to identify the danger signs, etc. So the sessions for the mothers and their newborn enables them to adopt preventive health practices using critical information given from the training. So we found that, once we give this training to them, the healthcare providers are able to identify the danger signs better. And also they are sticking on to the healthy practice even after going home. So it promotes the families to take care of their babies and uses behavior change education to empower the families. So once we involve them, naturally they feel more accountable. So it's not just, they don't just blame the doctor, the nurse. Now they are also part of the facility and they are also along with us taking care. So it brings in more accountability and more responsibility. So this model is, first thing is we engage. We have some content we have built up, and the medical experts and designers have developed culturally relevant, user-centered multimedia materials. So we train the trainers who are the nurses and doctors, and they are going to talk to the caregivers. And this is implemented in the wards. After that, they go home. After their discharge, we follow them up digitally. So we have prepared some WhatsApp groups, and they get some messages. Time to time is being given to them. And they also told about when to come back for vaccination. So we are in touch with them even after discharge. So the topics which are covered in the CCP sessions are the kangaroo mother care, hand washing, how to hold the baby, feed the baby, including breastfeeding, danger signs, and how to express a breast milk because the child is inside the NICU. So these simple topics are taken and shown to them by teaching aids. They are like, we have flip charts and also we use videos. Yeah, and when the nurse trainers take the sessions, and some drama-based videos are also made. We use print media, posters, and also infographics, and the mobile-based post-discharge support is through IVRS and WhatsApp. So after we discharge the newborns, with their family goes home. So they are in touch with, the phone call comes to them. Like, and then they can use the language what they want. In the next slide I will show you. So like this we have trained about 16,605 mothers and caregivers in 1,003 training sessions from September 2020. So this is a short report of what we have done. So then we started, this was going on before for quite some time. And then we integrated the ECD component. We all know what is the ECD components. So how early? So these are the components. We have taken up the ECD components which were by the IAP and also the EPIC, the preconception care, care during pregnancy, prenatal parenting, care at birth, child nutrition, stimulation, positive parenting. So these topics were integrated. And I'll not go much about this. The preconception care, in the preconception care we are talking about for the woman who is already delivered, we tell at least it will be useful for the next pregnancy. For 3 to 4 months before they become pregnant, what to do. So this message is going about folic acid and vaccines and the toxins to be avoided, etc. And then we also telling them about the epigenetics. And during pregnancy, how the stress should be avoided. We have evidence that high cortisol in the mother can cause DNA methylation in the baby. A genomic structure can be disturbed. So that is also we need to, and that also can lead to behavioral problems even after 4 to 7 years. So this is also we are going to, we are telling them. And after birth, stimulation starts from skin to skin contact, breastfeeding, and in the complementary feeding, textures, responsive feeding, allowing independence, increasing interaction, even massage is a good opportunity, stimulation at every age. So we have videos to show them how to stimulate from 0 to 2 years, 2 months, 2 to 4 months, etc. So this about play also. We tell them about different play activities they can do at different age groups from 0 to 3 years. And responsive caregiving, how to identify the cues, movements, emotions, how to satisfy them. And this will actually help them social engagement, cognitive stimulation, emotional regulation. So we talk to them about the different age groups. If their child comes for about 0 to 6 months, the information about that age only goes to them. That your child is in this bracket, so what you need to do, what play activities you can do, and how to stimulate the child for this age group. So likewise, for every age group, the information goes in the print media and also through WhatsApp. So in the sessions, on Monday, we have fixed these topics. Like on Monday, and we have this preconception, joyful pregnancy, maternal diet, then breastfeeding, skin to skin. The black ones are the earlier topics. We have integrated the ECD into the ongoing care companion program. Then the repeats on Thursday. So Monday, Tuesday, Wednesday, then Thursday, Friday, Saturday. So these topics are taken in the care companion sessions. So this is how we take, these are some photos about how the sessions are taken in the neonatal unit after the work is done. The nurses do most of the sessions. And after the session, the parent attends to the session. They go home, they have a missed call, then we give them a welcome message. They can also select the language. Do you want in Hindi, Telugu, Marathi, whatever the language they can select. And after that, the health messages are given every 2 to 3 per week. And we also reinforce with best practices reminders. Videos are given, infographics, and all these are shared. In this, we use a little bit of technology. And then the number of phone calls we have done from the SNCU, this is all, how many IVRS calls have been given to them. So just a small report about that. And so these are the number of sessions. In spite of COVID, we have done so many sessions in our NICU over the from March to November. And we have this Early Child Development Center, which we integrated like all the services, ROP, hearing screen, early stimulation, age-wise, we demonstrate with videos and also actually in physically. And we also we integrated again every visit what to do. The 11 visits of ECD of our IAP has been integrated, and at each visit what we have to do in a simple way, we have started actually applying it. Like these are the visits we all know in the ECD program. 11 visits are advocated, and every visit, height, weight, and then what the stimulation, parent stress questionnaire is being administered, and then scoring is being done, and then we tell them what to do depending on the score. In the nutrition and the responsive care, at every visit what to ask. So this we keep in the tabletop so that the residents or anybody sitting in the OPD on the follow-up clinic will do. For the safety and security, what questions to ask at every visit. So for the 5 components, what to do. So these things are there all, instead of remembering, we put it in the charts and keep on the tabletop in the follow-up clinic. So before they come, we are in touch with them through even through the phone calls. So these are the number of calls we have done, and what are the completed calls. Yeah, just visit. So this is the end of it. Like we just want to say the immediate outcome. This is very new integration we have done. And what we found, we have presented this paper also, and we got a gold medal. One of our residents got the gold medal that this program had made the increasing in vaccination visits. So, but just making a phone call and giving them health-related topics regarding stimulation, everything else, they are so happy and satisfied. Client satisfaction is there, increasing breastfeeding rates, increasing duration of KMC, and they are coming to follow-up visits. And a high degree of caregiver satisfaction, very much satisfied with the facility, and increases the credibility of the institute. So, just want to share this model with you. Thank you for giving me an opportunity.
Thank you, Dr. Himamiddu. I want all of you to be James Bonds. જેમ્સ બોન્ડની મૂવી હોય ને એમાં બધું વિલન એટલું બધું હાઈ સાયન્ટિફિક એડવાન્સ્ડ બધું સેટઅપ બનાવેલું હોય અને બોન્ડ છેલ્લે છે ને હથોડો મારીને જ બધું તોડીને પછી છેલ્લે એમાંથી બહાર નીકળે છે. It is just mechanical process. So a complex looking situation may have simple solutions. That was the message. And this is one such simple solution. And we have seen people doing the things in their own way. Now we have got time to ask our own people who are leading the things. I would ask Dr. Digan Shastri. Before that, I would, audience questions are invited and there will be volunteers in the middle row. Please, 2 volunteers in the middle row. You can give your suggestions, comment, questions in a chit. So, Digan bhai, you are one of the person at the helm of the affair at Central IIP so far as ECD is also concerned. And how do you look forward? And especially the Angan project, you already started it. So in a very short, crisp way, you can give the message to the audience.
Yeah. So thank you, Ketan, for this opportunity. And I represent Indian Academy of Pediatrics as a past president as well as the current program of IAP Nurturing Care Early Childhood Development program that is lasting for 3 years, 21, 22, 23, and then we are hopeful to continue it for the second segment that is 3 to 6 years in the next 3 years. So IAP has started focusing on early childhood development in last few years, and if you know, in Surat we started Project Spring where we had adopted the Anganwadi, but at that time maybe 6 years back, and at that time we were doing the work in a patchy way, an unorganized way, and there were no longitudinal follow-up of the patients. So that was the seed of ECD at that time, which remained dormant for a little bit some time, and then in 2019 we envisaged Project Angan, and then we had here in the same premises we had the first IAP's consultative meet on early childhood development, and then the consensus statement was published in the Indian Pediatrics. And then over the last 2-3 years IAP has taken a great progress on ECD. This year we had the theme of IAP Pedicon, which was in Mumbai, again was on ECD, where there were plenaries where Dr. Narayan also was there, Dr. Sumita Ghosh from Central Government Ministry of Health and Family Welfare, and WHO, Dr. Agrawal, and they all were there. So in short, right from the beginning we started with bringing all the stakeholders on the platform. Then we had Mumbai Declaration. That was a Pedicon time. We had the meeting and where we came out with the Mumbai Declaration. And then we had that famous 5 days jail for 40-50 people, where the experts from all across the country, they were gathered and put in one hotel for 5 days, and from 9 a.m. to 9 p.m. there they were working on the development of the module. And we are seeing that after successful 5 zonal TOTs, we have already started the provider program, and one of the program was conducted yesterday at Surat, and I am very happy as a steering committee chairman to see that people very much appreciated. In fact, the people gave a standing ovation to the contributors, and they appreciated the material. So that this is how IAP has taken up. We have also come out with a additional issue of Indian Pediatrics, which is having exclusive all the articles on ECD. I saw the Aram article also in that issue. Then we have also we are not just focusing on the pediatricians, we are also focusing on the would-be pediatrician or would-be doctors. So the children, the students who are coming in the medical education, or those who are pursuing pediatrics, so to sensitize them, again this task force has been created, and we have given our recommendations to the NMC, and I am happy to say and inform here that our recommendations are accepted by NMC, and the pediatric curriculum, the component of ECD is added, and so right from the undergraduate days, postgraduate days, we are sensitizing them. So this is about the pediatricians. Now, see, there are large chunk of patients who are not coming to the pediatricians, they are in the community. They are the people who are catered by Anganwadis. So again we came back to our project Angan, which we envisaged at that time and we started. So yesterday we had a very lengthy and on-length discussion on project Angan at a state level consultative meet. And there were participants from RBSK, participants from the Department of Women and Child Development. We had participation from Preventive and Social Medicine Department, UNICEF Gujarat, and then we had participation from Department of Social Studies with South Gujarat University. And of course IAP, AOPG members were there. Now in this program we are planning to have the interventions through the Anganwadi, where the Anganwadis are adopted by IAP, and the two components, the Anganwadis are doing wonderful work for several years, but the two things which is been probably lacking is responsive caregiving, then safety and security part, again probably it is little bit overlooked in the Anganwadi, and third is about the early learning opportunities. So these three components which are lacking in the Anganwadi, they are doing wonderful work on the health aspect, they are doing wonderful work on the growth and development monitoring and immunization, nutrition. But these three components, which are the important components of the nurturing care, and what just now even Dr. Gauri as well as Dr. Arjun and Dr. Hima Bindu showed about interventions, early interventions. So all these things can be done from the community level. So we have come out with this project Angan. We have the multiple stakeholders on the board. I am happy that they all came with a positive note, and we all dispersed with some blueprint about the program. And in the next few months, under the leadership of AOPG President 2022, Dr. Rakesh Desai, we will be launching this program Angan, and we look forward that all the AOPG members contribute it, and by that way can make the IAP's vision of each child having the highest of its own developmental potential achievement possible. Thank you.
Thank you, Dr. Digan. We have got few questions from the audience also. I rightly mentioned in initial sentences of today's program, you will have FOMO, fear of missing the opportunity, and both the states are for fear of missing opportunity. I would like Swati to very briefly allay this fear of missing opportunity, in the sense that majority are private practitioners, and how they can incorporate stimulations, and how can they deal with the parents. And specifically, I think we will have to mention about yesterday's workshop, how we will go about it.
So I think the whole concept of early childhood development nurturing care takes away the basic thought that we are not working on only identifying developmental delays and then intervening. The concept is supporting normal development, and doing that by empowering the parents and the caregivers. We are not only talking about parents, we are talking about caregivers, which will include grandparents, the preschool teachers, or the community workers. And thereby, as a private practitioner, see, I would be the happiest person even if I am a developmental pediatrician. I don't really want to see a child having developmental delays as often. Okay, yes, I need to work, but that doesn't mean I want more children to have issues. So if as a general private practitioner or a pediatrician, you can just talk to the parents during their well-child, or the concept of a well-child visit, or what we discussed yesterday during the ECD workshop. Every vaccination time is an opportunity to help parents become empowered to stimulate their own child in the home environment using materials which are available at home. So just asking a mother, how does she feel when she's breastfeeding a child? Or how do you play with your child while you are giving a vaccination shot will start the parents to think how they can be interactive with their child much more. And I think that's more joyful than just giving a vaccination shot and saying, pay your fees outside. I think you will enjoy your practice much more that way.
So we have published the workshop manuals, and in the manual.
Yeah, Ketan, I will like to add, sorry, I forgot to mention. See, the IAP Nurturing Care ECD module, those who have attended yesterday, they will agree to my statement. There, see, initially people had that misconception that this is for the developmental disorders. But this module is not for the developmental disorder. This is for the normal development. And so normal development is a domain of a general pediatrician. It is not a domain of a developmental pediatrician. So in fact, this NCECD module, I think can contribute by each and every general pediatrician by this module. And what Swati told about the well child visit, I think, and we have these three manuals, different manuals. One is a pediatrician's companion. One is a basic concept on ECD. That is, of course, having some resource material on the importance of the ECD. But pediatrician's companion is a very beautiful, color-coded, every visit, what is to be done by pediatrician, what is to be done by his or her staff, what is to be asked, what is to be looked. So I think it is a wonderful, you can have a reference manual on your desktop from which you can see, these are the manuals, and this is the manual for the parental counseling on various topics related to ECD, and this is the basic concept about ECD. And I am talking about, though this is a very small book, but this is a companion which you can keep it in your clinic and your desktop, and at every visit, I think it is very easy. You can just have a quick checklist.
Yes.
Same thing I showed in my how I integrated. Very beautiful module. This will all of you should attend this ECD workshop. So the same thing which is there for each visit, what to do, we have incorporated in our follow-up visits after the ECD program is coming. Very, very doable. Very, very simple. And this should be there. The companion, if you have, or put some charts on the desktop. Each one will know there are 5 to 6 points at every visit, and 11 visits have to be done.
Okay, so the question is being answered. Now I would like Dr. Upendra. So he is going to steer the academy in future. Okay, Upendra, how would you look at this project in future, and what plans you can have to take it to the periphery also?
Yeah, thank you very much, Dr. Ketan, and thank you organizers for giving us the opportunity to share our thoughts on this very, very important topic. As Digant Bhai and everybody else has said, very important difference between other modules and this is, we are not only talking about growth and development, but two important things which come into play is cognition and emotions. We have never ever discussed about it. We don't want the deviations, but we want to have support the positive development in the child. And health sector becomes the first entry point. Why pediatricians? Because patients come to us after delivery. We are there, the first point of contact. So the first visit itself is less than 7 days. So you take care of lactation. You see to it that the proper lactation is established. So why not make an opportunity? What more to talk? If the baby has gained weight, baby has everything is perfectly all right, just talk 3 or 4 sentences. He was talking about experience expectant. So there are two types of things pediatricians should know. There is experience dependent and experience expectant stimulation. We have all the 5 special senses developed. The touch, the smell, the hearing, the vision. So all that smell, so what it requires is not only the anatomical existence of the tract, but you need inputs. So unless and until from my eyes the input goes to my visual cortex, it is not at all going to develop. Not at all anything is going to happen naturally. So use those 5 special senses. In what way? So talk to the baby, smile at the baby, laugh, babble, do everything, gestures, different sounds, let the child enjoy everything. So that is what we want to tell. So by doing these programs, what IIP envisages is, what Digantbhai was saying, that this module was there was a setback, all of us know, because of COVID. If you know the IIP's roadmap, then it was already 100 modules, programs. The district level workshop would have been over by 3rd and 4th quarter of 2021, but we are not able to do that. And 100 were to be done in 2022, and there was an impact analysis which was to be done in my tenure when in 2023. But unfortunately, it's all acceptable because the entire world had that setback. So now what we plan to do is finish off this all 200 whatever workshops that we are planning. So pediatricians first, they get sensitized, they know more about it. So their front desk staff, the receptionists also need to be, trained about it, because everything cannot be done. I have a very limited time now, unfortunately, fortunately, quote unquote, that our OPDs are not those numbers that we had pre-COVID era, and then they're restricted. So why not use this as a quality time? And this is an additional incentive for a pediatrician to see to it holistic development that we are catering to. And I appeal to pediatricians, we are all considering ourselves to be very sensitive. So as SDG goals, the Sustainable Development Goals, the 5 most important which you and me want to overcome and see to it that the world is a better place to live is first and foremost, no hunger, no poverty, no gender discrimination, and a peaceful society. And if I tell you the answer to all these 4 is ECD, how exciting it is. So if we can do such ways, if we can appeal to pediatricians, and then I think pediatricians are extremely sensitive. They can give that message to your parents, then to your staff. So everybody gets sensitized. I think that is how we should go about it. Pediatrician's job is to pick those up. I am sure everybody has attended yesterday's workshop. So danger signals, and wherein key words, you need not talk about half an hour about for that. But 4 or 5, at 7 days, at 7 days, at 6 weeks, what should I speak? 10, 14, and in 6 months, never ever lose the opportunity of complementary feeding. So while you are giving a flu shot, why not talk more about it? So I always said in one of the videos which I released, 6 minutes at 6 minutes. So somehow, if we can do and plan every action, pediatricians, 3 to 4 goals. Don't keep it a very big agenda. No, this week I have to do, but then I cannot do it. So 3, 4 excellent, important agendas at every vaccination visit. So 10 become that, and then you have 30 and 36 ones which are extra. So if you plan accordingly, I'm sure you'll be able to do a great job in a given limited time. So that is how I think every pediatrician can contribute in a big way.
Okay, thank you. We are running very short of time. We have got only 9 minutes. We have got few more points to be put up. I would ask Dr. Nilesh, as he is from RBSK, how you can back up this IAP plan. Specifically, we don't want the whole picture of the RBSK. How do you back up? How will you?
Sir, from the session of Dr. Gaurij and Dr. Arjun, they sensitized us on for the development of the child. ECD is very necessary. And looking at the NFHS 5 data. Volume. And looking at the NFHS 5 data for the nutrition, undernutrition, fasting, and stunting. And I understand that not only the supplement, but also the ECD is very necessary for the overall development of the child in Gujarat. So looking at the NFHS 5 data, we are second in fasting and undernutrition. So ECD concept is very necessary along with supplement in Gujarat to improve the National Family Health Survey data in 6 in next coming years. One additional information under RBSK, government is also taking care of children, those who are affected by developmental delay. We have 21 district early intervention center running by government, and we have 14 professional teams of pediatric medical officer, psychologist, speech therapist, audiologist at district early intervention center. Some of are running with the help of public-private partnership, and 5 district early intervention center will start this year at Gujarat, Dahod, Rajpipla, Bharuch, and Viara. And we are ready to do MOU with any NGO and private pediatrician if they are willing to start district early intervention center at their place. We are ready to do MOU.
Thank you. Thank you for the details of what we can have a tie-up. Digantbhai would definitely be happy if RBSK joins with us. Now, very quick and very important comments from Dr. Narayan.
Yeah, thank you very much, Ketan Bhai, Digant Bhai, and all the organizing, committee of Surat Pediatric Association as well as AOPG. Actually, we are very pleased today to hear from our champions, three of them, telling us how to do ECD. Last conference, we were talking about why to do ECD, but we see now today the lot of evolving models of ECD. And also another beautiful part of today's session was, we have a three different level: community level, secondary specialty level, and also tertiary care level. We will be very happy to see in future a very good forward and backward referral system to ensure that every child we treat are actually taken good care in the facility, the community, and they come back to us whenever there is a need. To do all of this, to my mind, we need to strengthen actually the capacity of the caregivers and the parents to provide nurturing care as per the vision and the framework we have. It's a joint framework globally we practice for WHO, UNICEF, the World Bank. Everybody endorsed this. There's no doubt in our mind. As my colleagues were saying, there's enough evidence from neuroscience why ECD is so critical. So I would plead, to advocate and work on continuum of care, starting ECD very early, even maybe adolescent life stage, addressing the issues of nutrition. And in Maharashtra, many districts, we do have a pre-pregnancy, preconception care models, enhancing the, the health and nutrition of the adolescent mothers. So we need to do this not as an individual pediatrician, as an expert, but as a team. So that requires capacity building of everybody in the hospital. We probably need more communication materials to reach out to everyone. I encourage IAP and also together as a government and UNICEF, everybody, we should develop some communication strategy, not only print media, but also social media, mass media, so that, your P2P dream of IAP gets realized. You talk to parents directly, not necessarily through Asha or Anganwadi all the time. So I appeal the ECD champions who are getting trained. The vision of IAP is 10,000. You have more than 500 people already got certificates. I look at all of you, or we look at every one of you. Next year, we want to hear your story. What did you do in your clinics? We really request a central IAP to monitor and then also encourage people and enable them to champion these stories. Like we would like to hear the stories, 3 stories. Next year, 10,000 stories. That will be amazing. And Ketan Bhai keep asking, how many more evidences, Narayan? So we have enough evidences, but I request all of you, all this time you are downloading, can IAP, UNICEF, everybody can start uploading now with our own evidence locally. We can engage with the research institutions and other people, creating more evidence and knowledge, and also have a more learning exchanges next year, physically possible, visiting the intervention places. UNICEF will be there to support you if in any case. My last and final appeal to all of you. Together, we need to build a stronger society. We need to create a more cognitive capital. For that, it is not enough you work at doctor's level and the community level. We need to engage with senior policy makers as Niti Aayog, parliamentarians, legislative assembly, government officials to invest more in children and understand this is also development, not only road and building, dams and electricity. Cognitive capital building will require all of our engagement. And if collectively we raise our voice will be strongly heard for sure. So thank you so much for this opportunity.
Thank you, Dr. Narayan. Now, I would request Dr. Gauri, Madam, and Dr. Arjun, in very short, give us what private practitioners should do in their private practice to achieve the maximum returns. It may not be the whole thing. So only 3 things that you would advise what they should do.
I think now by the end of this session, everyone is clear what they can do. So I think putting up a lot of material for all the newborn children, like how to stimulate them, maybe putting out a huge board which suggests what are the normal development which a child should achieve. And if the child is not achieving that, then where you should send them. So you can send them to the nearest DICA. And I would like to congratulate the whole RBSK team that they had been very, very instrumental and they have been very, very proactive to bring all those children to the DEIC, because I think private practitioners might send them, but RBSK team brings them free of cost, or the all transport cost is bared by RBSK. So I think we all have to work together as a team for normal children in the well baby clinics and for all the children who have some issues. So please redirect them to the DEIC. Please have a follow-up and try to help them to achieve their maximum potential. I think that linkages is very important.
Yes.
So I think we need to get together at a district level, at even the block level. We can organize this kind of things for all the general practitioners and the pediatricians of that place.
Okay.
Because in IAP all cannot come maybe together, but this message should be there to the
Dr.
town.
Arjun.
Thank you.
Okay, so I'm just not want to be immodest, but
Volume up, Joe.
we need not to be at the center repository of the information. ECD is the domain of everyone. Just empower everyone, empower your staff. Anyone can deliver the ECD message. Number one, not necessarily doctor will deliver it. Number two, please tell the parents why it is important. We don't believe in our project that we will give set of activities कि आपको वो पिकअप ही खेलना है, आपको ऐसा ही करना है. Parents can find the way कैसे stimulus देना. Stimulus देना is not a rocket science. Just tell them why it is important. You have to talk to your child. Whatever form they want to do it, just let them do. No need to make it a very complex rocket science के 0 to 3 में यही 3 activity होगी. It is not a science, it is a nature. So just sensitize the parents why it is important, how they will figure it out, and follow-up would be very important. So don't complex it, it's very simple, it's a natural process, and don't be the center repository of the knowledge. Empower everyone, your staff, non-medical person can also do it, your paramedical person can do it, even your receptionist can do it. Display the posters, run the videos, and I think Angan project will come with the Gujarati literature. Till now, if you are running sort of any of the literature, contact us. We will be happy to provide you literature in the English language that you can modify and display in your private practice. So make it simple, please keep it simple. Don't make it rocket science, because health people have a tendency to make it very strict. Kaise hi hona chahiye. ECD is not like that. It is a development. Everyone has a different way to play with their child. Encourage them. Just giving stimulus is important. In which way it is not so important. Thank you.
Okay, thank you, Dr. Arjun.
I would
And
like to just say
fast
that-
comment from Madam. We have got only half a minute. Yeah.
Sir, one thing institutes can do easily, because deliveries are happening within us, and we are in touch with the newborns, and the follow-up is something which we need to strengthen, and the follow-up of every institute will increase if you do something like this quality. Like, each time they come just for vaccine visit, not enough. We ask about feeding, and now you can add about other aspects, nursing care, responsive care, safety, and all that. That is for institute. We have very good credibility. People will appreciate and actually will come back and again. For the private pediatrician, my humble request and suggestion is, in fact, pediatricians, when the diseases, the infections have come, they were asking what else to do. So in that gear up sessions which I used to do, I said you have to gear up now for child development, normal, every child is developing. Whether you do or not, the child develops. How much you are maximizing his potential in the hands of the caregiver, and you have to empower the caregiver. The caregiver has no training at all. So that simple thing if you can do, then that pediatrician will become very popular. उसको आजकल पीडियाट्रिशियन अगर आई कांटेक्ट भी नहीं देता है, जस्ट मेडिसिन लिख के भेज देता है, बट ये डॉक्टर मेरा सुनता है एंड ही इज एक्चुअली आंसरिंग माय क्वेश्चंस एंड इज टेलिंग मी अबाउट हाउ टू होल्ड एंड हाउ टू फीड द बेबी एंड इवन टेलिंग मी हाउ टू स्टिमुलेट, हाउ टू मसाज माय बेबी. I think that the common public will love it. The mothers and the caregivers, the parents will appreciate that pediatrician. You can hike up your fees if you want for 100 rupees more if you want, and that quality is what everybody wants. The public will appreciate that, and it's very much, I think that's an incentive, and I think that's only to motivate you that's what I shared with you. We have seen in my own Hyderabad, young pediatricians, Pawan and all, they started doing this. Online also they were giving counseling. So they became hit pediatricians in their area. They really started practicing their OPDs. So this is, I think is doable, and very much, I would love to see more and more pediatricians joining this mission. That's the way forward.
Yeah, thank you,
Thank
madam.
you.
And one request was there from audience for some important comment that he wanted to make.
I just want to make one comment because we all are clinicians. So આપણે આયર્ન ડેફિશિયન્સી હોય તો વેસલને ડેમેજ થાય, વાસ્ક્યુલર ડેમેજ થાય, અને સ્ટોર ઘટે, જાતના ડિઝીઝ થાય, બધું જ ખબર હોય. એટલે વી ફોકસ ઓન સપ્લિમેન્ટ્સ. પણ મને એવું લાગે છે ECDમાં આઈ હેવ નોટ એટેન્ડેડ ધ પ્રોગ્રામ, બટ ફિઝિયોલોજી ઓફ બ્રેન ડેવલપમેન્ટ પર ફોકસ કરવું જોઈએ. કેવી રીતે બ્રેન ડેવલપમેન્ટ થાય છે ફિઝિયોલોજીકલી. આ બધા નર્ચરિંગ કેર ને ECD ને સ્ટિમ્યુલેશન ને પ્લેન આપણા બધા માટે એલિયન શબ્દો છે. એટલે શું કરવાનું બહુ બધા કન્ફ્યુઝન છે. 15 વર્ષથી આ શબ્દો ચાલે છે. 3 ફેક્ટ કહીશ ખાલી. બટ વેન ધ ચાઇલ્ડ ઇઝ બોર્ન, લાઈફ ટાઈમના ન્યુરોન્સ હોય. 100% ઓફ ન્યુરોન્સ આર ધેર એટ બર્થ. એક નોટ અ સિંગલ ન્યૂ ન્યુરોન ઇઝ એડેડ આફ્ટર બર્થ. પહેલા 2 વર્ષમાં 100% ઓફ સાયનેપ્સિસ બની જાય. At birth, one neuron has only 2000 or something synapses, and at 2 years, each neuron has 15,000 synapses, and 100 trillion neurons hoy. So 100 trillion neurons, each neuron na synapses 15,000 વધે પહેલા 2 વર્ષમાં. તો આ બધા સાયનેપ્સિસ અર્જુનભાઈએ કીધું કે ડોક્ટરો સાથે ડીલ કરવું સૌથી અઘરું છે, કેમ કે આપણને ખબર નથી ફિઝિયોલોજી. એટલે આપણને જ્યાં સુધી ખબર નહીં આપણે એક્સેપ્ટ નહીં કરીએ.
Please cut it short. If you want to have a very specific advice, we are running out of the time.
Sorry. No, time is.
ECD વર્કશોપમાં અમે ડિટેલમાં લઈએ જ છે આ બધું.
So basically physiology, I just want to tell કે physiology પર ફોકસ કરવું જોઈએ. That is only thing.
Lot of things are being discussed in the whole workshop because it is a very big subject. Our purpose was here to have sensitization of people that it is very important, it is doable, it is achievable, and it is a win-win situation for everybody. So thank you very much. Now last comment.
Sir, एक mini information sir. 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 Actually we have included developmental delay or danger signs and early childhood development ECD component in our Mamta card. We request you to encourage parents to use Mamta card for ECD as well as for the diagnosis of the developmental delay, and if found a developmental delay in your clinic, kindly link the child with our RBSK team. Thank you.
Okay.
Yeah.
So if the organizers allow,
they don't have time, I think.
we already
shoot.
I am just asking for a 1 minute pledge by the audience if you allow.
Please.
If you don't allow, I don't mind.
Last 1 minute.
Okay.
Please.
Huh?
Yeah.
Okay. Can?
Last 1 minute,
Yes,
yeah.
yes, sir.
Okay.
Yes, you can.
So, see, this pledge we develop for the IAP NC ECD module, the workshop, and we ask the delegates, participants who attend this program. It's one sort of commitment as well as one sort of moral your binding for this program and for this intervention. So if you all are committed and if you are agreeing, I will just like you to take this pledge. You can practice NCECD and pass on the benefit to the coming generation. So I request all of you to take this pledge. Please stand up. I solemnly affirm to make ECD a routine part of my pediatric clinical practice. I will strive to make my clinic ECD friendly and will champion ECD services to all my parents and contribute in creating more efficient future generation and building our nation. Thank you.
Thank you all. With
Thank
this
you,
we
sir,
finish
for
the
this
session.
wonderful discussion. I would like to request Dr. Ketan to felicitate all the panelists at the felicitation corner. And I would request Dr. VB Shah sir to stay back to felicitate Dr. Ketan Bharadwaj sir.
Now everybody can go for lunch, but the lunch time is now cut short for only 30 minutes. We will back at 2:15.
Vaccination is a very, very important part of our practice, and I think since the COVID probably, as you know, morning Dr. Kinzhwadeker quoted that our practice, clinical practice is going down, and we are more dependent on now vaccine practice. So vaccination is an important part of our practice, and there are certain vaccines which are not part of NIP, and that is why most of the population who are willing to take vaccines in a private setup, they always ask, and some of those who are taking their primary vaccines in NIP also would like to take these vaccines. And so varicella is one of the very important vaccine, and we all know that in the past we thought that varicella is a mild disease and so self-limiting. But now we know that when the disease occurs in a children who are almost adolescent or in the school age group, the disease can create lots of problem. Absenteeism in a school is also a big issue, and we know that if the disease occurs almost for 9 or 10 days, child cannot go to the school. And so the importance of the varicella. There has been instances where even the colleges were closed down for almost 10 days because of outbreak of this disease in one of the college, engineering college in Kerala. And in the past, when the vaccine was not there, in the Western world, there used to be a varicella party of children, preschool age children, 3 to 4 years. So they play together so as they get a milder disease, and that is how they develop the immunity. Things have changed after we got a vaccine. Now, how does this varicella infect, and what is the transmission? We all know that it can enter into body mostly by the nostrils and mouth, but sometimes they can enter through conjunctiva also, and then there they lodge, and then they go into the blood and infect the whole body. The course of clinical features of varicella is like this, that initially there will be a small fever, and then the rashes will develop, and then after about, say, 4th or 5th day, they will start forming scabs, and they will there for about 9 to 10 days. So this is how the course of the disease will continue. Now let's look at the global burden of the disease, and this is where varicella stands. So it's for the total number of cases may be not that big. This is a 2012 report of the Lancet, and as the vaccine is available in Western world, this number has gone down. So whatever number is there is mainly from developing countries, as the vaccine is not as a part of NIP there. Though this number over here is small, as we all know that we hardly report chickenpox as not a notifiable disease, and we hardly report, and that is why whatever number is there, the actual incidence is almost 10 to 15 times more than this number. So that is what the situation is. This is how disease can occur. More than 1 million cases per year in India, and every 3 years there is a outbreak which is much bigger than the, so it comes in the cycles. Hospitalization is not that large. It is 3 cases per 1,000 cases of the disease. Death is 1 per 60,000 cases. Mortality is also not that high, as complications are not that big. The greatest disease burden is in the children. More than 90% cases are in children. 70% hospitalizations are also in children, and 50% deaths are also in the children. There is an Indian study published by Dr. Lokeshwar. Fortunately, I was also part of this study as one of the principal investigator. And what was found, that about 50% of the children were susceptible at age of up to 10 years also. So the notion or a myth that children seroconverts by age of 9 or 10 years was not true, and almost 50% of the children had not seroconverted, suggesting that they are likely to develop disease, and the disease in adolescent age group is much higher. So that is what this study brought out, and that is why there was a need. And if you look at the data from Kerala, only 25% of the children were seroconverted by 10 years. So 75% of the children were not seroconverted in Kerala. So that is the situation there. The risk factors for severe disease or a complication are in the first month of life, especially if the mother is seronegative and if there is a premature child. In adolescents and adulthood also, it's a serious disease. If child has received a steroid therapy, then it could be a serious disease and can lead to severe disease. If they have a steroid therapy, even if it is a short-term therapy, immediately preceding or during the incubation period of a disease, then also their child can develop severe disease. All immunocompromised children have a chances of a very severe varicella, and pregnancy also can have a high risk of varicella. So these are the situations where disease can be severe. What is severe disease? This is what the severe disease is. It's a hemorrhagic chickenpox or bullous chickenpox. This could be a modified varicella, as even though the child has received varicella vaccine only one dose, some of these children will develop modified varicella syndrome. Or congenital varicella, where mother has in the last 2 days before delivery has developed disease and they develop the disease. So, and this is a complication. Strep necrotizing fasciitis is a known complication. It's a severe disease and requires a long-term management. So then what is the alternative? We all know that vaccination is the best alternative to prevent the disease. But the question now, there are many brands available. So which one is the vaccine where we need to opt for? So that is what I am going to talk today now. So what is varicella vaccine and how it is prepared? Varicella vaccine is was first developed in 1970s, and it was developed by Takasai in Japan. All the vaccines which are available till now, the seed is same, starting strain is Oka strain, and from that strain only, all the companies are manufacturing varicella vaccine. To develop this Oka strain varicella vaccine, fluid was taken from a vesicle of healthy child who had developed the chickenpox, and from there, and so is from his family name of a child, this Oka strain is known, and that is how this vaccine has come. So the vaccine which I am going to talk, which is considered to be a next generation because it has some addition which is making it little special vaccine than the all other available brand, has very important is that stabilizer is nothing, it's a totally different, and it is a trihalose, and they do not have gelatin and MSG as part of their the preventer or other additional excipients which are not added in this. So it is a trihalose based type of a vaccine, and that is why it's different than the other vaccines which are available, because all MSD brand and Juventus and Vocard has these additional agents into the vaccine. So these are the different trials looking at what is the shelf life of these different vaccines, and with the addition of trihalose, if you look at the vaccine, the next generation varicella vaccine is a highest shelf life. It is 36 months as compared to the other vaccines. So it increases the shelf life and increases the stability. The vaccine effectiveness is also more than 90% of this vaccine. The breakthrough rate with single dose was 0.01%, and all age group vaccination, this vaccine is approved as compared to vaccine which is available from GSK. Rsv vaccines are only approved for the vaccination in children. So what the gelatin which is added by almost all the companies other than these new generation or next generation vaccine, the reason why they have not added is that gelatin is known for anaphylaxis. Most of the cases reported for anaphylaxis is because of gelatin, and this gelatin was added into many other vaccines in the past, and these reports are there. If gelatin is not added, one can definitely save these children from the anaphylaxis type of reaction. So this vaccine becomes anaphylaxis proof if it is not added. Similarly, MSG or monosodium glutamate is also known to give rise to some adverse reaction if if the vaccine is not having those type of MSG, then the reactions like headache, numbness, tingling, palpitation, and drowsiness will not be there, and that is the advantage of not adding MSG into the vaccine. The trehalose is a naturally occurring sugar containing 2 glucose units, and the fate of parenterally administered trehalose is same as what we give as a IV or parenteral glucose, so it gets absorbed, and that is why it is a safe and non-toxic material. It also provides end-to-end protection of the antigen, and that is the reason why there is an increased shelf life of the vaccine which has a trehalose into it. This is how the trehalose work, and this is how the potency is increased post-administration because of the trehalose. So this, if you look at the stabulated data of this next generation vaccine, which is Nexiploc, at different shelf life, and you will find that the varicella content of the vaccine is almost same at the end of 36 months or so of these lots, and that proves that trehalose has increased the stability of a vaccine. So if we compare with the other vaccines, the shelf life of only Nexipox is more than 36 months or 36 months, while rest of the vaccines has almost 24 months or so. The Indian phase 3 study of the Nexipox has also shown that the comparison with the GSK vaccine, that the GMTs were almost comparable with both the vaccines. It was a little higher than the GSK brands, and so this vaccine with trehalose was non-inferior to that vaccine, and that is how the vaccine was given a license in our country to practice, to use it very safely. If you look at the safety data of Indian study, again the varicella vaccine next generation with trehalose is equally safe, and there are no extra or additional side effects of the vaccine. So both all the vaccines which are available are very safe vaccines as compared to all other vaccines available. The post-marketing surveillance study of seroconversion with first dose and after second dose again shows that there were no unsolicited adverse events or no serious adverse event reported after the large number of doses administered in the practice. And this study was at the end of 975 subjects. It's a fairly large study which showed that there was no additional. The ACVIP recommendations for the varicella vaccines are that it has to be offered to all the children, all healthy children, this vaccine. Additionally, to certain high-risk group, we need to give as universal vaccine or to all those high-risk group, because it's very important to protect these children if they have a high risk. And this list of high-risk group includes children with immunodeficiencies, children with HIV, children with malignancies, children with long-term salicylates, children on long-term steroid therapy. If there is a household contact of immunocompromised children in that house, adolescents who have not had varicella in past and who are varicella negative, children with chronic lung or heart disease, seronegative adolescents, adults if they are inmates of working in the institutional setup, and then post-exposure prophylaxis in susceptible, healthy, non-pregnant contexts. So these are the indications for giving this vaccine to age group. The recommendation of varicella vaccine is for 2 doses. So now ACVIP in the last recommendation has said that there is a robust evidence for a primary vaccine failure following first dose of varicella vaccine, and there is a limited evidence for secondary vaccine failure. So looking at that, a short interval between 2 doses of the varicella vaccine might be preferable to reduce the breakthrough varicella, especially in countries of poor coverage where the wild type virus circulates predominantly. So it includes the country like India. So second dose of varicella vaccine should be preferably administered 3 to 6 months after the first dose. So in the past, there was a recommendation of giving second dose at 4 to 5 years, but now the recommendation has changed and second dose should be given after about 3 months of the first dose. So friend, experience of next generation varicella vaccine, which shows that almost near 100% antigenic delivery, effectiveness is close to 91%. India and international clinical trials on more than 2 lakh subjects has shown the breakthrough is with 2 doses is almost negligible or 0%. There is an enhanced stability up to 36 months. More than 95 million doses have been consumed worldwide of this next generation vaccine. It is pre-approved by WHO as a manufacturing facility, the only thermostable vaccine which is available at present, and end-to-end protection to the antigen when this vaccine is administered. So these are the advantages if we are using this next generation varicella as compared to other brands. So friends, my plea to all of you is that we should vaccinate all the children with the varicella vaccine, preferably with this new next generation varicella vaccine, and that will go in a long way and protect children from serious complications as well as from their scholastic or school absenteeism, so as there is no support. Even if the child gets a disease, even if it's a mild disease, the marks that is left in the children are for a long time, and some of them that create cosmetic problems also. And so it is better to protect the child rather than allowing them to suffer from a disease. Thank you, friends. If any question, it will be a pleasure to answer them.
Thank you, Raju sir, for the nice crisp lecture on varicella vaccine.
When was it available in India? First vaccine that was introduced in India was 1998-99, when the GSK company had, brought that vaccine. So that was the first time. Thank you.
Now next we have a panel discussion on interesting cases in a nephrology. I would like to invite Dr. Fagun Shah sir. He is a pediatric nephrologist from the Surat city. He will moderate the session. Along that, I would like to request panelists to join the discussion. And for that, I will invite Dr. Pankaj Bhansali, Dr. Kanav Anand, and Dr. Yagnesh Popat.
Well, I thank the MOC to have done the beginning of my job of calling my panelists to the stage. So thank you, Ashwini, for that. And so at the outset, I would like to thank the organizing committee as well as my parent body SPAC to give me this opportunity. Well, friends, it's definitely a very difficult session after the lunch because after such a delicious meal which you have relished, it is very difficult to abstain yourself from the dosing. But me and my panelists will try our best to keep you awake. So as far as the interesting cases in nephrology is concerned, these are not a very novel case or something out of the blue. These are simple cases which we see in our OPD. But many a times when we see these cases, we fail to understand some simple cues. And as a result of which, the whole case sometimes becomes botched up and we end up doing unnecessary investigations. So me and my panelists will try to make the things very simpler for all of you. So my first panelist is Dr. Yagnesh Popat. I don't think he requires any introduction. An eminent pediatrician from Rajkot, has held many key positions at the central level, state level, and also at the IAPID chapter. My second panelist is Dr. Pankaj Bhansali, a very young, dynamic pediatric nephrologist, a friend of mine from Aurangabad. And again, he's very apt at giving many lectures at the national as well as state level conferences. And my third panelist, again a friend of mine, a very young, dynamic pediatric nephrologist, consultant at Gangaram Hospital at Delhi. And he's also very apt at giving lectures not only at the national and state level, but also at the international level. In fact, last weekend he was in Delhi. So I just told him in the morning, then I hope you don't give us an Omicron scare. So with this, I start my first case. So
Okay, so this is a 3-year-old girl having burning maturation for 3 days. The child is otherwise afebrile, playful and active. Now friends, look at these two important symptoms which are narrated by the mother. There is pain and irritation which is persisting throughout the day, and the child feels relief on splashing water to the vulval region. The urine microscope is showing a pus cells which is 15 to 20 and proteins of +1. Now normal narrative for a pediatrician would be to send a culture and start with the antibiotics. So my question to Dr. Yagnesh Bhai would be that will you follow this narration or you have something else in your mind for this patient?
Good afternoon, friends. Looking at the urine routine micro examination, the pus cells are definitely positive, 15 to 20 pus cells per. And as per definition, more than 5 pus cells in a centrifuge sample and more than 10 pus cells in an uncentrifuged sample, it should be considered positive as a pyuria. It should not be labeled as UTI. That is what is the difference here. If you have an UTI, usually you will find plenty of pus cells, not just 15, 20, 30 pus cells, unless the child is already on antibiotic. Here the antibiotics are not utilized. Then can we go back to the previous slide? So as far as the first slide is concerned, where you pointed to important points, pain and irritation which persists throughout the day.
Yes.
If suppose it is an UTI, usually pain is peri-urination. Peri-urination means just before urination, during and just beyond urination, not all throughout the day.
Absolutely.
And the second, splashes of water to the vulval region relieves the irritation.
Absolutely.
So if that relieves the irritation, it is usually a local irritation, not the inside the urine. So these 2 points, as well as the urine routine micro, does not confirm it to be a UTI. If you want to have a confirmation, you should have a culture, and only then you should start. Here probably it is a local infection or inflammation, which is probably a cause of an pus in the,
Okay, so you have done a local examination, you have found complete inflammation of the vulvovaginal region.
This
so
is
it is a vulvovaginitis. So every time pus cells on the urine doesn't mean it is a UTI. It is very, very important that you take into consideration the important symptoms which is told by the mother. So sir, can you just tell what is the male equivalent of such a condition? In the males, if you find such a condition.
Balanitis prostata.
Absolutely. So balanoprostatitis is a condition in the male which might also have the similar symptoms and signs. Sir, many a times with a patient having a UTI, a female child rather, and you see, you do a local examination and you find such a condition. So can you elaborate this condition in females, especially in context with the UTI?
Yeah, definitely. In such a case, there are also increased chances of urinary pyuria rather than a UTI. It should be labeled as a pyuria. So there are definitely increased chances of pyuria.
Yes, Pankaj, you want to add something?
Yeah, so there is a adhesions at the level of hymen, and so it causes sort of stagnation of the urine while voiding, and that itself will work as a good culture media for bacteria. And we know in pediatric it is all retrograde urinary tract infection. So bacteria travels back from urethra into the bladder and kidney. So this works as a high risk factor for recurrent urinary tract infections. So whenever a child comes with urine infection, we should make sure that we have examined genitalia to look for phimosis and adhesions, vulval adhesions in girl child.
So point well taken. The local examination is very, very important because it will give you a lot of clues, and in fact, it can also tell you what is the risk factor for the UTI. So next up, this is a 4-year-old male child having oliguria edema for 1 week. There is no hematuria, no fever, no lower urine tract symptoms in the form of urgency, frequency, etc. There is no hypertension. Now, as far as the investigations are concerned, the urine is showing a proteins of +2, pus cells 15 to 20. There are 10 to 15 RBCs, and there are granular and hyaline casts. Because the child was having edema, you just saw there was a pitting edema on the lower limb as well as the child was having ascites. So we did a cholesterol which was 320, albumin of 2.1. And the USG was showing edematous kidneys, mildly echogenic parenchyma, and echogenic debris in the bladder. The impression which was given by the radiologist was acute pyelonephritis. So Dr. Pankaj, what do you think? We should treat as acute pyelonephritis in this patient, or it is a nephrotic syndrome with UTI, but still you would need to start an antibiotics. What will be your take on this?
Acute pyelonephritis is not a sonography diagnosis. It is clinical presentation with urine examination. And in this child, there are no symptoms which suggest towards urinary tract infection. So the findings like edematous kidneys with mild echogenic parenchyma does not mean it is urine infection. Any inflammation, whether it's a form of acute glomerulonephritis, nephrotic syndrome, urinary tract infection, or even ATN, all these can cause edematous kidney with echogenic parenchyma. So that does not equate with pyelonephritis. And then another common finding, echogenic debris in the bladder, which sometimes is mislabeled as a cystitis also. The cause of debris in the bladder are innumerous. It can just start from high-grade fever, exercise, any medications, any dehydration. All these can cause debris in the urine, in the bladder. So debris does not again equate to urinary tract infection. Now in this child, we have edema with hypoalbuminemia, raised cholesterol, and urine albumin also positive. So definitely diagnosis is nephrotic syndrome. Then question remains about pus cells. As sir has rightly pointed out, pus cells more than 5, generally we qualify for urinary tract infection. But again, pus cells are not equal to urinary tract infection. That's why sometimes we call it as a leukocyturia rather than pyuria. And one of the condition where we can get inflammation is nephrotic syndrome or even glomerulonephritis. So presence of pus cells with absence of any clinical symptoms, we should not label it as urine infection. Not only this child, so from my point of view, it is a simple nephrotic syndrome. Sometimes we do get RBCs in nephrotic syndrome. Incidents had shown that 20% of minimal change disease can have microscopic hematuria, and even 2% can have gross hematuria also. But yes, gross hematuria, we are not going to ignore, that definitely we are going to evaluate. But presence of microscopic hematuria at the onset of nephrotic, we don't need to jump, and conclusion should not be pointing towards something like mixed nephritic and nephrotic syndrome. We can follow up this child, and if these RBCs subside, probably it is still minimal change disease.
Absolutely, a point well taken. So there are 3 important points over here which is covered very nicely by Dr. Pankaj. One is the presence of echogenic debris which doesn't equate with the pyuria. Second important thing is the RBCs in the nephrotic syndrome, especially the low-grade RBCs might be present when the child presents with a nephrotic syndrome which goes off. So you don't need to jump, especially when you don't have any hypertension or any altered parameters of renal functions, etc. And third very important thing which is also brought out, and also by Dr. Yagnesh which was brought out, is the causes of pyuria. And inflammation, in fact, in any part of the body can lead to pyuria apart from other causes like fever, So like fever, calculi, acute glomerulonephritis, nephrotic syndrome, dehydration, and even in adolescent females, the epithelial cells are mistaken as or misread as pus cells in the urine. Okay, so we come to the case 3. So this is a 7-year-old boy, recurrent abdominal pain, not very specific, doesn't hamper with the routine activity. There are episodes of dysuria which is relieved by alkalinizer. There are no urinary complaints, and there is nothing specific on examination. The child is thriving absolutely well. So we come to the urine microscopy here. The appearance is a bit turbid. Proteins are nil, pus cells are 10 to 15, and the RBCs are 4 to 5 with an OBT which is positive. Again, the USG abdomen is showing increased bladder wall thickness, and which is commented as likely cystitis. Actually, I was quite obsessed with this likely cystitis and OBT which is positive, especially with the pus cells and non-specific abdominal pain or this dysuria. So I just gave multiple course of antibiotics, but it was all in vain. So Dr. Kanav, what do you think? I mean, are we right in giving antibiotics over here in context to this OBT positive or this cystitis, etc.?
Fine. So basically, since the pus cells are there and the ultrasound also reported as cystitis, so most of our fellow pediatricians will take it as a UTI and maybe treat like a UTI. But remember, get a urine culture done. If the culture is positive, then only think of infection and treat it off. If culture is negative, it may be that the child does not have a UTI at all. So just do not randomly give antibiotics. Second thing is, in a child, labeling cystitis is not an easy job. So on an ultrasound, you should make sure the bladder is full. That means at least 80% of the expected bladder capacity should be full, and then only you should check the bladder wall thickness. If it is more than 2 mm, then only it is labeled as cystitis, or you can say increased bladder wall thickening. But most of the time, small kids may not be holding urine to that level, and the ultrasoundologist subjectively feels the bladder looks thickened and he reports it as cystitis. So get into the habit of asking the radiologist what is the bladder wall thickness, especially in a scenario when the bladder is full, not in an empty bladder or a partially distended bladder. Second is if it is not UTI, then what can be? Like other differential diagnosis of increased bladder wall thickening other than UTI. So one is can be crystalluria. If you have any kind of salts or crystals that you're passing or calculi that is there, so that can cause irritation of the bladder and it may get thickened up, which can cause RBC in the urine also. Second scenario can be children with voiding dysfunction. So if you have a problem where your bladder outlet is slightly, you can say tighter. So your bladder or the detrusor muscle contracts against a tight sphincter. So because of which the bladder gets slightly thickened and trabeculated. So these are the reasons where you can get all these pictures. So dysfunctional voiders, children with overactive bladder, children with chronic constipation. The chronic constipation, the rectal loading that is there, that compresses the bladder from behind and then again it gets thickened up. So there are n number of reasons why your bladder can get thickened up other than UTI. So if your cultures are negative, child is not improving with antibiotic, think of the other DDs as well.
But what about this OBT which is positive? Is this significant? I mean, there are many times when we get the urine microscopy report and it is written OBT positive, and many of our friends are very much obsessed with this OBT positive and they just think that the child is having some serious or some sinister renal issue.
OBT is part of your routine microscopy where they do a dipstick method.
Absolutely.
So in the dipstick, if they said blood is positive, you are supposed to see how much are the RBCs there. So if your RBCs are more than 2, yes, it is significant, but then find out what is the cause.
Yes. So basically the occult blood is tested on the dipstick and we have this chemical method where the principle is the oxidation of the phenols and it is done by the heme. So even if you have 1 or 2 RBCs, it can lyse and it can lead to the OBT positive. So it is a very sensitive marker. In fact, the OPT, I think the panelists will agree that it is used to differentiate between hemoglobinuria and the RBCs in the urine, especially when you have a high cola-colored urine. But the most important point here is the bladder wall thickness, because 8 out of the 10 ultrasounds, even if we do it for some other reasons, for some other ailment, we get this bladder wall thickness and sometimes we are confused. But I think all my panelists will also agree that cystitis is basically more of a clinical diagnosis where the patient will have lower urine tract symptoms in the form of dysuria, urgency, frequency or urge incontinence. So just follow up of this case, the father had an history of calculi. So we did an urine calcium create ratio which was increased and was confirmed of 24-hour urinary examination to have a hypercalciuria. So this is a fourth case. 3-year-old male child having cough, cold, fever, anasarca and edema. Classically diagnosed to have a nephrotic syndrome. But because the child was having URI, so treated with diuretics and symptomatic treatment for the URI. But after 5 to 7 days, you can see that the child is absolutely gone into a clinical remission. The urine albumin is nil. So normally what we consider this as a spontaneous clinical remission. So Dr. Yagnesh Bhai, what will you do here? Will you start with steroids or you just want to wait for a couple of weeks so that we can say that the child is again having the relapse or something like that?
Here is a patient who has an acute respiratory infection which has precipitated nephrotic syndrome.
Yes.
On symptomatic management, it seems the child is in remission because urine albumin is nil. But urine albumin is a qualitative test, not the quantitative test. So here one should have a quantity of albumin which can be found from the 24-hour urine albumin, or maybe you can have a urinary protein versus urinary creatinine ratio. And if that does not show the presence of any albumin, you can label it as remission, not otherwise. So you should have that ratio with you.
Yeah, so this child is having a ratio of around 3.5 milligrams.
So that is positive.
Okay.
So more than 2 is considered to be having a nephrotic range. So this is still a nephrotic syndrome, not in remission, and hence one should definitely start a steroid here.
Yeah, but what is the reason that the albumin is nil and still the protein create ratio is high?
Because the child has been already on diuretics. So because of diuretics, the urine amount has increased. So the percentage of the albumin per ml of urine has decreased.
Yeah, so the false negative results, because when we are doing a urine microscopy examination, especially to the dipstick, it can give a false negative result, especially if the urine is diuretic or having a low specific gravity or when the urine is acidic. So this has to be taken into consideration, because normally what we were following in our old guidelines was that if the child is having +1 nil trace, then we consider that the child is in remission. And only if it is +2 or more, we used to treat it or consider it a relapse. But here now, the guidelines have changed, which embarks on the use of a protein creatinine ratio. So here they embark on the quantitative estimation of the urine to confirm whether the child is having proteinuria or not. So now the same patient has completed 6 weeks of daily steroids.
Dr. Faguna, can I add something?
Yeah.
So one again take-home message for the pediatrician is, how does the parent check the urine with the help of a dipstick? Because most of the time they are doing it at home with a dipstick. And they said, okay, urine protein looks negative on the dipstick, but protein creatinine ratio is high, child looks edematous. So this is a common problem that we face in our OPDs. So here you are supposed to ask them, how do they do it? Because most of the time they will not be doing it correctly. The current dipsticks that are available, the way it should be done is, take out the dipstick, make sure the starting color is yellow of the stick. It has to be dipped in, taken out, the extra urine has to be struck out. After that, wait for 60 seconds by the watch and now check it on the color panel. Because currently the dipstick that are available on the market says, under the PRO protein, it says 60S, that means 60 seconds. So if you randomly ask the patient, some says I just dip it and then check the color, some say I wait for 2 to 3 minutes, some say I wait for 30 seconds. So these are color based tests based on the time. So if it's a 60 second means dot at 60 seconds, you're supposed to check which color is it. If it is not giving 60 seconds, that means it will show falsely less amount of protein in the urine. So if it just dips and checks, it will be negative. But after 60 seconds, it may show 2 to 3. So you're supposed to ask, how do they do it?
Okay. So can we go ahead? Yeah. So the same patient has completed 6 weeks of daily steroids. He's now on alternate day steroids for 2 weeks. There is no edema and urine albumin is +1. So again, what will you do? Continue treatment?
Same principle.
Okay, so again,
as we had considered last time.
Okay, so the urine protein create ratio is high again, 2.5, so the child has relapsed. So Dr. Yagnesh Bhai has already cited the importance of the quantitative estimation, which can be done by 24 hours urinary protein, or it can be done by a protein creatinine ratio, which is more feasible in our pediatric patients. And we all know the range for the 24-hour protein, it is more than 40 milligram per meter square per hour, and for a protein creatinine ratio random sample, it is more than more than 2. So we come to this fifth case. This is a 1.5-year-old male child, a known case of posterior urethral valve, which is fulgurated. The child is having bilateral hydronephrosis, hydroureter bilateral scars. The weight is 7 kg. The child is, you can see, having severe failure to thrive. There is severe polyuria, polydipsia. Now here the creatinine which is mentioned is 0.9. Mind well, the normal range which we get for most of our laboratories in the report is around 0.7, 0.8 to 1.2. So here it is 0.9. Urine microscopy is showing a specific gravity of 1.005. The urine albumin is nil and rest is normal. So there are no pus cells in the urine. So Dr. Pankaj, I will like you to comment here on 2 important things. One is, what about this creatinine? Is it normal? Because our lab is mentioning the range of around 0.7, 0.8 to 1.2. And second important thing is that in this urine microscopy, normally with the patients with PU valve, we just always look at the pus cells, whether the child is having UTI or not. We don't look at other things. So what else you will like to look for and why?
Yeah. So creatinine normal value we all know is 0.8 to 1.2 for adult. But for pediatric, body muscle mass is quite low. So obviously creatinine value is going to be on lower side. For a 1.5-year child with weight of just 7 kg, his body mass, muscle mass is quite low. So creatinine production is low. So I will expect creatinine somewhere around 0.4 or at the most 0.6. So increase in, there is a definitely rise in creatinine. Again, which method we use also differs, because generally picric acid method slightly overestimate creatinine, but most of the labs are now following modified picric acid or enzymatic assay. So creatinine of 0.9 in a reliable lab is definitely high. So already child, and we all know that creatinine start rising once renal function has dropped below 50%. So that means already child is in CKD stage 2. So in this child, definitely creatinine is increased. Now second thing, we do see particularly in any urological problem, we look for pus cells, but we always ignore for specific gravity. When specific gravity is less than 1.008, that means it is a hypoosmolar urine. And in this urine, protein estimation cannot be relied on spot test. We again need to quantify. Now in this patient with posterior urethral wall, there can be 2 forms of proteinuria. One can be tubular. Because of obstructive uropathy, there can be tubular damage and cause proteinuria. And second can be glomerular because of CKD. So again, we need to quantify. And if there is a significant proteinuria, that is protein creatinine ratio 6, we need to add ACE inhibitors provided creatinine and potassium are well maintained. So in this child, any urological problem, whether it's a high-grade reflux, posterior urethral wall, we do need to monitor proteinuria for long-term consequences, because decreasing proteinuria do have long-term positive effect on renal functions.
Yes, so we need to reduce the proteinuria by ACE inhibition so that we can prevent the hyperfiltration injury. That is number one, I think. And number two is the GFR, which we need to see, because many a times, as mentioned by Dr. Pankaj, that the creatinine might be low because the body mass is low, because as you all know that the creatinine is the product of the body mass. So we might have a low creatinine value. So you need to calculate the GFR. And how will you calculate the GFR, Pankaj?
So GFR for pediatrics, it's a simple Schwartz formula, which it's simple to use in our routine OPD practice, where according to age, they have given some different parameters, but 0.5 we can consider as a uniform criteria for child, particularly when he is more than 2 years of age. 0.5 into height in centimeter and divided by serum creatinine, KL upon creatinine. And generally more than 75 to 80, we consider it as a normal. If it is below that, we need to consider there is already CKD stage.
Okay, so we talk a lot about this CKD, chronic kidney disease, and initially we used to coin the term as chronic renal failure, but now this term is obsolete. We use the chronic kidney disease, and it doesn't depend upon the creatinine, mind you. So can you just give us a very brief account of this chronic kidney disease? What is it, or in short, the definition, and how do we look at it?
Chronic kidney
disease. Just very brief.
Okay, so any renal dysfunction, whether it's a function, anatomy, or physiology, which lasts for more than 3 months, we label it as a CKD, chronic kidney disease, and then we divide it, then we classify according to GFR. More than 90, we generally consider it as a normal, but normal is, we all know, more than 120. So 90 to 120 is grade 1, and then we divide by 60, 30, 15, and below 15 as GFR calculation. And stage 5, that is less than 15 ml GFR, is an indication to start dialysis and prepare for renal transplant.
Yes, so this is a very important point, that we don't use the term chronic renal failure, and we don't judge our diagnosis or give our diagnosis simply on the serum creatinine values. We need to have a look not only at the function of the kidney, but also the physiology and also the investigation. So by this virtue, if your child is having a bilateral hydronephrosis and hydroureter, then also it can be considered to be a chronic kidney disease with a normal GFR. So this is a 6th case. Now this is an 8-year-old male child coming with edema, oliguria, hematuria. There was a history of fever 7 days back. The child was admitted with some general practitioners and was given some IV medications for the same. Initially the child improved, but after 7 days when the child came, was having these symptoms. The examination was showing a generalized edema ascites, a BP of 120 over 80 millimeters of mercury. So Yagnesh, is this hypertension, this 120/80, because in adults this is quite okay to have this blood
pressure? It is for adults, as you said.
Yeah?
It is okay for the adults, not for the pediatric patients. So this is a case of an infection which has led to an acute glomerulonephritis, probably because there is a generalized edema, including ascites. Blood pressure is definitely on the higher side, and one should investigate for it, definitely, acute glomerulonephritis.
Okay, so Dr. Kanav, if this is an hypertension, then in case if you want to know what is the cut down limit for an hypertension for a child, say for example this child, then how will you do so? What are there any measures for the cut down limit of the hypertension for different age groups?
We have the charts provided by the American Health Society, so which goes as per the age, the sex, as well as the height of the child. And depending on that, for every percentile, you have a different cutoff for the systolic and the diastolic BP. So we use those charts, which can be kept in your OPDs just to cross-check whether the child is having hypertension or not.
Yeah, so it is very, very important. We don't consider this as a normal blood pressures, and it is very, very important that we have the BP charts. It depends upon the height centile, and depending upon the centile, we need to look at the cut-down limits. Anything above 90th centile is considered as an hypertension. So going ahead, this child, now the investigations are showing a hemoglobin of 10.2, counts up almost normal. The platelets are on the lower side. Creatinine is higher side, 2.6. Electrolyte showing hyponatremia, hyperkalemia. And the urine is classically brown, showing proteins of +2, pus cells 4 to 5, but the RBCs are plenty, USG reporting as echogenic kidneys and ascites. So definitely the child is admitted. So now Dr. Yagnesh, as you said that the child probably is a post-infectious glomerulonephritis, but looking to the reports, the child having a high creatinine, low sodium, high potassium, hypertension. So if you admit the child, how much fluids will you give? What fluids will you give? Whether you will give fluids or not? What things you will monitor in this patient, and really what are the danger signs in this patient or red flag signs in this patient?
First of all, when the child is hospitalized and child is not in a position to take orally, one should definitely give an IV fluid. but one should restrict the fluid because the child is already on the oliguric stage. So the output will be definitely affected. So because just there is an electrolyte imbalance, you initially tempted to give a sodium and increase sodium in the urine, in the IV fluids, as well as you want to decrease the potassium. But you should not be overactive. You should restrict the fluid. Insensible loss should be definitely covered. You should monitor input-output chart. What is the input of the child and what is the output? Depending on that, you should titrate your fluids definitely. In addition to urine output, you should definitely look at the blood pressure, which was very high. So you should monitor the blood pressure at a regular interval. The weight of the child also should be monitored because it will also indicate whether edema is increasing or not. So apart from the vitals, of course, vitals has to be monitored in all the hospitalized child individuals. But apart from this, these three things should definitely be monitored. And definitely we are worried about the failure because if we are giving a fluid on the higher side and if child is overloaded with the fluid, it may lead to the CCF. So one should definitely be worried about it. One should not do it.
Okay. So 3 important points: fluids, restricted fluids, most important. You can give an insensible plus urine output. Number 2, you should be worried regarding the potassium. Potassium can kill. Number 3, you should be worried about the fluid overload. It can lead to pulmonary edema. And number 4, the hypertension, because it can lead to its own consequences. If the child is taking orally, you can give oral fluids, but don't look at the sodium, because this sodium could be, I think, Kanav, it could be because of the hyponatremia because of?
In this patient, it's not low because the patient is not consuming less amount of sodium. It is because of dilutional hyponatremia. There is a fluid collection that is then fluid overload state, because of which the sodium has gone down. So restriction of fluid is actually help you to get the sodium up. On the other hand, if you give sodium containing fluids, that will increase your hypertension. So you have to refrain from giving too much of sodium as well.
Yes.
Yeah. And another thing about potassium, we should ensure that these kids don't get any food containing potassium. And
Absolutely.
same thing about IV fluid. Most of the intensivists now suggest that ISOP, potassium containing isolate P, should not be there in pediatric floor itself. And particularly in these kids, no fluid with potassium should be there, even if creatinine is normal. Because most of the AGN patients do have decreased GFR. And adding potassium in this fluid can cause severe hyperkalemia. So even if creatinine is normal, try to restrict potassium in food as well as fluid also.
Absolutely. So, Dr. Kanav, what further investigations will you advise to confirm your diagnosis?
So since we are thinking of post-infectious glomerular nephritis as a first DD, so one will do a ASO titer. So ASO titer should be high and it should be more than 200 in case we are thinking of post-streptococcal glomerular nephritis. Second, in case it is post, you can say a skin-based infection which had led to this, then an anti-DNase B can be done. Thirdly, a C3 level to be followed up, which will be low if it's post-streptococcal glomerular nephritis. Follow the creatinine trends, see where it goes, see the electrolytes, and follow your blood pressures as well. So this is what is most important. Yeah.
Okay, absolutely. So definitely, as you mentioned, the C3 is low, the ASO, DSD, and etc. was done, which was normal. But the most important thing was that the child was initially having a low platelet. So I repeated a platelet, and the platelet is still falling. So now, what is this? Because we don't expect in a post-infectious GN the platelets to fall down. So are we dealing with some other pathology over here?
So it can be one. It can be an infection which leads to low platelets. Something like a dengue fever can be there, or any other infection which can lead to the low platelet. But then you have to see in what environment are you seeing. So it's a dengue outbreak that is there, you can think of that, or a severe sepsis. Secondly, DDs like for the PIGN can be a hemolytic uremic syndrome. In hemolytic uremic syndrome, you get low HB anemia, which is a microangiopathic hemolytic anemia. Secondly, there will be thrombocytopenia, and thirdly, you will have an AKI, acute kidney injury. So all the triads are there in this patient. So a DD of HUS will definitely be considered, for which maybe we can do a schistocyte index, an LDH level, and which helps you in a reticulocyte count.
Okay, so we have done a fragmented RBCs because we don't have a very advanced laboratory, but the pathologist is quite sure that the RBCs are, the schistocytes are very, very occasional and doesn't look as any sort of RBC damage, or we can say that there is any hemolysis in this patient, though the LDH might be high. So he is completely ruled out that there is no HUS. So what it could be? So now actually Dr. Yagnesh Bhai thought that he's a very witty pediatrician, so he thought that the child is coming in a dengue environment, and so he did the investigation.
Even the malaria
of a
should be
dengue serology.
DD here.
Yeah, so he did a dengue serology which was positive. The patient was hypertensive. Mind well, this is a dengue fever. The patient was not having any sort of hypertension or no white pulse pressure, otherwise okay. But there was an hypertension. So this was simple dengue fever. Probably the platelets were falling because of the child coming in 57 days of life. And this could be a PIGN secondary to dengue fever. Because if I go with the further course, the child treated with fluid restriction, antihypertensive diuretics. There is a gradual improvement, urine output, BP settled, edema decrease. CBC showing now an increased trend of platelets and the creatinine decreasing. Okay, so every time we see a case having a hematuria, the point here was as hematuria or an oliguria edema, we have to think of the lateral causes apart from PIGN, because D negative HUS also can be an important feature. And second important thing is that we should also take into consideration the local environment and also the other infections which could also sometimes manipulate your results. So this is a seventh case, 8-year-old, sir? Yeah, it was around 8-year-old female child, and C3 was low, and we were classically, we were classically seeing a course which was seen in the post-infectious GN. We cannot rule out if the child might have not improved in a couple of days, then we could have considered alternative diagnosis of a low C3, which could not be simply SLE. It could be an MPGN or other causes as well.
So that's why it becomes important that when you're following up a patient of PSGN or a PIGN,
yes,
and the C3 is low, follow them up, make sure the C3 comes back to normal. If it does not, then your DDs of SLE, C3GN, everything MPGN comes into picture. So you should always follow them and make sure everything comes back to normal before you let them off.
Absolutely. So we come to the seventh case, 8-year-old girl child, history of mild fever, cough for 1 week, treated with antibiotics. Now it is just opposite to what we saw. After 7 days, now the child is passing more urine. And, sorry? So C3 improved because basically, yeah.
And Fagun, whether do you come across the HUS now?
Sorry, sir?
Hemolytic uremic syndrome, whether do you see in the practice?
Yes, sir.
Yeah, HUS is a common entity which we see very routinely. In fact, we were not able to pick it up because we are not seeing it. So nowadays, many of the patients we pick it and they classically also present with such infections. Such trivial infections may just, trigger the complement pathway, and they start developing, the hemolysis, the thrombocytopenia, and they may have this hematuria, the classical presentation which we see in PIGN.
Just a point, I think, as a general pediatrician, what we are having the impression that commonly either the following dysentery or Shigella or these invasive E. coli varieties, this toxin will be liberated and responsible for the HUS in the past we used to see. Following the good antibiotics and I think properly management, now hardly we come across practically the HUS. I think that's our impression as a general pediatrician, and it is a statement. And suppose as a nephrologist, if you come across what other infections or toxins you are considering for the HUS. I'm sure that this practically now we even discuss and say even in ID chapter also that hardly now HUS is seen in our daily practice.
Sir,
our panelists can just comment on this,
sir,
regarding
HUS
the D negative
initially,
and D positive.
what we thought, particularly in developing world, was infection-related HUS, what we label is as a typical hemolytic uremic syndrome. But with the use of antibiotic, early use of antibiotic for any diarrhea, the infection-related HUS is significantly low, whether it's E. coli related or Shigella. Shigella was more common in our continent. But now atypical HUS, whether it is related to H factor deficiency, I factor deficiency, or autoimmune antibodies against these factors, those numbers are significant there. And if we go in Western world, developed country, HUS remains one of the commonest cause of acute renal failure above post-infectious GN. In India, still PIGN is more common, but there HUS remains higher on card. So
sir, I think in short, it is basically a D negative HUS, and it is a mutation in the genes which code for the proteins of the alternate complement pathway, which can lead to this sort of HUS. And here the treatment of choice is plasmapheresis. Okay.
So I'll agree with what you said, sir. It's a changing paradigm. So 20-25 years back, it was D positive, which was gone. Now it's D negative. But as I said, there's other infections also which can cause it. Currently, in our hospital, there's a child who's admitted with D positive HUS, came with dysentery, and the stool biofire revealed it's a Nova virus. So that virus itself has triggered the HUS in that patient. A couple of weeks back, we got pneumococcal infection causing HUS. So it's a different spectrum which is coming up now.
Yeah, I think we are running short of time. We have 3-4 more cases to complete. So we'll just quickly run through these cases. So I think this case, I will just again revert back. This is an 8-year-old female child having cough cold for 1 week, treated with antibiotics, and now the child is passing more urine, on contrary to the fact that the previous child was passing less urine. And the microscopy is showing a specific gravity of 1.005, sugar of +1, pus cells of 8 to 10, and RBCs of 6 to 8. So Dr. Pankaj, what do you think are we dealing with in this child? Definitely it is not a PSGN, I guess.
Yes, so there was a fever with history of medication, and now RBCs, pus cells, proteinuria, and at the same time there is a glycosuria. And there was polyuria also. So definitely I will like to rule out first diabetes, get his blood sugar done, and creatinine. So blood sugar is normal, so diabetes is ruled out. So creatinine increase in setting of fever with some medication without hypertension. So there can be, again, one possibility remains acute glomerulonephritis, and other thing can be interstitial nephritis.
Yes.
Because when there is a proteinuria, glycosuria without hyperglycemia, there is definitely tubular dysfunction. The tubule is hampered, so the more common differential will be interstitial nephritis. And we are seeing a lot of cases with drug-induced interstitial nephritis. Generally, we don't consider so much important, but for AKI, when we biopsy, almost 20 to 30% can have interstitial nephritis. And recently, I had 2 patients with anuric renal failure, secondary to either cephalosporin or mefenamic acid, generally which we consider it as a harmless medicines.
Yeah. So any drug or any viral infections can lead to interstitial nephritis, where we classically have a tubulo-interstitial pattern. 60 to 80% of the time it is a non-oliguric renal failure, but it could have a oliguric renal failure. Quickly, this case, 7-year-old female, height 87 centimeters, weight 12.7 kgs, multiple bony deformities. You can see upper limb, lower limb, and also you can see the X-rays. They are just simple thin paper, thin cortex. Matrix is absolutely, we can't see any matrix. The child is not able to stand and walk. In fact, this was after the treatment, mind well. The child is having polyuria, polydipsia, and had received many doses of vitamin D. The examination otherwise is normal. So, Dr. Kanav, these are the investigations, and the child has been to multiple pediatricians and other doctors. Everybody has treated them as rickets, and everybody has given them doses of vitamin D. Right. So, this is the result. Now, what next will you do in this patient?
So, basically, this looks like a non-nutritional rickets because we have treated it well and still there is no response. Vitamin D level, this is the 25 hydroxy D3 levels which are normal. And calcium continues to be low, phosphorus low, ALP is high. So, in the setting when the creatinine is normal, I will think about scenarios like a renal tubular acidosis, RTA-like scenario, or renal rickets. Okay. So I'll like to check the bicarb levels.
Okay, so these are the second set of investigations. Now, can you interpret this result?
So this shows metabolic acidosis, the bicarbs are low. The electrolytes are more or less normal, but you can say the potassium is low normal and the chloride is high. So it's a hyperchloremic, maybe a normal anion gap metabolic acidosis, which fits into an RTA, mostly a distal RTA, because simultaneously you have a high calcium creatinine ratio, that is hypercalciuria, that has been there. And PTH levels continues to be on the lower side. So it's mostly a distal renal tubular acidosis.
Definitely. Yeah. So basically the point here is that any of the patient, if is not responding to the routine therapeutic doses of vitamin D, you have to think that the child might be having some renal tubular disc problem or some other problems. And the most important thing which you do here is basically a blood gas, electrolytes and a creatinine, because this will mostly clarify your dots. And you can easily see here, there is a normal anion gap metabolic acidosis with hyperchloremia in a setting of a normal renal function. This is renal tubular acidosis. But Dr. Pankaj, now this is the same set of the patient. You can see again short stature and bony deformities. But you can see the investigations over here. The creatinine is 5.17. Otherwise, other things are same. Apart from that, the anion gap is high. So now what is this over here? You can also see the phosphorus is also high over here.
Yes. So now in this scenario, I think before starting vitamin D, when we have RTA with short stature, polyuria, polydipsia, straight away diagnosis is a non-nutritional rickets. So if child presents with rickets, with short stature and this polyuria, polydipsia, I think before starting vitamin D, get evaluated thoroughly, because unnecessary we'll end up giving high dose vitamin D and worsening renal function by nephrocalcinosis. Now here, creatinine is increased with hyperphosphatemia, hypokalemia. So it straight away goes towards chronic kidney disease. So RTA and CKD both can have similar features where creatinine can help in differentiating between RTA and CKD. And second will be anion gap. In CKD, anion gap will be wide once creatinine renal function drops below 30 GFR. So wide anion gap with deranged creatinine and hyperphosphatemia, it's CKD.
Yeah, so what is the difference in the treatment of a RTA and a renal osteodystrophy, which I think is the condition?
Now in renal osteodystrophy or bone mineral disease, here first treatment will be control hyperphosphatemia. We can't add calcium or vitamin D unless phosphorus levels are well controlled. Otherwise it will precipitate and cause vascular problems. So first phosphate binders, and once phosphorus is under control, we need to add active form of vitamin D because vitamin D sachet will not have any effect on these bones. So active form of vitamin D after control of phosphatemia.
Yes, so very, very important because here the kidneys are damaged. So the conversion of 25 OSD to 125 OSD will not occur. So you have to give here 125 OSD, this calcitriol. I think we can just skip this, come to the ninth case. This is the second last case. 8-year-old male child, 22.5 kg weight, increased frequency observed for 1 year. Mother is telling categorically that the increased frequency is observed only since last 1 year. No urgency, no urge incontinence, normal urinary stream, no bedwetting. The child doesn't wake up at night to pee or to even drink water. So Dr. Khanna, how will you proceed here?
So first and foremost, this is what the patient has told us subjectively. So I will like to take an objective evidence to it. What does he mean to say? So basically we'll ask them to make a voiding diary or a bladder diary. Yeah. So on the left hand side we'll make a note of the inputs that the child is taking, various forms of liquids and the quantity of each liquid at various timings. And on the right hand side we'll measure the volume of each void, the frequency of the void and the volume of each void. Yes. So that we have a net input output chart as well and the frequency chart as well. And maybe in addition to this, what we may require is to keep a note of the stool pattern as well.
Okay.
So this is a complete bladder diary.
Yeah, so I have done a bladder diary, but before that, ultrasound is also done. Okay. And before we come to the bladder diary, I will just like you to comment upon this because the radiologist has specifically mentioned the full bladder volume is 300 ml, post-void residue is 5 ml. So in context to this case, can you just comment upon the bladder volume or how to calculate the bladder volume and its significance and importance?
So what was the age of the child?
8 years.
8 years.
Yeah.
So expected bladder volume is age plus 1 into 30. So it is age plus 1, that gives you 9. So it is 9 ounces. So 9 ounces, how do we convert it to ml is into 30. So it is 270 ml. So 300 ml is good enough. Sorry. So basically this is how we calculate the expected bladder volume. So plus minus 35% is the range. So expected bladder volume, if it's 100%, so it can go up to 135% and the lowest is 65%. So that is the range that we have. So that is the expected bladder volume. It reaches the peak or the maximum like an adult by 12 years of age, that is around 400 ml. Yes. And post-void residue is significant if it is more than 20 ml.
Yeah. Okay, so basically here the child is not having significant post-void residue, the bladder volume is okay, so the bladder seems to be okay. And Dr. Khanna had asked for the voiding diary. Before that, normally the pediatricians like us, what we do is this, that whenever there is an urgency frequency, we just think that is an overactive detrusor, we start with cholinergics. This child was also started on cholinergics. The child who had been given the anticholinergics for almost a month without any respite. And as you said, so we asked just for a bladder diary, and this is the bladder diary. On the left side, as you said, is the input, here is the output.
Fagun sir, you have 2 more minutes.
Yeah. After this is my last case. Can you quickly,
the volume, the input is almost to the tune of 3 liters. So if a child drinks almost 3 liters of liquid, definitely the urine output is going to be high. So first and foremost, I will like to cut down the liquid intake and see whether there is a simultaneously improvement in the urine frequency or not. Okay. Secondly, if you see the things that have been rounded, that is the time, you can say the volumes at which the child is passing urine. So if 270 ml is expected bladder capacity and 250 ml is what he is passing, so it is not a scenario of small bladder capacity. So in overactive urinary bladder, what we get is increased frequency of urination with low volumes. So if 270 is my capacity, the child will be passing at 50 ml, 60 ml, 70 ml. So this will be his void volume every time he passes urine. So that is the reason why the frequency has increased. So in this scenario, maybe the polydipsia is actually causing the polyuria and because of which is increasing the volume. Absolutely. So here anticholinergics are not going to help you much.
So rightly said, if you, I just have put this slide to compare, you can see this is a 10-year-old male child and who is having a overacute detrusor, classical urgency, frequency, urge incontinence, and you can see the output, just 80 ml, 90 ml or 100 ml. So this is basically classically a voiding diarrhea of an overacute detrusor. And this child, normal creatinine, normal VBG, electrolytes, everything normal. Osmolality is 650 in the morning sample. So it is almost okay. So this was probably a case of psychogenic dyspolydipsia. Can you just give me 1 minute because it's the last case? Yeah. So I just skip this. We come to the last case. 14-year-old female child complains of turbid urine for 1 month. There is no edema, oliguria, hematuria, no systemic features, no LUTS. I mean, there is no urgency, frequency, etc. The child is normotensive. And this child had been to many pediatricians who have given, because just seeing the turbid urine, they have given multiple course of antibiotics. So Dr. Yagnesh Bhai, what do you think is the cause of this turbid urine, or what are the causes of turbid urine which you will evaluate for?
Yeah, turbid urine can be because of some of the commonest causes, like concentrated urine may cause a turbid. If there is something inside the urine additionally, crystals or pyuria, it will lead to a turbid urine. If stone fragments, in cases of urinary stones or urinary nephrocalcinosis, then it will cause a turbid urine. If there is a mixture of other secretions from the surrounding, vaginal secretions or in male sperms and the other secretion, prostatic secretions, it will cause a turbid urine. And some of the rare causes, chiuria, it will cause a turbid urine. But looking into the color of the urine in this, it looks like a much more a milky urine rather than just a turbid urine. So chiuria, though rare, it could be the cause.
Okay, so I've just done this set of investigations, and as you rightly pointed out, everything is normal. But the protein create ratio is high, but otherwise all the things are normal. Normal calcium create ratio, all the things are ruled out. But as you suggested that it seems to be a milky urine. So we have done a urinary triglycerides which were very, very high. It is 89 in the morning sample. So probably this is a chyluria. So all these things has to be kept in mind. You should have some latent thinking as well when you put forward the case. So to sum up, rare cases are indeed rare. Don't try to seek rare diagnosis every time. History, examination, investigations gives enough clues. Keep your eyes and mind open. Don't bombard yourself and your kids with unnecessary investigations. Keep it simple. And we all pediatricians are like this bus. I mean, we try to imbibe a lot of things in our mind, and since morning you have all been imbibing a lot of things in your mind. And I'm sure that like this bus, you are also, I mean, tolerating and imbibing all these things for a proper long time. So I think me and my panelists have clarified or given you very simple cues and also simple, carry home messages. I thank my panelists for a very excellent, overview of the routine problems which we see in pediatrics. Thank you very much.
Thank you, Fagun sir, for a wonderful panel discussion. I would like to invite Dr. Vijay sir to felicitate Fagun sir and Dr. Verma sir to felicitate our panelist. Now our next topic is immunization dialogue. For the same, I would like to invite our moderator, Dr. Manish Mehta and Dr. Yagnesh Popat sir. Dr. Manish Mehta, he is active dynamic secretary from AOP Gujarat, and Dr. Yagnesh Popat, he is from the Rajkot. He is the president ID chapter. So welcome, sir.
After nephrology, we'll be going for immunization dialogue, which has been the most awaited session in all conferences. Lot of controversy comes, lot of new recommendation comes, and everybody is eager to hear from the mouth that what is there. And we have two more experts sitting in the audience, would be Dr. Abhay Bhai and Dr. Raju Jha sir. Abhay Bhai, you are coming on the stage. So panelist would be Dr. Satish Pandya, Dr. Sangeeta Yadav Madam, Dr. Abhay Shah, Dr. Rakesh Desai sir, and Dr. Basavaraj sir. Dr. Basavaraj sir, welcome. Directly from flight to the stage.
Good afternoon, friends. Now, we come to the topic of our day-to-day use. Somebody call it a bread butter. Maybe somebody call it as a cheese and jam. So let us see what it has in our panel. And I am very happy that I have a co-moderator like Dr. Manish Mehta and allied panelists, right from Dr. Abhay Shah, Dr. Basal Raja, Dr. Sangeeta Yadav, Dr. Satish Pandya, Dr. Rakesh Desai, all leading pediatricians having keen interest in the vaccinology, and some of them SCVIP members also. So it will be I hope it will be a nice discussion of day-to-day use to everybody.
Hello.
Friends, immunization and science of vaccinology is very interesting. But at the same time, it is equally fluid and dynamic with constantly changing dimensions. A pediatrician or physician needs to keep a pace with it and updating himself time again and again. Science of vaccine is not just straightforward as 2 + 2 is 4. A vaccinator needs to use his acumen, sometimes for the situation-based modulation of the schedules. Vaccine being a biological product which deals with immune system bound to have some constraints and limitations, particularly under some special circumstances like prematurity, pregnancy, immunosuppressants, transfusion with blood products, transplants, illnesses, missed or lapsed vaccination opportunities, and so on. Friends, many a time there arises a dilemma superadded with some of the controversies at the time risk of AFIs coupled with medico-legal issues nowadays in office setup for vaccination, which indeed is a challenge to the vaccinator. And hence, a benefit versus risk of vaccination has to be evaluated. In majority of the time, more than 98%, it is in favor of vaccination, but one should definitely consider benefit versus risk in such special situations. So our today's agenda will include recent SCVIP recommendations, new vaccines, difficulties and dilemmas pertaining to routine and common vaccines in our office practice, vaccination in high risk and special situations, and some of the administrative issue related to the vaccination. I would request Dr. Manish to carry on.
Thank you, Dr. Yagnesh. First of all, I thank Scientific Committee of GUJPEDICON for giving me this opportunity to be part of this immunization dialogue with such a precious panelist and moderator, Dr. Yagnesh sir. Before we start, as we all know, every year SCVIP issues some guidelines related to the immunization. And last year also in March 2020, they had a physical meeting for these SCVIP guidelines, and during September to November, they had virtual meetings, and they come up with some conclusions and they declared those guidelines. We'll go ahead with one by one vaccines for that. First is polio vaccine. So Dr. Abhay Shah sir, I would request you to say something about IPV recommendations by SCVIP during 2021.
Yeah, so as you know that today we are in the almost, I would say it's hopefully we are in the fag end of the polio eradication. But this polio eradication is not going to be achieved only we will not take care of the CVDP and VAP. Out of these, CVDPV has a potential to cause the outbreak just like wild polio. And the most common cause of this CVDP is mainly type 2 polio. Now, as we have switched from trivalent to bivalent polio, there is no protection against the type 2. And therefore, as the entire globe is moving away from the OPV, it is the IPV, IPV and IPV is the order of the day. And rightly so, our latest immunization committee, that is CVIP, has now gone for 3 doses. I'm talking of private practice. Don't mix it with the public sector. 3 doses of the IPV along with either Pentavac or now standalone IPV is available, you can give it. You have to give a booster at 1.5 years. And what has additionally been added is a 4 to 5 booster, that is IPV. This will give 100% protection against the wild polio, as well as it will protect against CVDPV. Suppose if there is affordability an issue, again ACVIP has said that you can go to the public sector, take advantage of fractional IPV disease, 2 doses of fractional IPV is more immunogenic, 1 dose of intramuscular, but never ever forget to have a booster dose at least at 4 to 5 years. So a 4 to 5 year IPV is a new recommendation. I think it should be the order of the day. We should be away from the OPV. Never ever forget birth dose of OPV. Never ever forget all Sunday immunity activity as far as OPV is concerned.
Can I add on to this, if with due permission?
Absolutely
fine. I would like to add a little evidence based on this, because we had done 2 studies of late related to IPV and the antibody status. And we found one we did on with the fractionated IPV, and we found that it does produce very good seroconversion, even the fractionated with the 2 doses. However, what takes the beating is your type 2. The type 2 levels are definitely lower even with the fractionated, and also with the single dose IM also we found, because these were the 2 limbs which they were suggested by the WHO program that, madam, why don't you do this kind of thing. Another is we did it at 2 cohorts we picked up, one at 1.5 years and the other at 4 to 6 years. So we found that the ones who are 4 to 6 years now actually have 2016 we had started the program. So these are the kids who are now 4 and 5 years. So all the more reason to reiterate the fact that the booster is required, because otherwise their type 2 levels are very low and they are likely to get CVDPV and they are not protected adequately with the waning of immunity. So I just wanted to add this to what Dr. Abesha has said.
With your permission. Since it's a panel discussion, I think we don't have that time constraint today because we started in time. I want to make a comment on this waning of immunity. Now we have realized earlier we were not giving booster of IPV. Now since it is available and we are giving it, what will happen after next 5 years? Are we worried about older children, adolescents, adults also? Another thing is we made the switch way back in April 2016. At that time, the premise was that over a period of 2-3 years, we will get rid of CDP because we are not using trivalent OPV now. So any comments from Madam or Abhibai?
So yes, the point, see, in India we use 6, 10 and 14 week schedule. So it is supposed to be less immunogenic compared to the schedule which is used by the Western world, which is 2, 4 and 6. So in the countries where schedule is 2, 4, 6 or 2 months, 4, 6 months, there the waning of the immunity takes place, and that is why the booster is required 1.5 years as well as 5 years. And the same line, the waning of the immunity is going to take place, and again there will be after 10 years now people have started giving TDAP plus IPV. So the waning of immunity is always there, but it is not always only, the coverage is also important. If the coverage is good also, I think we will have a prevention of the nasopharyngeal carriage. If we are primed with the OPV, we have prevention of we have a gut immunity, so transmission risk. So it is the coverage as well as the vaccine at a regular interval. Both are going to be important.
So you, in the future, I mean in the coming years, do you envisage that
we
all
sir.
will be taking
we
IPV?
may have a 10-year booster later on, but we will restrict 5 years booster right now because
My answer, I didn't get the answer from CDP. Why is it persistent? I mean, since we have stopped using bivalent. You said in India we have more cases of CDV type 2. So is there any reason why we are having those cases?
Abhay said that with 2 doses of intradermal, it is the protection against type 2 is not that efficient.
One about vaccine-derived polio.
You are talking about the waning immunity. I have answered.
I had asked 2 questions.
Which one? Second one?
He wants to know about CVDPV, why that has not decreased. That's what he wanted to know.
That was the premise when we made the switch.
Before the switch took place, there should have been enough IPV doses. Fortunately, we didn't have enough IPV, and that's why we have gone for the fractional dose IPV. Now, this fractional dose IPV is, mind you, is a risk mitigation. It's not 100% protection, and that is why the cases have been there.
I will resolve this IPV issue and we will come to the again because organizers reminded me the panel discussion do have a time constraint.
So final word would be 6, 10, 14 weeks IPV, 1.5 year booster and 4.5 year booster IPV, either standard or combination vaccine. So next is influenza vaccine. Dr. Rakesh Desai sir, what has been changed in influenza?
So the current change is to give full dose of influenza vaccine above the age of 6 months. That is a 0.5 ml universal dose for all the ages. That is just because initially we were using whole virion, now we are using split products. That is, it has more less reactogenicity with high immunogenicity. So the recommendation is to give the universal dose after 6 months of age.
Yeah, so previously we were worried, between 6 months to 3 years, we were worried of increased reactogenicity with 0.5 ml. So we have kept it to 0.25 ml, but now we know that reactogenicity doesn't increase much by increasing from 0.25 to 0.5, while immunogenicity increases with 0.5 ml. So it is a uniform dosing schedule of 0.5 ml at all age 6 months onwards. Now varicella vaccine, Dr. Basal sir.
Yeah, varicella vaccine, what is the latest recommendation by the ACVIP 2021 committee is, previously what we used to do is, we used to give it after the age of 1 year, that is 12 to 15 months. That is the one dose we used to give it. Second dose we used to give it at the 4 to 6 years. That is the recommendation in the past. What really is changed now is, instead of waiting for the 5 years, you can give it after the 3 to 6 months later. What is the rationale behind that? When you look at the rationale behind that, there is a breakthrough varicella. So is this breakthrough varicella, is it because of a waning of the immunity, or is it because of a primary vaccination failure? These are the two things we need to look at it. When you look at these things into the consideration, rather than waning of immunity, it is a more of a primary vaccination failure. That means if you give a vaccination early, you can prevent the breakthrough varicella in the subsequent. That is the rationale behind recommending the second dose of a varicella vaccine 3 to 6 months after the primary dose, that is between 12 to 15.
Yes. So it's basically understanding is primary and secondary vaccine failure. Primary vaccine failure, as sir said, it is lack of uptake of the vaccine. So there is no protection built up against the vaccine. And secondary vaccine failure is waning of the immunity. Previously it used to be said it is because of waning of the immunity breakthrough varicella occurs. But nowadays it is confirmed that it is more of primary vaccine failure. And in the cases of primary vaccine failure, it is always recommended to give another dose as soon as possible, preferably 3 to 6 months after the first dose. And uptake of second dose is always better than the first dose, even in primary vaccine failure. Thank you, sir. So, madam, what about quadrivalent conjugated meningococcal vaccine, newer one?
The quadrivalent conjugated meningococcal vaccine has been recommended for use with 2 doses between 9 to 23 months with a minimum interval of 3 months between the 2 doses. However, there is another brand which is available, Menview, which is 1 dose has to be given after 2 years. And the conjugate one, fortunately, can be started recommended by the age of 9 months onwards. So that is the rationality, and we have done the study and published, and it is there.
So still recommendation from IIP is in special situations only. Now, Satish Pandya sir, what about newer typhoid conjugate vaccine?
That has also been approved by ACVIP. Efficacy is good. Only thing is that it has been proved that it is non-inferior to the existing TCV which we are using, and it is just using a different conjugate than the other one. So there are no major differences between all of them. We can use any of them.
Yeah, now all those are recommended about 6 months.
Changes in the schedule. Earlier we are recommending beyond 1 year. Now 6 months onwards, up to 45 years we can give.
Thank you. So Dr. Abhay Shah sir, what about DTaP and IPV combination vaccine?
Yeah, so I think this vaccine is very important for the 4 to 5 booster dose, second one. And ACPI is already recommended for it. Previously, when the recommendation was made, that time that our standalone IPV was not available. So affordability was an issue. But since now standalone IPV is available, so those when the affordability is issue, probably one can go for the DPT vaccine available. Plus, you can give this vaccine that is a IPV standalone, or you can give this acellular poison vaccine, which is going to be a less reactogenic will IPV. So IPV, ACIP already recommended the second booster.
So basically, don't miss any opportunity to give you IPV. Whenever child comes to you has not received previous any IPV doses, whenever child comes to you, don't miss opportunity to give IPV
So
in any form.
you can give 2 doses of IPV 8 weeks apart. It will clearly more than 95% seroprotection. Yeah.
Yes, sir.
Abhay, I just want to compliment you for the new guidelines where you very emphatically emphasize that in our clinic, no child should go without IPV. There are pediatricians who give Pentavac and child doesn't get even F IPV. I mean, now that IPV full dose is available, we can use that. But we should all keep in mind that no child should remain without IPV. Yeah. It's a major, I would say, consider crime if any child under your care goes without IPV. And this has happened to a pediatrician's grandson in one of towns in Gujarat.
So if parents want to come to you for Pentavac, at least don't give Pentavac. Make them sure that you give at least 1 dose of IPV, or you don't give only Pentavac and send it to the public at least to get the fractional IPV.
And this is written in the guidebook, new guidelines.
And we are very emphatic about this. Yeah.
So one of the most hottest topic these days, newer 10-valent pneumococcal conjugate vaccine. Rakesh sir.
So this, the newer vaccine is almost, the efficacy is same as the older one, the 10-valent that is available. But now it is available in government setup, but the schedule is little bit different as compared to what we give. The main concern is that it cannot be given after 2 years of age. So the dose is 0 and 2 and booster at the age of 1.5 to 2 years. But after 2 years, it is still not approved. That is the constraint at present. Yeah, so otherwise, the efficacy is same as other 10-valent vaccine.
But ACVIP does recommend it to be used as for booster
so
also.
I think this is what I would say, it's a local product for a global coverage, I would say. Because it has very important 6A and 19A. And both are emerging strain. Now in the countries where even 6B is more common, I think 6A is going to cross-protect disease. So I think for less amount, we are having a huge coverage about 6A and 19A is concerned. 19A drug resistant and emerging, number 1. As far as schedule is concerned, yes, DCGI has 3+0. But now we have got the Gambian data where the booster dose is studied. And on that basis, we have got the 3+1 schedule is also there. But remember that this is the vaccine is to be used only till the age of 2 years. This vaccine should not be given beyond the age of 2 years. That is very, very important. And it has not been studied in immunocompromised children also. So for immunocompromised children, the choice still remains the other vaccines.
So DCGI schedule is, sir, what is DCGI schedule of this vaccine? What schedule they recommend in government pneumococcal vaccine this?
Sorry?
9 months.
Government, they follow 3+0 schedule. But it's a modification of 2+1.
2+1.
So the booster is 9 months. So it will take care of the other primary immune response where not that robust. Once booster you give, the same OPA titer will go half once you give the booster dose.
So monoclonal antibody for post-exposure prophylaxis of rabies.
Yeah, this is another recommendation by ACVIP is, see, what we used to look into it when there is a post-exposure, we used to give a rabies vaccine along with immunoglobulin is the thing. Now the monoclonal antibodies is equally effective as that of an immunoglobulin, and cost-wise it will be less as compared to that of this thing, and adverse effects is usually it will be less. That's why we need to give along with as quickly, as early as possible. We need to go within 7 days. We need to give the monoclonal antibodies along with the rabies vaccine. One of the things as far as the rabies vaccination is concerned, as such we know that there is no adverse effect 0, 3, 7 and 14 to 28. That means 4 dose should be good enough for a post-exposure prophylaxis. For pre-exposure it is 0 and 7. And suppose if there is more than 3 months after the vaccination, if there is a thing, 0, 3 is the schedule. But important thing is we need to give an monoclonal antibody, whether it is a rabies shade or a twin rab. These are the 2 things which are available. We need to give the monoclonal antibody for that.
Yes, so basically if child has any time received this post-exposure or pre-exposure prophylaxis, they won't need antibodies in their further bites. One thing. Second thing, it is always local infiltration, never in peripheral intramuscular. So it used to be locally only. And serum rabies shield is available in 2 strengths right now, 50 and 100. And dose is 3.3 unit per kg. And that is on any weight, like with 60 kilo, 70 kilo, it is 3.3 unit per kg. There is no fixed dose for that. And I think twin rabies 40 unit per kilo.
That's correct. So we use in a 3.3.
Yes. Now I hand over session to Dr. Yagnesh sir for further.
Friends, now we come to the second session of newer vaccine. And the hot topic among that newer vaccine is definitely a corona vaccine. In March 16, 2020, the first experimental shot was given in US with the use of this corona vaccine. And December 11, 2020, the FDA granted emergency use for Pfizer as well as BioNTech corona vaccine. And thereafter, there were multiple n number of varieties of corona vaccines which have started experimental trials. Some of them are already in the market. But when we talk of in India, we have a vaccination drive which started in a phased manner from 16th of January 2021 with the two vaccines, namely Covishield as well as the Covaxin vaccine. And friends, I'm happy to inform you these statistics as on the last updated information of the vaccination status in India. Look at the budget of India with regards to the corona vaccine alone. It is 35,000 crores just for the 1 year. So India has done immensely well, and first dose and the second dose coverage, look at it, we have more than 60-70% coverage as far as the first dose is concerned. Thanks to the efforts of the health workers who have taken the vaccination to such a great height. And now the vaccination passport is the need of the day. We are required to print the vaccination certificates on our t-shirts so that we can display even while entering the hospital and getting the accommodation, we require vaccination certificates. So one would advise that print it that on your t-shirt and wear it so that everybody can have a look at it and you do not have to do the formalities. Now, few of the queries as far as the corona vaccine is concerned. Dr. Sangeeta madam, you will take it. Second dose with a different vaccine than the first dose. Whether it is advisable? What is your take?
The thing is that they say that if you can get your second or third dose with the same vaccine which you have received for the first dose, enough data is actually not available. So it's very difficult to make recommendations. And so again, it is definitely said that maybe a mix and match schedule is better off.
But for
related to this.
For our purpose, when two vaccines are available, it is better to have a vaccine with the same vaccine as far as the government orders are concerned.
There are, lot of studies which are being quoted as far as this business of mix and match is concerned. And different countries use their own different schedules. Like my close relatives who have traveled to USA or Belgium for study, they have been given 2 more doses of mRNA vaccine in spite of having taken 2 Covaxin or Covishield. In certain countries, they are talking about even 4th dose also. Some of the countries have also started with 3rd dose. So I think there is a lot of confusion amongst all of us as to what is right and what is wrong. So we all take it as and when it comes. We are all waiting for our booster. That is also not being given.
That is why I always say, as on today. Maybe tomorrow recommendation may change, but what is the recommendation as on today for India?
At a personal level, if I get an mRNA, I will take an mRNA booster rather than a Covishield booster today.
Okay. Anybody
Some
else?
studies say that once you have taken mRNA vaccine, and if you take the second dose as AstraZeneca, there is rise of 4-fold rise in immune level as compared to the same vaccines 2 days.
These are all not confirmed studies. They are under study. Not official recommendation.
Yeah, coming to the COVID vaccine things, whatever Satish Pandya sir and Rashmi sir, Rakesh sir both told, it's absolutely agree with the literature wise is concerned. But what we need to do at this present time is, we need to follow the Government of India guidelines where we cannot have our own policy. Yes, we can have our own knowledge. That's a different, but as comes to the things, we need to look into stick to the particular brand as per the Government of India recommendation till the further direction comes.
Yeah.
Pandya sir, yeah.
I want to make a comment here that as a professional body which has a lot of say in certain government policies, I think we must praise for vaccination for children. I do not know why government is delaying it so much.
We will come to it. Let us finish up this part first. We will come to the vaccination.
I think that
Now, when you have already taken 2 vaccine shots way back in January, February, at 1 month interval, because initially healthcare workers and many of us has taken the first dose on the 16th of January itself, second dose in February. So 1 month interval. Now it is almost 12 months, almost. So what is your say on the booster dose? As far as now we are talking about
I have
India.
been demanding it for many months now. Since I finished 6 months, I have been demanding.
You are demanding
various
it.
groups.
So you
I'll
want that
always go
booster
for a
dose.
third dose with this Omicron
So
coming
everybody
up.
agrees to it. We want a booster dose.
Yes, I think all of us would take booster dose. Why not? Yeah, Raju bhai, you'll have to wait for MRA.
Give with the other vaccine which is available.
Sahib ne mic up on. So you'll go for Sputnik, Raju bhai?
Take this, take this.
Yeah, if you have taken vector-borne vaccine, if you have taken 2 doses, it is not advisable to go for a third vaccine of a same vector-borne disease because there are going to be antibodies against those vectors. So adenovirus vector, Covishield, which is used, if you have taken 2 doses, then you are enough antibodies. When you take a third dose, the adenovirus will be killed. Along with that, whatever fragment of the corona is there, which also will be killed. So boosting effect will not be there as much as it is required. So those who have taken vector-borne vaccines, they should not take that, and it is better to take the other vaccine or Covishield. There are now some studies which have shown that if you take after about 10 months or so, then the effect is still there, but enough boosting effect may not be there. And that is why there is a caveat that those who have taken vector-borne vaccines, please take other vaccine rather than. mRNA vaccine will be the best as a booster when you have taken these 2. But if mRNA is not available, then I would say that you take other vaccine than the vector-borne vaccine.
Yeah, anything?
I'm raising my hand since long. Yeah. Anyway, see, there was the need of the booster. So now we have 2 doses and almost 1 year has been left. So most of the studies that I saw that the antibody has persisted till 8 months, 10 months or 12 months, and that is a B cell function. There have been studied that T cell immune response is also elicited, but it has not been measured. So looking at the disease transmission, none of the vaccine which is available are mucosal vaccine. So we are not going to prevent the transmission. With this vaccine, we are going to prevent only a serious disease and the hospital-related disease and the mortality, number 3. And if you look at any vaccine, only primary series, 1 or 2 doses, whatever the primary schedule with the vaccine, it is nearly in the tune of effective symptomatologically from 66 to 70%, and for the severe disease from 95 to nearly 98%. Now, on the top now, is there a node of the booster? Yes, it is there. If you take the advantage of example of Sputnik, there are 2 different adenovirus, what Dr. Raju is saying. So similarly, if you have a primary series vector-borne, then there is no point in taking the same. You have to change so whenever the booster is taken with the heterologous antigen, the immune response is going to be robust. So if chance is there, I will go for the Pfizer if I have taken a Covishield. So that is the answer.
So that is what is suggested, mix and match. But the time will tell whether we require a booster, with 1 dose, whether we require, because some of the countries have already started thinking of second booster. When we are talking of the first booster right now.
Yeah, Israel is going for
Israel has already started with the second booster. They implemented it, not only thinking of it, they already implemented it. But it has to be a mixed match schedule. But they started. For a high-risk individual like immunocompromised, they had started, but not for all.
Immunocompromised is a different story because immunocompromised are not giving enough immune response. Similarly, adults, more than 60 or 65 years, they are called immunosense. So those also needs extra booster. So these are the different situation. But otherwise, other people less than 60 or less than 65 do not require fourth booster. One booster should be sufficient.
But on top of it is the Omicron. Does the mutation of coronavirus affect the capacity of vaccine to prevent disease? Anybody? Dr. Rakesh Bhai?
Most probably no, because it's a genetic mutation, and most of the mutations are single gene mutations, and most of it constitutes about very small part of SAS protein, and most of the vaccines they utilize many epitopes of S protein. So even there are few mutations, this is not going to affect the ultimate immunity as far as vaccine is concerned.
So small mutations, definitely vaccine will be efficacious, but if it is a large mutation, we might end up in a problem, but only time will tell.
Can I add here?
Omicron is probably evading the immunity. And if you see, they read the reports from England and USA, almost 40% of those who have suffered from Omicron had received two or three doses.
So that is a large,
it is definitely
multiple
evading.
mutations.
So that's a different type of organism. And there is another B-type mutation now recognized that is completely evading the immune response. So, I mean, immunity in the adult. So it's going to be a big issue. But we'll have to wait and see how they are responsive.
No, I was telling the same thing.
Same, yeah. Now coming to your question, Dr. Satish Bhai, whether we need a vaccine in children.
I don't think pediatricians need to be told about that, why we need to have vaccines for children.
Not for an individual private practice, I am talking of...
No, definitely. I mean, we have been avoiding this age group for a pretty long time now. It's high time that we start protecting these children, because it was said that, okay, they have a mild illness, they don't have very severe illness. But in fact, they can also become carriers also. So we need to protect children now. So there is no doubt why we should not have any vaccine for children. We must go for it. Yeah.
Anybody having contrary view? Anybody tells that it is not required?
No, as far as the Satish Pandey sir is concerned, whatever sir said is absolutely right. Indian Academy of Pediatrics Advisory Committee as well as official stand, we have written it already 2 to 3 times to the Government of India. But thing is that as an IAP, we can play an advocacy role. Ultimately, Government of India has to look into the logistics. Logistics of is the sufficient vaccination supplies available, that is one thing. 2, they need to look at the manpower which is required to roll it out. Because once we start rolling out, almost around 40 crores of a population which is less than 18 years into 2, and financial cost, manpower, all those things comes into the play. But now they have taken it in a one step. Yes, they have already advocated it for the children's at risk. That's what Indian Academy of Pediatrics is also in the first phase. We are looked into that. Abhay sir can add further if they say.
Yeah, so definitely it's a need of an hour. And why I'm telling you? Because if you look at the cohort, nearly 1/3 of the global population is from this age group. Now, as the disease has become milder and milder, probably we are hoping that we might end the pandemic and we come to an endemic situation. Now, if we want to sustain this endemicity, we have to break the transmission chain. And only way to break the transmission chain is the higher coverage. Now, if 1/3 of the cohort is not vaccinated, then how can we going to break this? Number one. Second, even if the disease is mild, even if the children are asymptomatic, but they can transmit this to adults as well, to their staff, to their college folks. So I think to sustain the endemicity is very, very important, and that is why vaccination for the children is required.
And the best part is the Indian Academy of Pediatrics has taken out the recommendations and guidelines and very nicely elaborated it.
Yeah, we have
and obviously we cannot cover it up, but I would really like to refer that each one of us, because it is the need of the hour and the time which is important. So we should all go through these guidelines so that we are very clear as to what we have to explain to the parents when they come to us, and especially if we have to roll out the program into the lower age group, like we had done for MR, so that we do not face issues related to that, and we are on a smoother platform to get the whole thing running.
Yeah.
That's what is also important.
And secondly, we will use lot of non-pharmaceutical devices like wearing the mask. Now in the school there are a number of activities where mask is not going to be there. And we don't know that whether this mask protects against Delta variant or not. No studies have been carried out. It has been done only with the previous strains. With, whether this masking helps in prevention of Delta variant, there are no studies available. So during the recess time, during the lunch period, during the sports activity, you are not going to wear mask. And that is why this vaccination of the children is very, very important.
The paradoxical thing with vaccine hesitancy is that in children there is no vaccine hesitancy. I mean, from our experience, we'll all agree that parents are demanding that, sir, kyare aavse aa vaccine. It's the government hesitancy which is creating problem.
I would not agree with the fact that it is government's hesitancy. It's not government's hesitancy. The government has to, when it has to lay down the policy, it is going to take a lot of things into account.
Yeah, it is logistic issues which definitely, yeah.
See,
yeah,
the logistics, the feasibility. See, we have done the MR program, and you all know state-wise there were issues related to that. So it is never it is not the government's hesitancy.
Right.
It is
Basically,
yes. we have to actually put the things together as to how we have to roll it down.
So there are few vaccines which has been already approved for use in children in other countries, depending upon their age, and the volume of the vaccine is also different in different ages. We will not go in detail of it because of want of time. Yeah. So assuring vaccine safety in children is critical. And remember, friends, no one is safe until everyone is safe. So promote vaccine and have a vaccines not only for yourself but also for your family members. Now we will go to the next part of the presentation, some of the common vaccines in different situations. We will start with the case scenario. 4-month-old infant comes to your clinic for not having BCG scar. Dr. Rakesh Bhai, what is your approach?
Around 10% of children do not have scar even after giving effective vaccination. So if there is no scar, nothing to worry about it, because there is not considered a failure of immunization. And majority will have positive skin reaction to leukocyte migration inhibition. The only thing, when many times actually the vaccine is not given, when we are not sure whether vaccine is given or not given, even if you give second dose, if there is no scar after 3 months, I think there is no harm at all. But ideally it is not required. But if you can give, if you want to give, you can give after 3 months.
Yeah. But
not the answer is that there is no need to give, right? The clear answer is there is no need to repeat it. No, why do we want to give? If there is documentation, then we should not give, no?
No, if there is a documentation.
If document is there, we should not. But if you are not sure whether it is given or not given properly, then you have to give second dose.
Yeah. Yeah, next question. An NRI family is going to now settle in Surat. Parents inquire for the BCG vaccination, which has not been taken in their country, for 9-month-old and 5-year-old children. What will you do, Dr. Basal?
See, when India is an endemic country, yes, we need to give a vaccination for less than 5 years. That's the standard recommendation. There's another way to look at that. You look at the Monto test. Monto test is positive, then we can differ it. But ideally is give a vaccination in less than 5 years. They are planning to settle.
But there is definitely no need to do a Monto test.
No need to do.
And suppose those are the visitors to India for 2 to 3 months. They are not going to reside permanently in India. What is now status? Same, or you want to change your status?
No, just if they are visiting just for 2 to 3 months of a time, really it is not.
They don't need it. Everybody agree?
Yes, I would like to give.
If they are frequent visitors, even if the interval is short, I think we should give it.
Frequent visitors, only single visit you need
once
not
in a
do for
okay,
a couple of months? Fine, otherwise you can give. Yeah, next question. A 3-month-old girl child presented with swelling in left axilla, progressively increasing There is no constitutional symptoms. This is the picture of the child. Dr. Madam, you will take? How will you manage?
Definitely, we have to see whether this is BCG lymphadenitis or is it an abscess. So that is one thing which we have to see, because
if it would have been an abscess, the child would have constitutional symptoms. Fever would have been there.
So these children, even if we do FNAC, we are going to find some bacilli, because after all we have given BCG. So ATT is not recommended for these children, and this happens generally due to the change of the manufacturer something, or some programmatic error is there. So we do come across these clusters of, in AEFI, we do come across these clusters of BCG lymphadenitis.
Yeah. So these nodes will regress spontaneously, usually within 4 to 6 months. Usually you do not require FNAC also. However, if it liquefies and forms an abscess, if you do an FNAC, you will definitely find an bovine type of vaccine bacilli which do not require antituberculous treatment, and in extreme of cases, maximum you require is the removal of that pus.
I think the NTP guideline which we have, I think the answer is very clear. If it's a firm swelling, don't do anything, wait, it will resolve. In the process, if it liquefies, if there is a small collection, you do aspirate. If it's a large collection, you drain it. I mean, very simple. You don't have to do any FNAC or anything.
Now, Satish bhai, there was now BCG accident. A staff nurse gave BCG accidentally in thigh as an IM injection rather than an intradermal. What will be the consequences? And how
Fortunately, it has not happened so far in my practice.
But that is why I written not your staff,
so
staff.
If it happens, there will be a local reaction, there will maybe abscess formation, there may be adenitis also. So you have to take care of that. And because it was given intramuscularly, I think it should be repeated intradermally after, say, a couple of months or 3 months.
Any other?
Nothing is. I think we have to first.
That is okay. Repetition of BCG, whether we should repeat or whether we should.
No, I think even if the BCG subfield is going to work, only reactor is the issue. So I would not repeat here BCG.
Does not matter. It will still
There will be issue of reactogenicity. There is no issue of immunogenicity.
So immunogenicity is definitely there.
No
Previous recommendation was to repeat the BCG after 1 month. Right now, the new recommendation is you do not require to repeat it. That has done enough immunologically. Now, in another situation, a child has been vaccinated with birth dose of OPV, BCG, and hepatitis B. He has also received pentavalent vaccine on 10th of March 2020, before COVID crisis started. After that, because of COVID, no more vaccination has been taken. Now he is almost 23 months and has landed up in your clinic. What will be your approach? You want to read? Yeah, please.
Now this child has received only 1 dose at 6 weeks, and after that he has not received.
No dose.
So now he's 23 months old, so he has missed out on all the completion of the schedule. So what we will do is we'll give the penta 2 doses, like 4 weeks apart, so that we complete that schedule along with the penta, along with the
and thereafter all the
OPV
vaccines
and IPV,
which has been missed.
and after that we continue with the
No need
so
to
this
repeat
is missed opportunity, and we continue with the schedule.
Yeah, and no need to repeat the 1.5 month dose.
Yes.
But important here is not to miss IPV. So you give 2 doses of IPV 8 weeks apart, because now standalone IPV is available. So if you're not going to combine with DPT, means DPT or DPAT containing vaccine, then do not ever forget to give IPV. That is the most important. IPV 2 doses 8 weeks apart.
So
and of course, then you need to go booster and all things. But to complete this primary series, I'm answering this.
So the message goes from the stage once again, IPV, 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 ever since 2000.
Yeah, definitely, yes. No issue, but you should give. Another situation, if mother is HBsAg positive, what should be the most appropriate schedule as far as the hepatitis B vaccination is concerned, whether it is hepatitis B immunoglobulin within 12 hours of birth plus 3 more doses of hepatitis B vaccine at 1, 2 and 6 months, or hepatitis B immunoglobulin within 48 hours with first dose of vaccine and additionally 3 more doses, or hepatitis B within 12 hours of birth with vaccination plus 3 more doses of hepatitis B. Satish bhai.
Yagnesh bhai, it depends on whether the child was less than 2 kg or more than 2 kg. Essentially, the answer will be this last one that you have to give HBIG within 12 hours. You have to give the birth dose of vaccine. And if it is a full-term baby, I don't think the last option is the correct one because it has written 3 more doses of hepatitis. Only 2 doses should be sufficient. Here we can count the birth dose. But had it been a low birth weight baby, less than 2 kg, if you are giving, then 1 more dose is okay.
Agree.
Otherwise, the last one is fine.
Now, if hepatitis B immunoglobulins are not available, what will be the best schedule?
Then you give 4 doses schedule.
Okay. Now, protective efficacy, Rakesh bhai? With the use of both.
It would be around 90 to 95%.
And if hepatitis B immunoglobulins are not given, only vaccines are given?
That will be less, it around 70-75%.
Yeah.
So, message is not that bad. Means hepatitis B immunoglobulin is not available, not feasible. Cost is an issue. Just go for the 4th additional hepatitis B. It will take care of your thousands of rupees. Few hundreds will take care of the thousands of rupees and baby will be saved in the tune of 75-85% as far as the perinatal and the horizontal transmission of hepatitis B is concerned.
Should one check a seroconversion?
Yeah, ideally, especially this type of a patient, we need to do the checking. Preferably, you can do it around the age of 1 year. That is the time where you can do those things.
Yeah. What is the importance of birth dose of hepatitis B vaccine? Do we recommend it? Or if we give it 36 hours, maybe 48 hours, what is harm?
Actually, it is there to prevent the vertical transmission. And so it is important that we give it as a birth dose, but the birth dose does not mean actually just then. It can be given within 12 to 24 hours preferably. And if the thing is mother status
should be
is not,
given as early
not
as possible.
Available. So that is why
you want to add anything?
Because as a moderator, I have been asking this question in all the immunization dialogue, that this message should go to pediatricians because I have seen so many infants who are not given the birth dose. And if it is left out, then they give at the 1.5 months only. But the importance is that birth dose importance is not only to prevent vertical transmission, but also postpartum horizontal transmission also. It contributes a significant chunk to the chronic liver disease. Yeah. So the message is that if you have missed that birth, give it as early as possible. Don't delay it till 1.5 months.
Yeah. So it's two different. Timely birth dose. Timely birth dose means within 24 hours. I repeat, it is within 24 hours. It will take care of the vertical transmission. At the same time, it will give protection against the horizontal transmission because in India we have a lot of skin infection, eczema, so a lot of horizontal transmission taking place in the family as well. So if you give a birth dose, it will prevent vertical as well as the horizontal transmission.
Yeah. And what are the precautions that you are needed in immunocompromised children as far as the hepatitis B vaccination is concerned?
Yeah, so usually for hepatitis B and of course for hepatitis A, we don't go any boosters. The only exception is the immunocompromised child. Children who are on chronic hemodialysis. These are two important. And third one, children who has got a chronic liver disease, where the seroconversion is not that great. And these are situations where boosters are required.
So what are the methods? How do
so you can double the dose, and instead of 3 doses, you can go 4 doses. So instead of pediatric dose, you can give an adult dose.
I'll just add a little to it because one of our studies is published related to CKD and nephrotic syndrome. We did this study and we found definitely the levels for hepatitis B because it has been there in existence in our schedule for so many years. Definitely the levels are low, but by and large they are still seroprotected, though they do wane off. And I've just submitted that research work related amongst our type 1 diabetics also. And they are protected. The only thing is that there is waning of immunity.
And you should, at the end, you should confirm the seroconversion.
Yeah.
Another question with regards to hepatitis B. An 15-year-old male got an accidental prick with needle used by the father for insulin injection. The father is HBsAg positive. The boy has received all 3 doses of hepatitis B vaccine during his infancy. Seroconversion has not been documented. This is routine situation. What should be now your action? Rakesh bhai.
Ideally,
3 doses are being given.
You should check for anti-HBs antibody status of the patient. If he's not immunized, then give the HBIg and booster. If he is already protected, there is no need to give anything.
Now anti-HBsAg status has been checked, it is undetected.
So in that case, you have to give HBI.
Yeah, Yogesh bhai, the message should be there, yes, you put it fine.
Yeah. Now we switch the...
But you will read out the slide. I want to put this message across that in any such situation, 3 things should be considered. The source, whether it is HBs positive or not, and the recipient, whether it is vaccinated or not, and whether its sero protection level is known to us.
Now there are 2 different situations. In first situation, 12-year-old girl has been given HPV vaccine. 1 minute later, complains of giddiness, starts sweating and falls down. In another situation, a 5-year-old boy has been administered MMR and the varicella vaccine. 5 minutes later, he develops some rashes, starts sweating and becomes breathless. Madam, is there... sorry, if you want to read? Sorry.
Actually, no, I think he pointed towards me because I've been very active about AEFI, both at state level, national level, and everything. So a 12-year girl who is presented with following the HPV vaccine is definitely an anxiety reaction, and that's very clear. And it will come in that A type of anxiety. And the 5-year-old boy who's received MMR and varicella is actually an anaphylaxis. So both of them, that one is actually reassurance that girl has to be reassured, and the parents also, and just keep them under observation for a little while. That's what is required, so as to allay everybody's anxiety. And the one which is the anaphylaxis, we have to give 0.01 subcutaneous ADR, and these children need to be hospitalized and admitted, and fluids and all need to be given.
Yeah. What Madam has said, I totally agree with that. Only one thing what we need to remember is, older children, the moment the child sees the syringe, they will immediately faint. That goes more in favor of possibility of syncopal attack. That's the one thing, especially it's more common following an HPV vaccination and all. That is the thing we need to remember. Within a few minutes, it will happen. Whereas in the case of an anaphylaxis, things need to be remembered is, there will be the skin and mucosal involvement is one of the typical feature where they can have a mucosal congestion or a rashes or GI manifestation. These things will be there. And apart from that, when it comes to the treatment is concerned, Madam said is adrenaline. Yes, it is adrenaline. We need to keep adrenaline, which is a short expiry. We need to check it. It is an intramuscular of 0.01 milligram per kg of intramuscular adrenaline is the...
So I'll just add on 2 things. If it is a single episode, then that girl is vasovagal. But if there is clustering, again, it can be anxiety. So that also we observe. And definitely, adrenaline has to be kept in each and every place wherever the immunization is being done. So in inverted commas, that's what it is.
Yeah. Anybody want to add anything?
Yeah, majority of the pediatricians, what they try to do it, they'll try to give an antihistamics and steroids as a thing. That adrenaline is the drug object. Satish.
I just wanted to say that message what Madam said is that every facility should have this resuscitation facility, and the staff should be trained for it. Just keeping there is not important. It's important for the staff to know how to resuscitate.
Yeah, definitely. Because of want of time, I would skip some of the other cases. But remember, friends, there are many special situations But don't worry, call for an assistance. Have your vaccine gurus, maybe from the audience or maybe of the audience, but have your vaccine gurus, call them in emergencies. So don't worry, be happy, don't wait, vaccinate. Thank you.
So it's been a very interesting and interactive discussion. Thank you, sir. I would like to invite Dr. Indira Parbar Madam to felicitate Dr. Manish Mehta sir and Dr. Yagnesh sir. And along that, I would like to invite Dr. Darshan sir and Dr. Hitesh Jariwala to felicitate our panelists.
Friends, it was a great vaccination session. We learned a lot of new things, including COVID and AEFI. After 15-20 minutes, we'll have an inaugural ceremony. High tea is ready upstairs. Please go, get freshen up, and after 15 minutes, maybe around 5:15, we are going to start the inaugural function. And we need to look how Dr. Rakesh Desai and his team is going to perform. So all are invited for inaugural function at 5:15 in the same hall.